है यहाँ पे? किधर है देखिए? कौन है किशोर यहाँ पे? किशोर कौन है?
ये जूम में लॉगिन कर लो।
इसमें
करो उसमें। तुम लॉगिन हो जाओ, मैं इसको एडमिन बनाया था।
9 o'clock पर she will be waiting, huh? बिल मारो बोले ना, हाँ ठीक है, मर गया।
Hello.
Yeah, from here, down, can we get it onto our today's?
Yes.
Hmm?
पूरा
Hmm. अपना शायद का श्रीनिवास का फोल्डर है।
इसको हेडिंग क्या देना है सर, टॉपिक?
टावर लाइव इन बॉक्स वही है जो रहने दो।
हाँ ये है ना,
वो हो गया पेस्ट,
एक
प्ले करते क्या देखें।
सोर्स फॉर्मेटिंग करता हूँ
ठीक है, अभी
तो सेव करता हूँ पहले।
सेव करके उसका विंडो ओपन ही रहेगा,
हाँ,
फिर उसमें वो सर्च करना पड़ेगा।
टावर लाइव इन बॉक्स ओके ना, 24 अगस्त।
हो गया, 24 में आ गया।
यस,
रूम प्ले हो रहा है क्या देखें। चलने दो, चलने दो। चलो, हाँ ठीक है, चल रहा है। हाँ जाओ जाओ जाओ, ठीक, पहले प्ले हो रहा हो।
हाँ पूरा
ठीक है, बस फाइन। तो ये हो गया की नोट का एक, लाइव इन बॉक्स का एक।
वो हम चेक करते हैं सर,
की नोट में इसमें कॉपी इसका ले लो,
ठीक।
नहीं तो मेरा लैपटॉप दे दो।
हाँ चलो,
मेरे को बस बता देना कंसोल पे कौन सा कॉपी करके रखना है।
ठीक है, वो बाद में बताता हूँ आपको।
अच्छा,
ऑपरेशन
से।
तो ये इनका आता है।
ओके, ये सब ठीक है।
ये तो चल रहा है, मैंने 24 वाला जो फोल्डर है ना उसमें डाल दी।
Not only is a young, beautiful, dynamic cardiologist, but she's a cardiologist of high repute. She's the director of cardiorenal program at Columbia University New York Presbyterian Hospital, New York. Areas of expertise as shown there: adult cardiology, angioplasty, PTCA, and she has special interest in doing seeing CKD patients and coronary artery disease. She also shows a lot of interest in you. Did work with her, request her. This time today, can you guess what is the time? It will be almost midnight there, but still she agreed to spare her time for us, and hope you can connect us to Mega Prasad Madam on Zoom. Hello.
Hello, can you hear me?
Yeah, madam. Morning to us, and full hall. We are waiting to hear to you. And then thanks for your time, and I'm extremely Sorry to also disturb you in the night, but that's how the day-night schedule comes. And then we have special personal congratulations to you on your new achievement. And at the same time, we are very thankful to you in spite of all your tough problems. Still, you gave time to us. And this is the fellows course which we run. This is the third year we are doing it. And last year also we had the opportunity to have you. And we request you to present. We have two talks as presented, as informed to you prior, both on CTOs. I think you can, if you're ready, we can go on. Hall is full. I think we are eagerly waiting to hear you, madam, because it's Zoom. We'll sit in front and, along with other delegates, and we'll interact once your talk is done. I think with this, I hand over it to you, and the stage is yours, madam. Over to you. Thank you.
Perfect. Thank you so much, and thank you for having me again. This is always an honor, and I'm glad it worked out. Initially, I wasn't able to respond, and I, due to God's grace, delivered the baby last week, and so I'm very, very lucky to be with all of you today. I've actually merged both of the topics, and sort of in this one talk, it's going to be sort of a large overview of CTOs and the chip field in general. And please feel free to stop me as any questions arise. My goal today is really to discuss the chip premise, to define a CTO, to review some of the rationale that we have to treat CTOs and some of the key relevant data that we must keep in mind, and lastly, to describe techniques to treat CTOs. But overall, as we do this, sort of the big message through my talk is very simple. It's that we can do a lot with our hands now, and the technology that industry has provided to us with better wires, better techniques, better intravascular imaging, better gear that allow us to get through a CTO. But at every step of the way, just because we can cross a lesion, we always have to ask ourselves, should we cross the lesion? What is the benefit to the patient? And how can we optimize the outcomes of the patient without increasing risk to the patients? And so it's especially important in CTO PCI, which has a high complication rate. But if we do this correctly, it can be done with a very low complication rate. So we've come a long ways from Jeff Hartzler and his primary angioplasty back in 1979. And, in that amount of time, we're now able to do a significant amount of things in the cath lab without relying on our surgeons. And in the US, we've seen our CABG volumes continue to go down because of what all is being done in the cath lab. And data now supports that many of the things that we're doing in the cath lab do, in fact, rival the outcomes that surgery can in certain cases. But of course, there's patients that we continue to send to surgeons. But it has allowed patients greater options because of what we can do in the cath lab. But there remains a subset of patients, these CHIP patients, who are complex, high risk, interventional or indicated procedures or patients. And these CHIP patients who are complex, higher risk, and have an inherent increased risk of complications, we need to think even more closely about whether they should go to PCI or CABG. And when they go to PCI, how can we optimize their options? This was a paper written by many of my mentors, Dr. Kirtane, Dr. Leon, Dr. Moses, Dr. Lombardi, Dr. Parikh, and Dr. Stone, all of whom put their heads together and said the treatment of higher risk patients with an indication for revascularization is an area that needs to be further developed, and that there's a large underserved patient population that can really benefit from revascularization. And we need to start focusing on these higher risk patients that have a high prevalence of coronary disease, and a need for comprehensive specialists is there that are trained to treat these patients. So those specialists need to have technical and cognitive skills that allow them to be able to treat high-risk complex patients. As you've seen probably in your labs in India, as we've seen here, that we no longer see sort of the type A lesion as commonly, the patient that just has a little bit of coronary disease, a soft plaque lesion. We're starting to see more calcified disease, more CTOs, more low EF patients. We know that when a surgeon turns a patient down and deems a patient ineligible, that patient's survival goes down significantly. And so with that decreased survival is sort of a lifetime sentence of knowing that they cannot be revascularized. in medical management is what we often say in the guidelines, but what we forget is that patients rarely improve with additional calcium channel blockers, ranolazine, and often are not able to tolerate significant increases in medications. And so they often do need the cardiac cath lab, and beta blockers, calcium channel blockers, and ranolazine don't suffice. And our current guidelines actually put revascularization all the way on the bottom, which we're working on changing. As patients take beta blockers, nitrates, calcium channel blockers, and ranolazine, you can see that from a data standpoint, there's very little benefit from these drugs. And then, but we prescribe them regardless. And from a patient standpoint, there's significant hypotension, cost associated with it. And then, of course, sluggishness and fatigue, which makes them, it makes it difficult for them to tolerate these medicines, as opposed to if we're able to open these lesions, this can be helpful. As the population ages, we continue to see an increased prevalence of calcified lesions and type C lesions in the cath lab, making it all the important that our skill set, especially as we come out of fellowship, keeps up with the complexity of the patients that we see. When we think about the CHIP population, these are patient comorbidities that we think about, the complexity of the anatomy itself, and then the hemodynamics of the patient. So when you think about complexity, you're thinking about, is this a CTO? Is it a left main bifurcation? Is it a calcified lesion? Is it an SVG, like a vein graft with significant thrombus burden? Is there significant tortuosity that's going to make it difficult for you to deliver your equipment? And as fellows, I would encourage you to study the films as much as possible before you go into a case, because you'll then be able to in your mind think, if this, then this, if this, then this, and have a roadmap for what happens if you fail your initial plan. So plan A, plan B, plan C for every case. Hemodynamics are important to understand. Obviously, you want to know the EF of every patient before they go in, but understand that if they have a low EF, a right heart catheterization can be very helpful to try and understand what are the hemodynamics in that particular patient. Do you need a support device? If you need a support device, how can you justify the support device? And B, can you get away without a support device? And sometimes oftentimes what I do is I try to do the cases without a support device for cost reasons and for patient complexity reasons. And so if you do the right heart catheterization, you can always take the patient off the table, optimize their hemodynamics with adequate diuresis or dialysis, depending on if the patient is dialysis dependent, and then bring them back for procedures. And we've avoided the need for mechanical circulatory support in many patients like that. The main thing to remember is this is, courtesy my mentor, Dr. Karmpaliotis, who's with us no more, but he always used to say the indications for the case does not change because the lesion is harder to treat. So we have to still do a risk-benefit analysis and understand whether the risks are worth it, but this can be modified with appropriate training, the correct technical advances, and appropriate devices and equipment. So if it's a lesion you would treat when it's 70%, even at 100%, it deserves consideration. Whether or not you treat it is different, but it deserves consideration. So what is a CTO? A CTO is a complete coronary artery blockage, but TIMI flow of 0 for longer than 3 months. And what you'll see here is that, back in 2012, they looked at the treatment of patients with CTOs, and you can see that 18.4% of patients overall were thought to have CTOs, with the attempt of CTO PCIs being less than 10% back in 2012. This number has gone up significantly, and now many CTOs are attempted, especially in symptomatic patients. Histopathologically, we see organized thrombus, fibrotic plaque, and a proximal or distal fibrous plaque with a cap with some microchannel in the occlusion segment. And that is a microchannel that angiographically we sometimes look for. Often you're not able to see it, but what you're sort of probing for with your wire. And if you can are able to navigate the cap and get into the microchannel, then your chances of success go up. There's a lot of data that supports the treatment of CTO-PCI, but there is some data that does not support CTO-PCI. And we'll briefly go through this because I want to focus more on showing you some cases and more on techniques. But really the reasons to consider CTO-PCI is to improve angina, to improve ventricular function, to reduce the need for late CABG. So if you treat a patient earlier, the chances that they accumulate so much disease and need CABG later goes down based on the data. It also improves event-free survival in certain small trials, but the larger trials have not shown that. It increases the tolerance of future cardiovascular events. So imagine if I had an RCA CTO, I would like that to be fixed potentially, because if I come in now with an LAD STEMI in the setting of an RCA CTO, I'm going to be much sicker than if I just had an LAD STEMI with a fixed RCA CTO. So that has become the rationale for us to fix many CTOs that previously we did not, because we noticed that when patients were coming in with a medically managed CTO and then a non-CTO vessel STEMI, those patients were getting sick very quickly, often to the point of no recovery because of severe cardiogenic shock. And lastly, to achieve complete revascularization, which has been shown time and time again in multiple trials to be associated with improved mortality. But like we know, when we consider CTO-PCI, we still have to think about the risks versus the benefits and think about how we can mitigate those risks as we go through with the procedure. Thinking about CTO-PCI from that standpoint is fair, but it's important to dispel myths that are often there. And the first myth is that collaterals are good enough. So the number of times I hear it's a well-collateralized RCA, the LAD is supplying adequate territory, it's not ischemic. But when we look at the studies, even the best of collaterals, still ischemia exists in the territory of the CTO, and that ischemia is enough to cause long-term deterioration of LV function as well as symptoms. Oftentimes we say complications aren't worth the risk, but this is important to consider because depending on the operator and depending on the equipment, you can reduce the risk of complications. Often they ask, will they really feel better? Will the EF really improve? We have ample data that shows that they will feel better and the EF will improve in the majority of cases. And then lastly, the big question, and this is a valid one, is if there's no improvement in mortality across all the trials, what's the point? And that is a very valid question, but we also know that when we fix a 70% mid-LAD lesion, there's very little data to support improvement in mortality in those patients as well. But we still fix them because we think of it as a lower risk intervention as opposed to CTO-PCI. And so by the same token that we fix a mid-LAD 70%, the thought process in our cath lab and across the US has become we should at least try in the appropriate patient that is symptomatic. This was a study looking at patients with collaterals, and you can see that despite having good collaterals, these patients continue to be ischemic with the ischemic threshold at 0.8. But complications will happen, and this is a case that I was asked to help the operator that was performing, and it was a simple type C lesion. It was a calcified mid-LAD lesion. They were struggling with equipment delivery. They put in a bigger balloon, and then at 18 atmospheres, they got this perforation. And it was a 3-5 vessel on intravascular ultrasound. So these things happen whether or not we're doing a CTO-PCI. In this case, I put in a ping pong guide. We put down a separate wire. We balloon tamponaded the lesion, and the patient did fine. But this skill set that you get from doing CTO-PCI will help your colleagues and your own self rescue yourself even in other cases as well. And that's been one of the things that I found in the last 6-7 years since graduating fellowship, that the ability to rescue from complications is a very good side effect of learning CTO-PCI. The complication risk is there, but the more CTOs a person does, the greater the success rate and the less the MACE. And this has been published several times in several different studies, but this was the initial publication that showed this by Brulakis et al. In JACC Cardiovascular Interventions. And the reason this is important is if you start sending to an operator your cases to an operator that's doing a significant number of CTOs, you can then guarantee that your patients will probably have less risk, and then you can use that to then learn from those operators as well. Otherwise, it becomes a vicious cycle where you cannot get more cases, so you cannot improve your outcomes. But if you start to become familiar with the basics, start watching a lot of CTO cases live. Dr. Brulakis has a very good YouTube channel I recommend. Connect with teachers through colleagues and vendors. connect with other fellow learners, and really dedicate yourself to figuring out these CTO skills and using them in non-CTO settings. Travel to labs that are doing CTOs and then slowly start to do CTOs, starting with easier CTOs. You can improve your outcomes and really learn this because it's a very learnable thing. Everybody that does it, nobody's hands are sort of that much more superior. It's a mindset, and it's taking the steps to go through it step by step and moving through the hybrid algorithm, which we'll talk about. Several studies have shown that the 1-year clinical status is very good. This was a study that looked at angina, exercise tolerance, a maximal exercise tolerance. And you can see that in all departments, if a CTO was successful, patients did significantly better than CTOs that were failed. Again, in this study, the fracture trial, you can see improved angina frequency, improved physical limitation, and improved quality of life. In general, if a CTO is successful, patients do significantly better. If a CTO is unsuccessful, patients do worse. A, because they're unrevascularized, and B, because there may have been some sort of complication from the CTO itself in this group. And so ideally, success from a CTO PCI is important, and that's where that practice and that thought process before going in is important. Arrhythmias can often be managed with CTO PCI as well, especially in the setting of significant scar burden. So VT burden can also be helped, and there have been several studies that have shown this with ischemic cardiomyopathy, that if you fix the CTO, the patients may do better. LV function has been shown in several studies to improve post-CTO PCI, and that is in and of itself is associated with improved mortality. And there have been several registry studies, the first of which was OpenCTO, which was a prospective, non-randomized single-arm study to evaluate success, safety, efficiency, and health status outcomes, and really was focused on health status outcomes. Many centers, including ours, recruited patients for this study. And you can see that these were sort of our routine CTO PCI patients. Most of them had a JCTO score less than 3, with 20% having were hard CTOs, JCTO score greater than 3. And then again, similar risk factors to what we see, about a third prior CABG, 40% diabetes, and occlusion lengths of about 30 millimeters. OpenCTO showed us 4 things. 1, that there was an 89% success rate. 2, that the time taken was not significant, but about 2 hours, give or take 1 hour. So that was the average time that it took. The radiation, again, was there, but not significantly high. Initially, it was thought that these were exceeding 4 grays, but really it was about 2.5 grays. This number has gone down significantly with improvement in equipment. And then the contrast usage, again, has gone down significantly, but at that time it was 260 cc's. OpenCTO basically showed that with respect to refractory angina, patients did much better when they had a successful CTO PCI versus an unsuccessful PCI, and patients' quality of life also improved. There were significant complications in OpenCTO. This has gone down, but perforations were about 6%, which is not insignificant. Death was 1%, and rehospitalization about 15%. And so it's important to remember that these perforations and rehospitalizations shouldn't be ignored, but this has gone down as the equipment has improved. You can see again that OpenCTO had several sub-studies that showed that patients did do better from an anginal frequency score, from a Rose dyspnea scale score, as well as from an SAQ summary score standpoint. And overall, what we found from OpenCTO was that there was an improvement in symptoms versus optimal medical therapy. There was no increase in CV mortality or MI despite the increase in complications. And there was a significant reduction in overall MACE that was driven by less need for ischemia-driven revascularization because patients were no longer ischemic. So this was thought to be a relatively positive study, and this led to a separate study that was done almost simultaneously, which essentially did the same thing, prospective randomized multicenter open label study, and was asking, is PCI plus optimal medical therapy superior to optimal medical therapy alone? And again, it found similar things, improved physical limitation, improved anginal frequency, improved quality of life. And then the last study that sort of threw a wrench in things because we didn't really know what to do with it was Decision CTO, which was a randomized study, CTO PCI versus optimal medical therapy. Patients were followed for 4 years. And so it was a relatively long period of time. And you can see that there was essentially no difference. It was stone cold, no difference between CTO PCI and OM and optimal medical therapy. And this study has been cited time and time again as a reason to not perform CTO PCI. And so ultimately, as you see your patient, you have to think about what your patient is feeling, whether you think you can open the lesion, whether you think you can do it with minimal risk, and sort of proceed from there, because there's data to support doing it and there's data to support not doing it. But generally, our practice has become attempting patients that are truly refractory. So let's go through how to treat a CTO PCI. There's 4 main ways to treat a CTO PCI. And in order to be a good CTO operator, an excellent CTO operator, you need to do all 4 techniques and be able to do all 4 techniques well in sort of your first 100 cases, if you will. There are new technologies that continue to come out, the coronary sinus reducer and other therapies for refractory angina that may or may not become a mainstay in the future. But for now, wire-based treatment of these patients is the way that this is being done. And so antegrade wire escalation is the first step to learn. The second step to learn, I would say, is antegrade dissection and reentry, because oftentimes when you're working antegrade, your wire may become subintimal or extra plaque, and you should understand how to re-enter the vessel. And then as you become more advanced, then retrograde wire escalation, true to true lumen, and then retrograde dissection and reentry as a final step to learn. I highly recommend using Dr. Balakis's manual of CTO interventions, which is very, very helpful. And the first step when we look at a CTO PCI is to think about what is the difficulty that is going to present to us. And the way we do this is by first saying, is this a tapered tip of a lesion or is it a blunt cap? And depending on if it's tapered or blunt, this helps us decide how difficult or not this will be. So there's 1 point given for blunt lesions, then 1 point given for the presence of calcification, especially at the cap or within the CTO segment. Then there's another point given for tortuosity. So if the CTO is at any sort of a tortuous segment, then that can be a major issue. And so that's a third point. And then the fourth point is the length of the occlusion. The longer the occlusion, the more likely you are to need to go retrograde. But greater than 20 millimeters gives you another point. So an easy CTO is a CTO score of 1, but as you get into 3, 4, these are difficult CTOs that may require more options. So let's start with antegrade CTO PCI. This is a reasonable choice for lesions that are short. There's no tortuosity and there's no calcification. So that's generally the first strategy. You want to put a microcatheter in, put a nice 45 millimeter bend, and then start to probe the CTO and see if you can make progress. With your hands, you're holding the microcatheter with your left hand, stabilizing the microcatheter, and with your right hand, you're sort of spinning right, spinning left, but not more than 30 degrees, just nicely going back and forth with your finger, like back and forth like this. And then you're trying to advance the wire slowly, but you're not pushing. You don't want any tension in the wire as you push. That's very important. You don't want to see buckling of the wire because you don't want to push into the lesion and you don't want to dissect if you can avoid it. So what you're trying to do is back and forth motions to just find the channel. You want the wire to fall into the channel and you want the wire to sort of carry itself to an extent because it's very gentle back and forth. You're mostly working the angle once you get to the tip of the lesion. I typically start with the Fielder XT if it seems simple to begin with, but I only use the Fielder XT for maybe 30 seconds. So if you want to save cost, then I would just start directly with the Pilot 200 if you don't know the course of the vessel. Some people say start with the Gaia Second or a Confianza Pro 12 if you can really see the distal part of the vessel. But generally, most of us say the Pilot 200 is a much safer wire. It's stiff, it's polymer jacketed, and most CTOs can be crossed with the Pilot 200 and a good operator. Most CTOs are not heavily calcified can be crossed like that. When you think about the wire, you're thinking about what are you trying to do? Are you trying to access the lesion? You're trying to directly penetrate, then you may need something with more stiffness. Are you just tracking the channels? Then you need something that's more lubricious. Are you crossing collaterals? Then you may need something that has very low stiffness because you're trying to get through collaterals. When you're knuckling, again, you want something that's very lubricious that will slip into the subintimal space. For re-entry, you want something with high rotational stiffness. And for externalization, you're really looking for length and then low shaft bend stiffness. And we'll go through some of this later. But it's important to remember why you're using whichever wire you're using. The first step is obviously knowing the steps. So how do we do anterograde wire escalation? We start with the good guide engagement, good support. Then we engage the cap with the workhorse wire and we place the microcatheter distally. Third, we do wire escalation and then de-escalate after crossing the cap. The fourth is to advance equipment, and this may require a guide extension, so balloons and stents. And then finally, intravascular ultrasound to optimize durability of the stent. So that's sort of the basic steps. But we have to set ourselves up for success. Biradial is very common as a way to approach CTO-PCIs, but if this is what your catheter looks like going in with your diagnostic, you know that that is going to be it's going to add difficulty to your CTO-PCI. So I tend to go femoral anytime I have any sort of problem with the radial because that sets me up for success. A microcatheter will be helpful understanding your wires, why you're using which wire, and getting very comfortable with 2 to 3 wires. So my 3 wires are Pilot 200. I rarely use the Fielder. So Fielder or Pilot 200 as the first step. The second step for me is always a Gaia second or a Gaia third. And then the third step is a Confianza Pro 12. And if I'm not able to get it with those 3 antegrade, that means I have to go retrograde or I need to go antegrade dissection reentry. So as you get comfortable with CTO-PCI, you'll understand which wires are your wires, and you get very good at knowing if you're going to be successful with that versus not. It's important to be flexible going through the different parts of the hybrid algorithm and deciding on when you go antegrade and when you go retrograde. So the cases you want to go antegrade are where it's a tapered stump, not a blunt stump, a short segment. You can sort of see the microchannel. There's not very much calcification, and there's a broad, good distal landing zone, so you're not giving up on major branches, or you're not landing in an area at a bifurcation or something like that. You always want to be prepared for antegrade and retrograde. Using a microcatheter is very important because it gives additional support to your wire. So while it's additional cost, it is very useful because it allows you to mark your place in the vessel, and it allows you to continue to change your bend to make sure that you're appropriately attacking the actual lesion and the actual CTO. And when you're dissecting, it allows you to form a smaller knuckle, which is associated with improved outcomes and less damage to the vessel. A dual lumen microcatheter can be very useful, and I encourage you to be very facile at using it. This is a case I was doing where I kept ending up in the RV marginal branch. You know, in retrospect, maybe I could have done a retrograde approach here and gotten through this lesion more quickly, but this was sort of a case I was doing in the first couple of years outside of fellowship. And so I was very committed to wanting to stay antegrade because I was not as comfortable with retrograde at that point. And so I put the wire, kept putting it down the RV marginal. That didn't work. So finally I put a dual lumen down. So I left the wire in the RV marginal around and used a dual lumen to redirect a Gaia second and sort of poke at the cap here. And that allowed me to then, with distal visualization, advance the Gaia second. Then I switched out for a regular microcatheter, and that was a successful CTO-PCI. Again, one could argue that I should have gone retrograde before, but retrograde is associated with more complications. And so this was a nice way of being able to get through using that RV marginal branch. The fifth trick is to know your wires and why. So what are you trying to do? Are you trying to just get to the distal vessel? Are you trying to get through a very tough occlusive CTO? Are you trying to knuckle? Are you trying to re-enter? And that sort of helps decide which wire. It also helps you decide what kind of bend you're going to put. So generally, I put a 30 millimeter bend like this, 30 to 45 millimeters, to cross the CTO. But to access the CTO, I may put a bigger bend, and then this will be sort of a workhorse wire. And then this is what I would do with my actual CTO wire. The shaping is important, and it helps penetrate from the subintimal space if you put a proper tip also. So about a 45-degree bend if you're in the subintimal space, and we'll talk about that more. I can't stress enough how important it is to be familiar with new equipment that you have access to. So anchor balloons, guide extensions, intravascular ultrasound, all of these things can be very helpful in delivering equipment, but also in assessing where your wire is and in helping cross the lesion. IVUS is specifically important because it allows you to identify whether your wire is intraplaque or it's extra plaque. And if your wire is extra plaque, A, recognizing that on IVUS is very important, and B, understanding how to get back intraplaque is important. So IVUS will tell you how calcified that area is. Maybe you need a stiffer wire. It'll also tell you a little bit about the distance in terms of where the best place is. And as you get more advanced, you'll be able to penetrate into the true lumen on live visualization with the large guide and the IVUS catheter on the initial wire. The most common reason antegrade wire escalation fails is because a wire becomes extra plaque. And so IVUS can be very helpful in recognizing that, as you see here, this wire is extra plaque. And then because we know it's extra plaque, we can then start to direct it and see where this white dot moves to understand if we're going towards the true lumen or away from the true lumen, and that can be very helpful. It's useful to delineate the position of the wire, to perform IVUS-guided puncture of the cap, and to help identify the proximal cap characteristics to determine what you need to cross. And so this is sort of an advanced thing to learn, but eventually it can be very helpful in simplifying your CTO-PCI. And so for now, what I would say, especially as you graduate fellowship, is just get comfortable with looking at intravascular ultrasound images, because then when the time comes for you to learn more about CTO-PCI, you can learn this skill set very easily if you've become very familiar with looking at IVUS images. And trick 7, but perhaps this should be trick 1, is to be safe. And there's many things you can do to be safe, but the single worst way to cause a complication and the easiest way to cause a complication in CTO-PCI is to advance your equipment without confirming distal wire position. So this is number 6. And that is a very common mistake. That's generally what causes perforations. And so the way you can avoid that is to ensure that you've got a good antegrade and retrograde angiogram before you advance anything, to make sure your wire is dancing with the vessel, to recognize that if you have sudden spontaneous freedom of the wire tip after it exits the distal cap, that's maybe too good to be true. The number of times I think I've crossed a lesion because the wire just frees up, but it's too free. And then when you do the injection, the retrograde injection, you realize, oh, I'm completely off plane, and so my wire is completely out. Generally, a wire will never cause a bad perforation. You may get some staining, but it will not cause a bad perforation. But if you advance the microcatheter, that's now, a one French hole that you've created through the vessel, and so that's a bigger issue. Distal vessel wiring should always be confirmed by angiography, and then you always want to take multiple views because you can be fooled. So this was a case from my fellowship, actually. So we were advancing the wire. We thought we were in a good position. You can see the distal part of the wire is not really anywhere, but so we sort of redirected, and then in this view, we realized we were completely off, right? So you can see the wire is completely far away. So because we changed views, we realized that. But when we pull the microcatheter back, you can see that we had already caused an Ellis type 3 perforation because we just didn't recognize initially that we were in the wrong space. So you want to avoid this mistake. Just as a side note, you can see this case was difficult to deliver equipment. So you can see that this was anchor balloon was used in the RV marginal branch to get things down. And so that's another trick that can be used in CTO PCI or in regular PCI to get things down. When you're delivering equipment, you may sometimes, run into issues. And so you want to understand the algorithms to do that. And so one was the anchor balloon, like we talked about. But sometimes you may need to do a deliberate balloon rupture which we call, basically you put a carlino, or you put a balloon up, or a granatoplasty, where you put a balloon up and you purposely rupture, or a carlino, where you create room with a forced injection, or you can, obviously do rotational atherectomy or some form of atherectomy. But if all else fails to try and get equipment through the true lumen, then sometimes we will purposely dissect and then create a dissection plane, because it's easier to deliver things in a dissection plane and then re-enter. And that's again in very complex cases. Cases like this, it's much safer for you to dissect rather than to try to deliver equipment through this, because there's again a high risk of perforation. So anytime you've got very tortuous lesions, you may want to initially cause a dissection so that you can work through the tortuosity. So knowing how to dissect and knowing why to dissect is the next important principle of CTO-PCI. It's often safer, especially with an ambiguous cap, severe calcium, or tortuosity. And it's basically, imagine a closed fist pushing through the vessel versus a needle pushing through. So the needle has a higher tendency to sort of burst a balloon or to burst the vessel. But if you think of a closed fist through a balloon, that's not going to pop a balloon like a sharp wire is. And so it's the same concept when we travel through a vessel. A knuckled wire is like a closed fist as opposed to a sharp tipped wire, especially a high gram load wire. And then the other main thing is that it takes advantage of the distensibility of the vessel, so that allows you to go through with it. Another reason to dissect is when you're already subintimal with the penetration wire, and when you're trying to minimize dye. So how do you do it? You take a microcatheter, you take a polymer jacketed wire. A trap liner can be helpful to reduce how far the dissection extends. And then if it's getting harder and harder, you may use a ballooner and contrast with the carlino to do it. So you want to, again, take a small bend like this. These two B and C are too big. It's going to create a big knuckle, but a nice small umbrella bend. And then you use the microcatheter. Without the microcatheter, again, the knuckle will be too big. But with the microcatheter, you want to just push through, get into the dissection plane. Beyond the scope of this talk, but I can send the slides your way of how to do each one of these dissections. But there's scratch and go, there's power knuckle, where you put a balloon up and then you push the knuckle. There's a balloon assisted subintimal entry, where you use a balloon to then get into the subintimal space. Side base, when you're doing it with the side branch. Carlino, which is with a strong injection, and power carlino, which is with the strong injection and a balloon up. So all of these can be ways that you dissect. But dissection can be very helpful. This is a case with this is sort of how you do it. You have the microcatheter, you put the bend on it, and then you're sort of pushing, making sure your guide is not coming back. And eventually this knuckle will just free, and it'll get into the subintimal space, as you'll see here. And you see this is a tight knuckle. The goal is for it to be a tight knuckle, so it's not creating sort of a big area of dissection. In cases with a very long CTO, these are cases where you want to think about going retrograde. This was a case where we did a retrograde dissection. So you can see we went through the EBU 3.5 guide, took a long turnpike, put a long Xion wire through. And then here I started to meet resistance. So then here I took a retrograde knuckle. And this was an osteal occlusion, as you can see there. So I was not able to get much in the way of antegrade visualization. And so then I used this to try to wire the guide, kept missing the guide, then thought, okay, maybe I'll re-enter into the aorta, and then re-entered into the aorta, snared, and got a good result here. So this was sort of a relatively complicated CTO, but because we just went retrograde immediately, was complete in less than 45 minutes of time with no complications and very little dye load. So again, the flexibility of going from antegrade to retrograde, and understanding that there's certain cases in which antegrade is better and certain cases in which retrograde is better. So this is the type of case where retrograde is better: an osteal stump occlusion, a blunt cap. This was a very long CTO segment, somewhere where you have got very good retrograde collaterals, something which has when you have a very calcified lesion or a narrow landing zone, or when you're concerned about side branches getting lost. I'm going to end with a few sort of more recent cases. This was a 54-year-old came in with an NSTEMI, multiple medications had failed, 55% EF, but chest pain was just not resolving, and he was no longer able to perform his everyday activities. And so he had a stump, again, osteal RCA was stump occluded. We actually were not able to engage it. We got a CT scan, which showed that it was stump occluded, and you can see a long sort of PDA collateral coming off of this septal here. And then there looks like there may be an epicardial also going down here, but the epicardial I typically don't touch because there's high risk of perforation. So this septal was what I was thinking about going after, and this was sort of the only option this patient had because of the fact that there was no antegrade option, and the symptoms were severe, and you can see that he had had previous surgery for a valve before, and he was turned down for reopening of the chest. So surgery was not an option for this patient. So you can see here we found the septal sort of connect. We started surfing these septals. Contrast wasn't really an issue in this case with the normal creatinine. So this is a long turnpike. So you want to use a longer microcatheter when you're going retrograde because you'll need the length, and you want to use something very floppy. So turnpike LP is my go-to for retrograde, but you can also use a Corsair XS, but again, long, 150 centimeters. And then a Xion wire is very nice at sort of traversing the retrograde space. And so you can see this is the wire sort of going across, and the microcatheter is following. As you're advancing the microcatheter here, it's very important to watch the guide catheter and make sure the microcatheter doesn't start to buckle. If the microcatheter starts to buckle, that can be a big issue because then you can get perforations of the septal perforators, which is not very serious, but it can cause sort of hokum-like symptoms, and we have had to watch patients in the unit for that. So you want to try and do that very carefully to make sure there's tension in your wire and sort of take things from there. Then a distal tip injection can be performed, and you can take a look at the distal RCA here, and you can see that, we look like we're in the right place. We continue taking the microcatheter up. I took the Fielder XT knuckle up, and then here again, I was not going to be able to get into the guide, so I went ahead and snared in the aorta, and then took an RG3 and externalized that way. And then you can see here, once we got this all in, the patient had a good result. This was the stents going in, and this was the final result. And that explains a little bit. So this was an unusual takeoff, and so it was stump occluded up here, and we were just not able to engage into that initially. And so this patient did quite well with very little contrast. This was another case from a few weeks ago, 79-year-old came in with shortness of breath on exertion for several months and an EF of 35%. So when we did the dual angiography, we saw that there was an LAD CTO in the setting of a low EF. So we did think it was important to treat, especially given that he was very symptomatic from it. But the question was, initially I wanted to go antegrade, and we sort of went back and forth, the fellow that was with me, and we said, okay, we'll go retrograde. This was a Turnpike LP 150 and a Xion wire. And you can see, so you can see we basically took the Xion wire, we're able to get retrograde, crossed back into the LAD, and then used a Gladius wire to finish this case. And you can see here again, this was snared, externalized, and then we were able to then place the stents, and this is the final angiogram. So both of these cases illustrate long lesions that were better treated with retrograde CTO-PCI rather than antegrade CTO-PCI, as you can see here. That's the final result of that. This patient did really well. He started running 5Ks and 10Ks afterwards, and his EF improved to 55% at his 1-month follow-up. And he was, I think, running within 3 to 4 weeks of the procedure. So that was a good outcome. So I've showed you a lot of cases of how CTO-PCI can be very successful, but the big question is, when do you do it? and when do you stop? And the most important cognitive thing for you to learn as a fellow in general when doing interventions is when do you stop? And this when you stop is not when you're tired or you've decided you've done enough. It's really has to be the patient, because otherwise what happens is inevitably our ego will always come in the way, and we will always feel in the moment, no, if I try one more thing, I'll get through. If I do this, I'll get through. If I do that, I'll get through. And as an operator, it's very hard sometimes, especially initially, to say that I have failed this case and to walk away from it. And I encourage you to lean on your colleagues as you start practice to be there to sort of be that judgment for you, but to also be aware yourself of when you think the case is sort of slipping out of your hands, because it will never be the first complication. Often the first complication you'll be able to sort out on your own, but it's often the second or third complication that gets you. So once you've had your first complication and you've solved your first complication, to stop the case is always very important. And there may be cases you're working on a CTO for 4 hours and you recognize that you're starting to mix up wires, you're fatigued, you've had a long day, it's the last case of the day. It's okay. There's no shame in admitting that my fatigue is now maybe at detriment to the patient, and the patient can always be brought back. Radiation exposure is important to consider for yourself, for the patient, and the staff. And now Dr. McKentigard, who works with us, Margaret McKentigard at Columbia, has an INVEST study that she's doing with Anya Oskinsons from Norway. And both of them are basically looking at which patients can we invest, so which can we create a dissection plane, do some ballooning, and bring back. And so oftentimes, if it's a very hard CTO, you can always just dissect, balloon, and then bring back, and those patients tend to do okay. But it's important to understand when to stop, but also when should I even attempt the CTO PCI in the first place. And that's where you really need to know your patient, know the indications, and understand which patients you should bring. So if you think you're going to make your patient feel much better, if you think that you're going to improve their EF, if you're going to be able to achieve complete revascularization and improve their long-term outcomes, and so that you can provide your patient with that cutting edge care if that's what they want, those are very good reasons to pursue CTO PCI. But you want to make sure that it's about the patient and not about developing our own skill set, because it can be very difficult sometimes to distinguish those two. It's as time has gone on in 2025, CTO PCI is much safer. There's excellent risk scores. We've got much better technology than we did even 7-8 years ago when I had started. The stents are longer, the microcatheters are more deliberate, and the wires are excellent, and to the point where we very rarely go retrograde, because antegrade is so often successful. And antegrade obviously is associated with less complications as well. So some key take-home points for you that I hope that you keep with you, at the end of this is there's an increased prevalence of complex patients that's going to require your time. It's important to discuss these patients and refer them to either your colleagues that are specializing in CHIP or yourself if you're going to specialize in sort of taking care of these really high-risk patients. Ignore the myths about collaterals, about the data, about all of that, and really think about there's good data that supports improved symptoms, improved EF, and improved electrical stability. And in the right hands, so your goal as fellows should be to get yourself trained so that you feel comfortable either during fellowship or after fellowship. It's a long training route. It's not going to happen in 1 or 2 years, so that you can safely and effectively take care of these patients. And with that, I'll open it up to questions. Thank you so much again for having me here today.
Hello, can you hear us, madam?
Yes, I can hear now.
Yeah, thank you. That was a great talk. You covered both aspects in one lecture, and what all points which are very particularly relevant for fellows who are sitting here or training, you covered up very well. I was really impressed for the first statement what you made. The indication, just because the lesion is hard or tough, the indication should not change. If a patient needs revascularization, it has to be done irrespective of what is the anatomy and long CTO, things like that. And coming that again, the steps, how to handle the CTOs, and then when to stop also you highlighted it well and covered some of the important theoretical aspect. And finally, you also mentioned you should ignore the myth and try to do good. If your individual patient needs it, you have to do it. And you also should be teaming up with a few of your colleagues who can be your mentors, and then probably try to do initial cases with them. All that points which are very relevant for fellows, you covered up very well, madam. Thank you for your time. And I have Professor Sandeep Mishra, who is already institute professor before. Now he's heading, he was a vice chancellor before and Cygnus Institute, now in cardiology professor. I have Dr. Kannan, is again a head in medical college in Chennai. So I request if any of them have any questions, or Dr. Chiba madam also, anything you have to ask her, because she has to leave. It's already 12:30 there. Sorry for keeping you little way.
No, not at all. Not at all. Thank you for having
And
me.
after they ask one or two, then I would take your time to have a brief rapid fire session in the end again.
It's a wonderful talk, Dr. Kannan. I'm the Director of Cardiology at MMC Chennai. So what is the experience in going through, retrograde through the, you had gone through the septal. What about the epicardial collaterals? What is your experience and what are the tips or tricks in that?
Yeah, so I think the biggest trick to epicardials is to not do it unless you have to, because the complications associated with epicardial, traversing the wire, not so much, but traversing of any sort of equipment can be very treacherous, especially if it's a tortuous epicardial. But we do them on occasion, but we typically try to avoid them. So generally, antegrade, retrograde, medical management, and then we'll bring back for epicardials, and with multiple senior operators as well and whatnot, because the risk of epicardial collateral perforations can be quite severe, especially in a couple of these that the post CABG patients and whatnot. So if you're going to go epicardial, I think the advice is obviously to take a very low profile wire, low profile microcatheter, and to be ultra careful as that microcatheter goes through the tortuosity that's often present in the epicardial wires. Septal perforators tend to be quite safe to traverse. And so it's sort of much more favorable sort of in the first, we say 5 to 10 years of trying the CTOPC. And as you become more advanced, more comfortable, then the epicardials we recommend.
I'm Dr. Mishra. Excellent talk, madam. Since this is a gathering of mostly fellows and beginners, so could you tell us, like in US, how do you go on these algorithms, strategies? So for how many cases you go for only antegrade wire escalation, and then once you have done X number of cases, then you graduate to, let us say, dissection, antegrade dissection, and then finally how many cases, CTO cases I'm talking, when you start doing your first retrograde and then ultimately the retrograde dissection? So any US guideline or something like that?
Yeah, there's not. We've looked at, there's a document I can send that we put together that basically looked at what a CHIP fellowship looks like and what skill sets should be learned during a CHIP fellowship, how many impellas need to be placed, how many CTOs need to be done, and all of that. But in terms of graduating from one skill to the next skill, we've not put that in there because it's so variable. Some people train on retrograde first, other people train antegrade first. It just depends on the training style. But our particular method at Columbia is, and what we sort of recommend as fellows go out, is about 20 to 50 antegrade cases, because the antegrade skill set to do antegrade dissection and retrograde is not as important. So first I would say 100 angiograms that have been studied, whether or not you're scrubbed, but 100 CTO angiograms that have been studied with an operator, what approach, retrograde, antegrade, and that can be done via the YouTube channels as well. So where you see a case and you see somebody that's thought about it and you look at that angiogram and you analyze it. So the most important is the analysis of the angiogram. Then 20 to 50 antegrade cases. Even 20 is okay because the antegrade skill set is very different. And then once you feel comfortable with that, then you can start moving into antegrade dissection entry, and that would be about 20 to 30 cases before moving to retrograde. But it can be done simultaneously because each of them are different skill sets. But I think it takes, 15 to 20 retrograde cases on your own 15 to 20 ADR cases, and at least 20 antegrade to start to feel a little bit comfortable with each of them. And obviously, the more you do, the more comfortable you'll be, because every case will present different challenges. And then the more you can use intravascular ultrasound during those cases, the more live feedback you'll have. Where's the wire extra plaque? Is it intraplaque? And all of that.
Thank you, Madam. Satpati, Madam, you want to ask anything? Yeah, I think the great talk. I'd just take 5 minutes more of yours. Is it okay? And then
Of
we will,
course.
because I don't want our fellows to get depressed thinking all this, that they're not able to do the high-end stuff. But what I want to assure all of them is, even in her setup, I think she would agree, doing all these the retrograde cases and taking the various other techniques would be in less than 10% cases. Do you agree, Madam? Out of all the PCIs which you do,
Absolutely.
I think about
Even
18, 20.
less than 5% of my cases will be retrograde. And the reason for that is because the antegrade wires are so good now that there will be some operators around the world that like to go retrograde because they like to go retrograde. But is it necessary? No. Most of the cases can be crossed antegrade, and most of the cases you can start to do beyond fellowship. So you don't have to learn it. You don't have to be at the front of the table holding the wire as a fellow in order to do it. As a fellow, you want to watch what your senior operator is doing and understand what his mind is doing during the case, or her mind is doing during the case. That's the most important thing. Because and I tell this to my fellows every year, and every year my fellows come. This year again, they come and they say, I'm not doing enough. I'm not at the front of the table. I feel like I need to be more at the front of the table. And we all have different teaching styles. But some people are not wanting the fellows to go to the front of the table until they see that the mind is engaged and you're understanding, why is Dr. this taking this next? Why is he or she taking this wire next? What did he see on that angiogram that he wanted to pull for this? Or what did she think about that complication? Why did she not react to that complication like she reacted the day before? So understanding the why is the most important thing. The hands, anybody's hands can be trained. And anybody's hands can be trained. But if you spend time with a good operator and understand why they're doing what they're doing, that's the most important thing. And these videos online will help you do the same.
And another important thing which Madam already stressed enough is analyzing the angiogram properly. Most of the times what you think as CTOs, there could be a faint trickle of flow if you observe it very carefully. And then filter XT type of wire could do the process rather than going to stiff wires. I think how much percentage of your cases which are thought to be CTOs, you could cross with filter XT type of wires because of micro channels being there in that?
So Fielder XT or Pilot 200, I would say 70%.
You see that. So it's
70%.
very
Yeah.
important to analyze the angiogram carefully. Don't think always you need to take help of very stiff high-end wires, because most of the times this 0.09 filter XT has a very tapered tip, and then pilot also, Madam is telling, you will be able to get out on that, you'll be able to do a good job. But only thing is, once you cross, you need to know how to control that wire. If possible, you change over to regular workhorse wire later. And after you cross that type of wire, Madam, what is your favorite balloon? Our fellows want to know here. Difficult, toughest, where is not balloon, non-crossable type of lesions. Which one is the balloon which you prefer? It's obviously variable from place to place, but
Yeah.
what do you prefer?
We like the Takeru balloon, and I'm trying to think what the name is. You have it in India. Does it ring a bell,
The
Takeru?
Termo company?
Yeah, Terumo's balloon.
Yeah,
It's a Takeru PTCA balloon. So it's a Terumo balloon.
yeah.
And it's 1.5. So that's what I start with always. The 1.5, 15
Here we have it as
Takeru
rail,
balloon.
Termo rail balloon. It was 125 before, now 1.4, but 5 mm length is also available. That's, I think, most of the times it crosses. And then once, if it's not going, what is your favorite micro catheter which you use if your balloons are not going?
So it's actually interesting. So generally, I try to get the microcatheter across, and if the microcatheter doesn't go, then I take the Takeru balloon, which often goes if the microcatheter doesn't go. But if the
Okay.
Takeru also doesn't go, then I might take a Caravel. Only problem with the Caravel microcatheter is it's very flimsy, so you have to be, and you cannot spin it, so you have to be very careful that it does not, the tip does not fall off, especially in calcified lesions. But generally, the Takeru goes.
Thank you, madam. I think once you are comfortable doing it and then you have done, how many times you have crossed with the wire changed it, and finally something happened at the end, you couldn't do the procedure successfully? Is it there like that? Or once you're done with the crossing the wire and balloon, you're done with the procedure? Any
So
examples?
we do joke that sometimes that's just the beginning, but it has happened where you still cannot get equipment, still cannot get equipment. So, you may spend 3 hours after crossing roding, guide extensions, guide liner, getting the guide extension down, or then needing to go back and go subintimal. But most of the time, if you've have adequate guide support and you're able to sort of get balloons down, you'll be okay. But it does happen where the equipment delivery can become very difficult, especially in the calcified kidney patients.
Lastly, before I give it to our fellows here, I see a lot of female cardiology fellows also sitting here, inspired by you. And any tips for them for the radiation protection?
That's a great idea. That's a great question and a great concept that we are sort of starting to understand more. So, from a radiation standpoint, I think the risk is there to men and women both. But I think during pregnancy, especially, is when we worry about it more. Here in the United States, we cat through. So I just delivered we cat through our pregnancies. But we also now having more equipment. The Rampart we have. That reduces some radiation. Lead is lighter now. But all of the data has shown that pregnancy and radiation with lead has not caused any long-term issues. And so I cat through both of my pregnancies, and I think that's all fine. I think where sometimes as a woman you need to think about is work-life balance, and that's just as a woman and as a guy, you just need to be able to know when to say no and how to organize sort of your schedule and whatnot. But I think that's sort of something that now, both genders will struggle with as the homes become sort of more equally divided.
Even during pregnancy, you worked in cath lab, you mean?
Yeah, so we work through, we don't take off during pregnancy. So I basically was cathing, I delivered early because of the pregnancy complications. So I delivered at 34 weeks, but I did my last case on the Friday before I delivered.
The great commitment, madam. We congratulate, and big round of applause for madam. Hall is full. Hope you heard those claps for you. And any final unfulfilled desires for you in CTO?
I'm very interested about the coronary sinus reducer. So that's sort of outside the CTO space, but it's basically a device that occludes the coronary sinus, creating backward pressure to treat microvascular dysfunction and refractory angina and epicardial disease, right? And so I wonder whether when that device is placed, will we be doing less of these dangerous CTO procedures because that simple device will treat refractory angina? So that I think is the next frontier of CTO PCI.
Recently, in the last recent TCT, we were identifying who to speak on that microvascular reducer therapy. We finally brought Ajay Kochar from Brigham's to talk to us and share his experience on that, madam. And as madam has to leave, any female fellows, residents want to ask any question to her or anybody before we close? Any questions from the hall? We in India, this is a problem, madam. They know everything, but they talk little. And we have to learn that also a lot from you all Americans, where I had recently one MBBS fellow from US came for observership. She was asking questions at every step what we do. So that is a thing which we need to cultivate, because it's an opportunity for you to learn from her. And with her expertise, most of the questions which they had doubts, I had asked you, madam. Again, thanks for your time. And thank you again. Hope we'll have you in person next year. Thank you again.
Thank you. No, please convey my number to any of the fellows. If there's any questions, anything that comes up, you have my number. Just please send me a WhatsApp. I'd love to hear from you.
Thank you, madam. Thanks. I think we can break and we'll go to. Okay. Now we'll have Professor Sandeep Mishra with us. He will have. She didn't spend too much, most in the techniques and other things, but toolbox of CTO. Requested what all the material to be kept available in the lab. Professor Sandeep will be taking us through that. Over to you, Dr. Sandeep. As mentioned here, many of us know him as the All India Institute professor. He has been a vice chancellor of NIMS University in between. Now he came back as chairman cardiac sciences, and now he's working as director cardiology Ujala Cygnus Bright Star. Over to you.
Uh, फुल स्क्रीन करना था, फिर वैसे कर दी। Again. And I think, a lot of things have already been told. Few things I want to say before I start anything else. Number one is that PCI is different. That I think you have to understand. And why it is different? Because unlike other kind of PCI where you negotiate empty vessels or vessels filled with blood, here you have a resistance there. So for that, you require certain things. You require a good support so that you can pass the things. So you require a good guide catheter and that kind of thing. Other thing is you require a wire which has got a higher tip load because you have to cross the resistance. So, and then third thing is you don't know where you are going because everything is opaque. So you require to be very well conversant with IVUS techniques because you want to have another look at what you are trying to do. So I think some of the things are very important to understand, that if you really want to do CTO, you have to have experience with certain different group of equipment and you need to know them well. So I think that is number one. The other thing is that all CTOs are not equal. So there are certain CTOs which are relatively easy to do, and there are certain CTOs which are relatively difficult to do. They may be a very small percentage, but they are there. And so you need to, figure out which are those CTOs that are easy to do and which are those CTOs which will be very difficult to do. And as one of them, first thing is to very carefully inspect the angiogram. And then you may even do a CT angio to look at, the distal things. And so basically, what I'm trying to say is you have to make up your mind that this is a relatively simple CTO or it is a very complex CTO. So that is number two. Third thing is that not all people can do all types of CTO. And therefore, you have to, match your skills with the type of CTO you are attempting and the kind of equipments you know. So this matching part is very important. You need to know that this is the way I have to do and this is the equipment I will have to use, and then use it according to the type of CTO. So I think these three things are very important before you start anything else. Now the philosophy is to understand this algorithm. So that is the main philosophy. As I said, all CTOs are not equal. You have to have your algorithm that, okay, this is the first thing that I will do. This is my first strategy. This is the second one. This is the third one. And I will go only up till this far and I will go no further because this is what I'm skilled at. So that is, I think, an important thing to know. Then obviously, for that, you need to have a set of skills and knowledge of different hardwares, guides, wires, microcatheters, and specialized devices. And then, as I said, the matching part is very important. Matching your skill with the type of CTO and with the type of device that you are going to use. I will also tell you approximately what device is used and approximately how many percentage of CTO cases to give you an idea that what you should be choosing yourself. Finally, I will be talking about some tips and tricks and tips of how to do those CTOs and then my conclusion slide. So coming to guiding philosophy, as already told, there are four philosophies. First is anti-grade wire escalation, which is the simplest. Second one is anti-grade dissection re-entry, which we were discussing also. So that is the second one. Third is retrograde wire escalation. And then the last one is retrograde dissection and re-entry. Now understand that if there is a certain obstruction in the vessel somewhere, what you can do? Simply, you can try to reach that obstruction, may try to go through that obstruction if possible. So that is anti-grade wire escalation. Or what you can do is you can slightly move your direction and go through a micro channel. So remember, in a CTO, there is not only obstruction, but around that obstruction, there are many micro channels or many areas which have got relatively low resistance. So if you encounter an obstruction somewhere, what you can do is slightly change the direction of your wire and try to pick up a micro channel. So this picking up of a micro channel is the most important thing. And those wires that you are taking are doing exactly that. They are trying to pick up a micro channel, which will make the whole procedure relatively simple. So I think that is important. But if you encounter the resistance you cannot surpass for some reason, or if you go through before the obstruction, there is a fibrous cap as well. Remember, there is a fibrous cap, then there is an obstruction, and then another distal cap may be present. So these are the total composition of CTO. So you need to understand the composition of your CTO as well. But if you cannot penetrate the cap, if you cannot penetrate through that obstruction that is there, then what you need to do is you need to go outside the vessel lumen into the artery vessel wall, and through that artery vessel wall you cross that particular obstruction and then re-enter into the artery lumen again. So this is the re-entry technique. So this happens when there is so much obstruction that you cannot somehow cross it, you cannot find any micro channel as well. Then what you need to do is you need to exit the lumen, enter in the vessel wall, remain in the vessel wall. You don't cross the vessel wall, you remain in the vessel wall. Through the vessel wall, inside the, let us say, media, you traverse and then you re-enter in the true lumen. So this is the re-entry technique that we are talking of. If still it is not possible to do, then you might have to do a retrograde technique. So I think important thing is that hardware enables the operator to switch strategies seamlessly based on anatomy, progress, and your skill level. Now, one important thing I wanted to say that the support is very important in these kind of situations. Therefore, for most kind of CTOs, the minimum size, and at least most complex CTOs, the minimum size is 8 FR. 8 French is the minimum size. If you are doing a complex CTO, there is no point in trying to take a smaller guide catheter, and no point in taking a radial approach unless you think it is a very simple CTO and you can manage only with wire escalation. If you think you will need anything more than wire escalation, you require a 8 French support. And then there are different types which give better support. I don't need to go into them. The second important thing that you need to know very much, if you really want to do CTOs, is to your experience with these guide extensions. And these are the ones which give extra support. They are child in mother catheters, guide liner, trap liner, which the lady also showed you. So these are the guide supports. And they increase the support so much that you can work on your obstruction. So I think that is the idea. The third thing is sometimes you don't get a good support, and if you are doing femoral, then you can use the femoral sheaths. On the right side, you can see there is a guide liner. This is the micro catheter. This is the child in mother guide that you use. Other thing that is very critical, and I don't need to emphasize again and again, is the IVUS guidance. Because this is a totally opaque area, you really don't know where your wire is going. And whether you have crossed the fibrous cap, whether you have entered into the lumen, whether you are outside the lumen, many times you won't know that. And only IVUS can help you there. So minimum requirement for a dedicated CTO operator is a very good knowledge of IVUS and how to use it. Then also radial versus femoral, as I said, if you think only antegrade wire escalation will work, you can go for radial, but otherwise you have to go for femoral using a 8F. And then because you use a larger axis, then you also need to close it. And so that experience is also necessary. In this right side, as you can see, there are special IVUS catheters now available, which are front-looking IVUS catheters. And those are very useful. The other thing is you use a dual lumen catheter. Through one lumen, you put IVUS on the vessel and work on through another wire. So this kind of dual lumen is also very important. And then you can know whether your wire is in the true lumen or false lumen. If your IVUS is in the true lumen, and if you see, this is called a dot sign. If you see a very bright dot of the guide wire, then you are in the true lumen. But if you look at it, it looks very blurred, then you are in the false lumen. And then you can direct your wire from false lumen into true lumen. And I think that is the idea of IVUS. So my take on all this is you can't win a CTO without a proper guide support. ATF is non-negotiable in most cases. And IWAS is the most important thing in probably in this whole thing. And that is one skill that you need to acquire. Now, coming to guide wires, choosing the right guide wire is, of course, the right thing. There are three types of guide wires. One is the navigation or tracking wire, and these are the drilling kind of wires through which what you do is you drill through the obstruction. If you find something obstruction, then you change your course and try to pick up a micro channel to cross that particular obstruction and then go forward. So these are the kind of wires. Obviously, as I said, these wires, all of them will have a little bit higher tip load compared to your normal wire, which is 0.7. Also, they will have a higher lateral support. So these are the things, and then they could be a penetrating wire so that they can get into the micro channels and then you can move forward. But the most important guide wire, I think that you need to know here is the Gaia wire. And the important thing about Gaia wire, particularly Gaia 2, and as you can see now, the dedicated CTO operators use it 70% of time. So really people who are trained in CTO would use it 70% of the time. And why is it different? It has got a rope kind of coil, which is different from other kind of wires. What it can do is you can not only drill, but once you find an obstruction, what you can do is you can slightly just swing it, and you can swing it to and fro in 1:1 fashion. And that way you can have more likelihood of picking a micro channel. So this is even better than Fielder XT or Fielder kind of wires for picking up a micro channel if you encounter a resistance. So this is what you do. You drill in, reach a particular spot, you cannot go through it. You slightly change the direction of the wire, which you will be able to do with Gaia wire because it is 1:1, and then you pick up a new micro channel and then you go through it. So I think this is the thing, and the real reality is that it has got a rope kind of coil inside it, which is very different technology. But then if you are unable to do, then these are the high penetration wire. Remember, nowadays, high penetration wires are not used for anti-grade wire escalation. Previously, people using it for anti-grade wire escalation. Now they are only used for when you have to go for dissection. So once you have to do for dissection, then you use these wires to go from the maybe true lumen into the subintimal space and then re-enter into the true lumen. And for these kind of things, these wires are used. Therefore, the usage is only 20%. There is another one which has got even higher tip load, and that is the Hornet wire. The Conquest Pro wire has 12 tip load. Normal BMW wire will have 0.7. And this has 12. So this has got a very high tip load. So these are called the problem-solving wires, but nowadays used only for dissection. Then, of course, there are wires for, if you do retrograde, then you have to go through small micro channels. Here, these channels are even lesser than the normal vessel caliber. So you have to use very soft wires. So the key here is a smaller tip load. So tip load of 0.6, 0.5, Xion Blue has 0.6 and 0.5 tip load only. So they are very soft. They will not cause any perforation. They can negotiate the micro channels, and then later on you can put a micro catheter over it. Then, of course, sometimes you have to penetrate through the distal cap also in retrograde. Then you require some little bit more tip load, and therefore Xion Black or Fielder XT-R or XT-A can be used in this particular situation. So basically, what I say is that you can start with a Xion or Gaia wire, but you graduate to Conquest only when you want to change your strategy or that kind of thing. Now, the second thing that you need to know very well are the micro catheters. And micro catheters are of two types. One is a low profile micro catheter, which basically negotiates when there is no problem in crossing the micro channels. But once you need to dilate the micro channels, then the real micro catheter that you need is a Corsair. And as you can see, it has been used in more than 95% of cases. So this is the regular micro catheter that you need to get used to. What it can do is it can not only give you wire support, but it can also used in crossing and even collateral dilatation. That is what I was talking about. But the simpler or more lower profile microcatheter are something called fine cross or caraval. They're only used when you have to cross the microchannel. You don't have to dilate those microchannels. And therefore, because in those cases, only 15% of cases are like that. And these microcatheters are used in those cases where you have to just negotiate the microchannel, don't have to dilate it, and you can just get into your retrograde thing. Then the last kind of catheter is a dedicated re-entry catheter. And I think, let's see. So this is a re-entry catheter. It has got two things. It has got a cross-boss catheter, which crosses from the point of obstruction into the subintimal space, traverses the subintimal space. Then there is a balloon there which dilates that subintimal space so that the passage is easier. It recrosses into the true lumen, and then it is that balloon can be used to dilate the true lumen as well. So this whole specialized catheter is there. And sometimes when even microcatheter cannot cross, as Madam was also telling, you need microvascular balloons. And some of them are available in India as well, as Dr. Srinivas already told you. And these balloons can be used to cross through when ordinary balloon or microcatheter is not passing. Then other thing that you need to know is when you encounter a lot of calcium, nowadays IVL is a very good thing, especially if you are able to cross through your balloon, then you can place this catheter, now used in about 10% of cases. And then orbital atherectomy if it is not, if you cannot cross. IVUS, as I said, is the most important thing, I think. And if you really want to do complex CTOs, required in more than 90% of cases. What it does is it can find out where is the cap located in case you are unable to locate the cap. Then you can identify whether your wire is in true lumen or false lumen because of that dots sign I told you. Then you can, once you enter into the lumen, you can optimize the dilatation, you can optimize the stent size. And if any complication happens, then IVUS also helps you there. So there are many, many reasons why you should be using IVUS. And I think this is really, somebody, real CTO operator, I would consider only when he is very proficient with use of IVUS. It is important not only for the success, but also for the safety. What it does is before starting the procedure, it identifies the ambiguous proximal cap. It can help confirm the vessel patency. During the procedure, it can help in guide wire entry. In the retrograde technique, you can know that you penetrate the distal cap, enter into the donor, through the donor vessel into the real vessel, and also in the re-entry, it can help you. And finally, once you do the procedure, you can optimize by the correct size of stent. So I think IVUS just isn't a tool. It is your, basically, if you travel somewhere, you put your map into the GPS and then you travel accordingly. Likewise, this is your GPS. It will let you know your location at all times. So this is your GPS in interventional cardiology, and it eliminates guesswork and is critical for safety and success at nearly every case. Now coming to some real world usage, in real world, more than 90% of the cases, Corsair is used, 8F guides are used, and IVUS is used. And this is by trained CTO operators. More than 90% of the cases they will use this, and 40 to 70% of cases they would use either Gaia wire, then some of them will use Xion wire and Stingray systems, and then many will be also knowing Crossboss, Conquest Pro 12, Caravel, and intravascular lithotripsy. So I think, important thing for a beginner is to know the microcatheter well, especially the Corsair, and to know the IVUS well. So I think this is the basic minimum that a fellow should know if they really want to start a program, and then match the strategy with the hardware. So if you're using integrate, use Gaia wire, Corsair, IVUS, three important things, as I said, in 70% of the cases they are used. But if you want to do integrate dissection, best thing to use Crossboss, Stingray, and even Conquest Pro wire, which can do the thing. In retrograde, you require wires with less tip load because you have to cross through the micro channels, and therefore you require Sion wire, you require lower tip micro catheter like Caravelle, and you can even need micro balloons. So I think you don't pick devices at random. You plan your strategy and then you escalate from there. This is how you do the whole thing. Finally, some tips and tricks. I know I'm a bit exceeding time, but some tips and tricks. Number one rule is do no harm. I think that is the number one rule that has been told. So for first cases, safety is more important. You first 50 cases, you should have no complication, even if you are unsuccessful in them. Then once you cross 50 cases, then you can think of success rates, and then you will always remain safe. Second thing is, once you do something and you are failing, after 20 minutes, you stop, think what is happening, where you are, what is really happening, think on alternate strategy. Okay, this is not working, I will do this different. And if not, then you even call for help, because this is the sign of wisdom, not weakness. And finally, and I say this again and again, that CTO PCI is a marathon, it is not a sprint. The pacing and strategy will win the race, not the brute force. So it is, a slow and steady thing. It is a marathon. It is not a sprint. I think that is very important to know. The second rule is learn your algorithm well. And as I said, you feed your algorithm like your GPS before you start your whole thing. Plan everything, plan A, plan B, plan C. What I will do, this fails, then I will take this device, do this, if this fails, this. And this is like what you do when you travel as well. Then some simple tricks. If you can see the proximal cap, go for integrate wire escalation. If cap is ambiguous, but still you know that there is no tortuosity, you can go for dissection. And then you can cross into the true lumen. But if you know that somebody has already failed in integrate, very carefully think of retrograde, and then you start doing the retrograde technique. So for first cases, I think 50 cases or 20 cases, whatever your skill is, the word is integrate wire escalation. Once you do those cases, then I think you graduate to dissection, re-entry, and then finally retrograde. Then, as I said, your 8F guide is your best friend. Don't, in most complex CTOs, you will have to use a 8F guide, and you have to be conversant with use of guide catheter extension. So if you want to do a CTO, you first learn IVUS, and you also learn how to do a guide extension, how to use guide catheter extension. And third thing is you learn how to use a micro catheter. These three things you have to learn before you start your CTO program. And then start soft, say soft, escalate only when you cannot with the regular wires. Shaping your wire is also very important. So for polymer wires like Fielder FC, Fielder XT, you should do 30-degree angle shape at 3 millimeter from the tip. But if you use Gaia, you use 1 millimeter tip, you have to bend, and 60-degree you have to bend. So according to your wire, your tip should be made. And the drilling is the main thing. But if you drill and you cannot get in, then what you do is you basically do a clockwise or counterclockwise movement, which is done very well with the Gaia wire. And you do a counterclockwise or clockwise movement, enter into the real lumen, and then you go in. Using Conquest Pro 12 for anti-grade wire escalation nowadays is not a good idea. It is not a crossing wire. It is a re-entry wire. Remember, previously it was used as a crossing wire. Now it is a re-entry wire. Then another important thing, micro catheter is your hand on the wire. It gives you support. Without a micro catheter, most people don't do CTOs, as I said, required in 70% of the cases. And there is a micro catheter push test as well. If you can cross with micro catheter, then you are okay. If you cannot cross with micro catheter, use IVUS to know where you are, whether you require to go into some different place or whether you require a micro balloon to cross. Because if micro catheter is not crossing, then you need to pause. And the most important thing is that maybe your guide support is not good. So whether you need a better guide, whether you need a child and mother catheter, guide extension catheter to improve your guide support, I think that is very important. Then when exchanging wire over a microcatheter, the thing is keep microcatheter at the point. First, gently withdraw the wire, keep it in the tip, and then you re-enter with a new wire. So this is the way of exchanging wire using a microcatheter. Then IVUS is your eyes on the vessel. And I think one tool you should master if you want to do CTO is IVUS, because you can see the proximal cap, you can see the true lumen, you can see the size through which you can do. And I already discussed with you the IVUS dot test, which tells you whether your wire is in true lumen or false lumen. Some common pitfalls: if you don't use a hammer to swat a fly. So you don't need an elephant to kill a mosquito. So I think that is the important thing. If things are not moving well, think of support. Whether your support is okay, whether you can increase the guide support, whether you can use the extension catheter. I think that is important. If you are failing, then pause. Don't keep continuing. Pause for 20, after 20 minutes. Pause, reevaluate, think of a new plan, maybe do IVUS, change the strategy or call for help. Then in retrograde, I think you don't ignore the donor vessel, because already the other artery is CTO, and if you damage the donor vessel also, person will collapse on the table. Finally, your cheat sheet. First, plan is important. Your strategy based on hybrid algorithm. Then second important thing is support. You need to have a ATF support, even guide extension. Third, use IVUS early and often. Fourth, start with a very soft guide wire and slowly escalate. Maybe you can start with Gaia second also. Then another important thing is to support the wire using a microcatheter. Then know when to stop. I think that is very important. After 20 minutes, if nothing is happening, stop and reevaluate. And finally, as I said, protect the donor vessel. So I think mastery of this strategy and comfort level using this toolbox is what defines success in contemporary CTO PCI. Finally, to conclude, the strategy first is hybrid algorithm. Second is use of ATF guide and IVUS catheter. Third is use of a microcatheter like Corsair microcatheter. Then wires, you need to know your wire, you need to use them suitably. And then sometimes you may need to use intravascular lithotripsy, crossbows, stingray, etc. Thank you so much for your kind attention. Before I end, I will just say that this is the most rewarding field of interventional cardiology, but you need to respect the procedure, respect your tools, and always prioritize your patient safety. IVUS probe, Corsair, Gaia wire are the most important tools that you have, and ATF guiding catheter. So you build these habits now and you will become a safe and successful operator. Thank you. This is a book I wrote, so of complications in cath lab. Thank you so much.
Wonderful, wonderful talk, Sandeep. Wonderful talk. And very good takeaway points as well. That is, use a proper guiding catheter. That's number one. And use a guide extension when necessary. Number two. Have good idea of IVUS. That is very, very important for anybody. And then use the correct wires and the technique, and always know when to stop. That's a very good lesson. Great talk.
Thank you so much, sir. So with this, I would request Mr. Ashish Chinchole to please felicitate, sir. Please give a loud round of applause. Thank you so much, Dr. Mishra. Then coming on to next, I would invite Dr. Kannan to please be on the stage for a felicitation. Thank you so much. I would invite now Dr. A. Srinivas Kumar for the next session.
Okay. It's connected. Not coming. I think after those two exciting talks and on CTO, I think all of you will be geared up now, will be impressed and will have more enthusiasm to do primary CTO PCIs. After everything, I show few snippets here. It was not opening, but one thing which I thought every fellow should know is nowadays you should protect our health by ourselves too. Hospitals, managements may not be interested too much about your radiation protection things. I think. How many of you sitting here will wear your radiation badges? Yeah. I think even sometimes we also don't wear it because when we sent it, the measurement showed 0. That means you are not entering cath lab. So that occasional exceptions may be there. It's always good practice to have your radiation badges. I had some snippet pictures how to wear that. Where will you wear that radiation badge? Outside when the exposed portion or inside the radiation apron? Lead apron, huh? Inside the lead apron. And if you have two, you have luxury of two, you can have it one on your hand, outside it also, but preferably to have it inside the lead apron. And now, how many of you in the habit of it, I don't know. The lead aprons are to be given up because lead is very heavy. So now we have what is a modified thing called bismuth-based apron, which are very thin and lightweight. And protection-wise, we compared it with our nuclear medicine detector, radiation detector. It is much less. So many of you, once you go into practice, you can buy a bismuth-based lead apron, which is thinner and very less heavyweight. And one more new thing which has come is some small technique called G-lift, where it has a support at the back, and then nothing falls on your shoulders. If you have little more money, you can take that G-lift type of lead apron. These are simple things, and the lead apron, which all of you can do it. And the things, other thing is, when you're taking views and pictures, we did discuss about views. Whenever you're absolutely essential, only you go to LOOs and cranial views because that gives you more exposure, right? And always RAOs and RAO caudal views give less exposure to us. So they keep that in mind. Then how many of you are in the habit of acquiring fluoros and then fluorocine captures? That's a good way, again, especially need not do cines always. Do fluoro and acquire that. So that gives again less radiation. Then how many of you are in the habit of using 7 frames per second? You need to understand, be nice with your technicians, senior technicians in the lab, they will tell you. In CTOs where you don't need too high-end quality, you can put a 7 frames per second, and then that gives much less radiation. Only when the heart rates the heart very faster, you tend to take it into 30 frames. So normal thing what you use is 15 frames, right? So then these high frequency things, if somebody can afford it, all those what madam mentioned in Colombia is that things which come directly from ceiling suspensions and zero gravity, what they use in Colombia. And one more thing which has come is egg nest also has come in our country. But they're selling it at very expensive price. But apart from it, the personally what you can do, you can always do it. There's some of the tips I mentioned for radiation protection. And it is real because many of us neglect, and you have senior cardiologists who have succumbed to left-sided radiation tumors and all that. So we need to take care of your health too. And whenever you get exposed to more radiation on that day, you feel little feeling of when you get mild temperature, viral fever-like feelings. Also, you get when you get a long case. So that's why you be aware and protect yourself. With those tips and tricks on radiation protection during the CTOs, somebody requested to show 1 or 2 cases of Impella because nowadays that's a thing in acute MIs. Again, I keep telling that acute MI, sending patients for surgery should be last resort because it's not easy. And our surgeons also hate it because the mortality is high. Even to do punctures in multiple places, patients tend to bleed with antiplatelets. So we need to avoid it, and if possible, use a support and whatever forms it is available. And be IABP in many places, but 1 or 2 cases we had experience to use Impella, So I thought I will share with you, but always try to avoid sending patients to surgery, because unless there is a mechanical complication in today's era, whatever type of anatomy which you get, still you can avoid sending patients for surgery. You can do a culprit vessel PCI and then plans if required later. So this is a 83-year-old male gentleman, comes with hypertension, dyslipidemia, interval MI, ongoing pain. They don't come on time. This is the problem. If patient comes late, it is always a problem. The most difficult thing even today in primary PCI is patient coming late. If he comes on time, you can do a quick job and patient improves. If patient comes late, especially going into cardiogenic shock, stage A to B, echo shows severe dysfunction, angio shows left main disease. I hope they praise, I don't know. This is settling type, echo severe dysfunction, not moving.
Okay.
So then we did discuss with surgeons, and surgeon, I'll show you the angiogram in a minute. Then surgeon also felt it is high risk, is not willing to do surgery. That's where we decided to take its support and do it. Some of the talks which I didn't mention, the access yesterday, again, this access has come out important because doing the right point in the femoral artery, there's nothing great about it. Whatever thought before is the same thing applies even in structural heart era. The femoral artery, the point where you need to puncture is what is the main femoral artery. Don't do it below, after bifurcation, don't do it above, because the chance of retroperitoneal hematoma goes. You can identify that point better. This is the bifurcation point. You can have recorded some of the stuff if time allows, because we need to be strict on time again, because 11 a.m. We'll have Ramesh Dag participating on the match.
Okay.
On Zoom.
So
this is the
okay.
ultrasound-based method.
So now we are
Bifurcation,
trying to demonstrate
then you follow it, and then probably at that
ultrasound
point
guided.
you take it. You can actually do a.
So now we are
also
the
take
common
the help
femoral
of,
artery. Put it AP.
senior
Sometimes if you are
here
in RAO, you
on the
feel that
opposite side,
slightly above.
where we need
But I
to
think
do a
it is
puncture,
exactly
not
on the
below,
point
after
where the
bifurcation
femoral
is
head.
below. That's the same standard femoral puncture techniques, holds good even in the structural heart thing. There's nothing new about it. The other technique which people use is a roadmap technique. Whichever one you are comfortable with, you can use it. I did record, I think, one more
Going
other thing
to
is the
take
closure
a
device.
proglide inside
I think once you put a
for
wire,
for closure later. This will put in. This
take
we
the
are trying
closure
to
device,
put in
proglide. Some of you
two
must expose.
o'clock position.
We use two if it is a
Once
big
you are
wide
going
board.
in,
If it is a thin one, you can
you
run it
monitor
there.
to see that the
Once you're
blood should
taking
come
in,
out with a jet.
you get a
That means
rapid
it has
jet of
entered the
blood from
artery.
here. That means you have entered
Now
the
the jet is comes.
Okay. Once you
It
enter
is
the
more.
artery,
So now the
flow
jet is
flow
aggressive.
very good.
Now we
Then
remove
you
the
deploy.
wire.
Next step would be remove the wire.
Then
And you deploy the plate inside.
raise the foot plate up.
Of the proglide.
Then get it
So
back.
then you get it
That
out.
means now the foot plate is holding
anchoring
inside
the
the
artery
femoral
plate.
artery. Now the bleeding
Okay.
is also
At
stopped.
that point, you
Next step
press
is
the plunger.
to
The numbers
push the
on
plunger
the
in
proglide
so that
way. Press the plunger. That means
then
you
after
deployed
1,
the stick
2,
there.
3, then we remove
Then
this.
take it out. Get those.
Get
Cut
it out.
that, and then
Then
the plate has
close.
to be down.
Plunger down.
Then you get
Now
it
we
out.
want to get it
It
back.
has come out of the artery. Then there's a wire, whitish
And you have to be
marker
careful here
there,
to
because
get
we need
those
to have the
two
second proglide.
threads out.
Then we do this. Then after
And
the
the white
identifying
one
the
should
wire
be fixed
separately,
so that it doesn't
there's a
move.
white marker on the wire which
Then
we
once
not pull. Then the
we get it little more out, you get a
then you're
white
putting the
marker on the proglide.
second
You
wire
see that?
inside again, so
And
that is
then
white dot there.
we are advancing the another wire
After that is
so as to
done,
put another proglide. Because
then,
generally 13, 14 French, sometimes
to take
you
this
end
out,
up, you see that wire has gone all the way up. Close on. Okay.
after
Then
checking on
you
the
have now
flow,
secured the wire. Now we remove this
you
and
remove
take
this.
another proglide.
You have to apply pressure there.
You know.
Then we go on to the next proglide.
Another second
Then again,
proglide
you're
in.
taking the second
Now
one
we want to
inside,
do it in the
same process,
opposite
but
direction.
you turn it in the opposite direction so that you
So
get
once
a
it goes in, the
crisscross,
same thing.
not
Once it
inside.
enters the artery, you
Oh,
get a
not
good
both.
flow.
Now again, you can
Pulsatile flow.
previously
Then
that
remove the
marker
wire.
was this side, now the opposite side.
Then
Same
deploy the
process,
foot plate.
It goes into the artery.
Get it
Deploy
back.
the plate, pull it back. Once the
Once
plate
it is
holding
back,
it,
that means it's
then
anchoring
you
on
plunger
the
it,
wall.
the stitches
Then 1,
come
2,
onto the artery.
and 3.
Then again,
Then
get the foot
once
plate
the
down, remove
stitch
the
is taken,
wires thing, then get the foot plate down, and then
remove this.
you put a stiffer wire to cross. I think further things will be different from the structural heart. You get a stiffer wire from here to tower. For impella, again, this is important. Then from here on, that on the put an impella wire here, and then the wire is there inside.
Now this is a impella sheath which we're going in. This is a peelable sheath. Once you've dilated it properly, hopefully it should go.
Then after that, then
Where the wire go?
we put a pigtail inside.
Does it go?
That is just like any
Okay.
other routine pigtail
Where-
only, which comes with that also. Then that I will edit here. Then this is the impella
Comes
wire.
with impella. We try to
This
shape
impella,
it a
the
little
wire needs to be
so
slightly
that it won't
shaped
irritate the
once it
LV.
comes
It seems
And,
well with the LV. Now
Yeah,
we are
I feel
taking
there
that
should be some
stiffer wire,
improvement on
thin but stiff
taking that impella
wire
thing
through the
inside. When
pigtail.
you're
We
pulling
try
it
to
out,
place
you
it.
should be careful not to remove totally. Sometimes
Comes with impella. We try to shape it a little
gets
so
difficult
that
to
it
take
won't
inside.
irritate the LV.
It is a slight
It seems
shaping
well in
because
the
the wire
LV.
goes
Now
inside.
we are taking that stiffer wire, thin but stiff wire through the pigtail. We'll try to place it.
We are just
Comes with impella.
pigtail, what we have
We
put
try
and
to
taking
shape it a
the
little.
impella
so
wire
that
inside. Then after that,
the wire is left in the
pigtail is
LV.
removed after the placement. Now this is the impella sheath. This is how you
Now the port, that
inside.
small
And,
side
this is
port,
like any other
which is red
threading,
one,
the
we
thing.
put that wire
The
which we have
motor is
placed
here
in the
inside,
LV.
here.
Now this comes out.
This
So
wire
this is,
inside.
now this is, once you have the wire
Regular
secured, then the
process of
thin
14 French
sheath which
thing
we
is
had, we are
introduced.
removing it now.
And,
So that that
from
channel
here,
is, you have a wire. Once you
this is
remove this,
over the wire rapid exchange system, that wire comes out and this gets
Okay.
threaded
So now-
on that. So I think some of you who have already seen in your setup, so please ignore this. I thought for sake of everybody.
now we are trying to take the impella system
So
inside.
then you're taking the impella inside.
Kinda, Flora?
So steps are same. Then you position it. This is a impella thing and 2.55 and now you have CP. Then I actually wanted to show you this. I'll show you in one of the snippets. How does impella work? This small thing, how is it doing wonders? I thought I would check it once. I'll show you later. This is put in LV. This is coming into aorta. In spite of heart stopping, it produces a lot of blood back. It's not playing in this keynote. I will show you later in the snippet. Remember this. It gets spouts blood in a lot of spiraling fashion. So that's
measure
about
that
it, and you also
equivalent
need to check the impella
radius
position and
portion
how much depth from the
from the aortic annulus.
So you need to
It
maintain
has to be minimum of
at least a minimum
3.9.
distance of, 3.
Somewhere
Then
in between
again,
4.
you need to monitor that. This is after that, the impella
1.5,
control
1.7,
just
1.8 liters.
how much output you want, how much
Ah,
pressure
okay.
places. Will show you
Now
all
it
that.
became-
So that's how the impella placement is done. Then this again the standard puncture technique. What I showed is done in this patient. Then this we are putting it. Then impella was inserted. This in this patient, acute MI patient, this impella placement was done first. And then see this angiogram when what is taking. It's done with this. He has a critical distal left main. LAD was occluded. LCX again had a disease here. RCI I will show in a while that also had a disease. So a left main, triple vessel disease, cardiogenic shock, acute MI. So we thought we could take the help of the support system and do the procedure. Then both were wired. Initial dilatation, these are regular steps. I would skip for the sake of time. Wired both vessels, dilatation of thing, then again dilated LCX, both things are dilated. See the tight lesion opened up. That's the appearance after initial pre-dilatation, you got some flow. That's a lesion in LCX. Then further bigger balloon dilatations. For the sake of time, I think you all, the steps, basic steps, you know, dilated proximally. That is the thing which is being initial dilatations. You have the lesion that is known. That's a lesion in LCX2 where you can't avoid working on the left circumflex. So the initial stent always, this is a basic principle like anywhere, work on the distal portion first before coming proximal, because if you do a crossover, it might be difficult for you to take the stent in. So placing the LCX stent, though in principle we want to do the culprit vessel first, but the dilatations we did, flow is established and the impeller support being there, it's okay to do like that. But in acute MI, don't tackle the other vessel first. Then once this is done, then we started I think there are multiple steps. This is inflated. That lesion is done, come out well. So now we are working on the LED. I think for the sake of time, we can go to the, I don't know how it will stop. Then initial stent was put here. Then you are doing a crossover stent from here, left main to LED. And post dilatations, serial were done again. So this is the final part. See that without in between, without the impeller support, heart would have stopped here. The movement has slowed down. So that is the comfort which you have when you're continuously pumping with impeller. In spite of that, sometimes you could have some problems. So be careful in handling and avoid the too many dilatations. But the proximal part is a must. Again, when you're done through left main. So that is the result. Then we wanted to check how is the LCX ostium behaving. So we did OCT. You could argue saying that IOS could have been done, but that particular point, I think there was some issue in the lab with IOS. I don't remember exactly. That's the picture. Then we went on to right. The right had a straightforward lesion. Not to be done in routine cases, but because we had a supported with the primary impeller, we wanted to finish everything together. Then that is anyway straightforward lesion. We finished working on the right also. Khan, you can inform me whenever Dr. Ramesh is ready, we can stop. So that is once the procedure is done, then we remove the impeller immediately on table. That's another advantage. Once the hemodynamics are stable, you need not keep it longer. We can just pull it out. There should be some improvisation here also, I feel. You can't put the wire back in this present technology. You have to just pull it out because the soft portion, they claim nothing happens, but we are in the habit of putting a wire and removing it. That is not possible because over the wire came out from the side. You have no direct access to go into that. So then after that, it's pulled out. Then you close the sheath with the per close system, what I mentioned. Then this is removing here. This is after that, you have to close with per close and take a shot always in the end to avoid any constriction or narrowing on the femoral artery. And that's how I think a patient improved. And then there's no problem locally for the femoral artery. I think I said we did OCT on this patient, and after the proximal left main portion is what we were interested, and we could get good expansions and here, and then I have a picture of LCX ostium also, I think, where the ostium was okay, we did nothing for it. So this patient did well. But see the amount of material which gets consumed during the procedure. That's why the cost should not be a problem when you're handling such patients. And overall, the patient did well, and we could avoid surgery even such type of patients. So with this, I will stop here, and they'll be happy to take any questions. So what I want to mention to you is, so basically, try and avoid sending patients to surgery in acute MI. Can you get that snippets one? Okay, you can connect your laptop. How many of you have faced, we have 2 minutes time left. How many of you have? Anything is fine. Okay. How many of you are in the habit of sending patients to acute MI to surgery in your places? Do you send or you don't send? Nicole, though? Pura Nicole, then, no? You put that snippets open, the snippets. Yeah? Acute MI? Because when we were students, when we just started our career, it was routine practice to send patients of anything which was not like left main, you used to send for surgery. And then osteal LADs also, there are instances where people have sent for surgery. Nowadays, with the advent of good technology, and then not only that, we want to use the technology, but patients of acute MI surgery is not easy. In spite of the best centers, the mortalities of having acute MI surgery is high. If at all you're not comfortable with doing all that stuff at one go,
You can do a culprit vessel PCI and plan a staged procedure later. That's also an acceptable approach. Or plan surgery only you want because of more than 2 CTOs. There's a time where I think we still tend to send the patient for surgery. Then you can stabilize the patient with culprit vessel PCI and send the patient for surgery at a later date. Because acute MI first very system, the tissues will be very friable and it will be difficult for the surgeons also. Only exception is patient develops a VSD or acute MR. That is the place I think sometimes you tend to send the patient for acute MI surgery. Anybody has any difference of thoughts in this? Your instances where your surgeon is very good and is able to operate also, and but by the time the surgeon arranges every theater and blood transfusions, all that, the important time is lost. So that is why I think myocardium gets damaged already. That's why I feel this approach is a safer approach and should be followed. Any thoughts on this? I will show you some of my thoughts because you have time, 2-3 minutes of decision-making process in multi-vessel PCI. See this, can you project this? What I was wanting to show was that it didn't work in that system. So this is put in the LV, and I wanted to check how it is doing in vitro. So see that how much it is coming out from here. So LV it picks up and it gets empties into the aorta. Even if there's no contact, this is the first still starting again for you. See this. It's coming, picking up from here, and ejecting the blood here. So that is the thing which the small pump which is doing here. So that's how that it works so well. See that you can increase the speed, you can increase the number of liters of output. And it is all possible. See that how much thing it is doing here. So unless you see this outside, it's difficult to believe. And that's the technology is coming at a cost, unfortunately. But we're developing some alternatives, indigenous alternatives. We're a part of that government project. Hopefully something comes out. But this is a great help, but I feel it is a very costly, like bench car, it is very costly comfort while doing the procedure. So that is a challenge. But I thought this is a good way for you to understand what this small pump is doing. See that? How much generation of thing happens. I thought I would show you that. Then apart from this, this this is I wanted to spend 2 minutes time. Whenever he's ready, you tell me. So this is a patient's age is the most important criteria. Please don't send patients of 40 years for surgery, because by the time he becomes 50, he will repeat surgery, it will be very risk. Age of the patient is very important. Before retirement, no surgery. My colleagues keep joking that, what sir, you don't send patient before retirement, 3 months of time is lost for him. It's very precious. So maybe after 70 years, surgeons don't want to operate. What can you do? So the narrow window, about 10 years for us to send for say patients for surgery. Some of you could be coming from very strong surgical backed up centers. In India, unfortunately, how it is going is, if the hospital owns a surgeon is very popular, is dominant figure, then he goes for surgery. If cardiologist is dominating, comes for intervention. It should not be like that actually. That's why I thought I would just share the decision-making process in multi-vessel PCI. So CABG is preferable to the patients of age. Avoid it in young patients. Anatomy, syntax score is good. Only in high syntax score, sometimes still you have data. Now in low and middle range, you need not even discuss even if it is left main. More than 2 CTOs, and they are important big vessels. That's where I think they should go for surgery. LV dysfunction and significant mitral regurgitation, these are other places where CABG could be preferred. Okay. On the other hand, multi-vessel PCI, including left main PCI, could be done. Patient is young. So but these should be done only when the patient requests you. You should not force the things, because they should understand it is high risk, it is his disease, not our problem. So I send them, give them time, they should come back, the elective cases at least. And your operator comfort, expertise, what is possible in your place is also very important. So you need to understand, explain the patients the risk of 10% TLR, and image guidance is mandatory in these patients. And renal dysfunction, again, it was an issue before. Now I think is less and less bothersome to us because once we start practicing zero and low contrast PCI, IVAS guided PCI can be done. And complete revascularization should be always done as a priority. Please, just because you can want to avoid surgery, you want to revascularize one chota mota vessel of OM, don't do it. So these are some of the revascularization principles I thought I should do it. And surgery is again not easy. These are one of the patients immediately post to 1 year itself could develop into problems. So that one of the other things are there. I couldn't go into details, but some of you wanted to see this graft intervention, filter removal. This is a process where it is going inside. This I brought it as snippet to show you. Basically, the filter process, I don't know if you're able to see it. Light, can you dim this light? So this is a filter placement. And this side, the filter is open here. The graft intervention generally tend to keep the filter is opened and deployed here. You have to do it in the normal segment. Then after that, a regular process, stenting is being done. Ideally, you should prefer deploying the optimal size stent and just be okay with the nominal atmospheres. Don't go to too much high pressures because slow flows incidence could be very high if you go to very high pressures. So take a little more appropriate size stent to deploy it normally. And once that is done, then you take the sheath in again. Not that the filter should be pulled out. You take the sheath in, and the sheath should be taken onto the filter. Thread the sheath on the filter. So if you pull the filter back without taking the sheath in, you will embolize the material. So that is why I think it is important. I thought I could show you. And then if you want to, sometimes very rarely, but in life, sometimes you're forced to do, you might post dilate, but generally it is not advisable. Now you are taking the sheath onto it and remove everything en masse as one go. So that is the thing. Finally, I think that patient had a good result, and then procedure was done, everything is removed, and finally we had a good result. And for some of you, I thought I would share total interventions of NIC data. See this, that's a strength of our country. 9,81,181 PCIs are done. Enormous numbers, much more than entire UK VAL registry and other things. But unfortunately, we don't network among ourselves, don't maintain our data. Most of it is drug-eluting stents. And I'm happy that Apollo stands ahead of all because of a huge number of centers, 91,380 procedures at standard alone. And then stents-wise, we are not bothered too much, but imaging is coming up in a bigger way. I'm happy that left main imaging is picked up. Most of the cases of left main are done through image guidance, about 40% of them. Then PAMI, though data is very limited, it should be much more, but only 15% of our acute MIs go for PAMI according to this prediction. I think with this, I'll stop. And if Dr. Ramesh is ready, we'll go to his talk. Thank you. And any doubts you have, again, after we can have discussion. After Ramesh talks, Dr. Ramesh Ragupati's talk, we can have a discussion further. Thank you. Can you connect, Dr. Ramesh?
Yeah, I'm already on, Dr. Srinivas Kumar. Can you hear me?
Yeah, try. Thank you. Again, you see, many of you don't need introduction of Dr. Ramesh. He's already part of us. He is associated with us in many programs. His commitment to us and for education is in another program in Mumbai, but on a request, he agreed to do it. Extremely thankful to you, Dr. Ramesh, and he's great help for any meeting or program. And as he mentioned, now he's promoted as a professor and the chair of cardiology, chief of interventional cardiology in West Virginia University. He makes India proud there, and he helps us in training of a lot of our colleagues too there in US. So it's always important to keep good relation with Dr. Ramesh. Thank you, Ramesh, and over to you. The floor is yours for the yearly listen. This procedure is just started and picking up in our country, as you all know. So our fellows are interested to learn this technique, and we have later another talk for echo session that is different. But we'd like to hear from you. Mitral treat step by step. Over to you. Thank you. The hall is full, Ramesh. 200 fellows are waiting here to listen to you. Thank you.
Wonderful. Thank you very much, and great pleasure being with all of you today. Good morning, ladies and gentlemen. So I think without further ado, I would go ahead with mitral TEER step by step, because as you know that the Indian mitral TEER device has been approved, the MyClip from Merrill, as well as we have Abbott. Obviously that Abbott now is in G5. So 5 generations, and my clip is only first generation. There's still a lot more nuances that will make my clip much more user friendly. And the path is obviously already there. It is going to be a little bit cheaper than FDA approved devices. So I think that'll open up the window for many people to be treated with this therapy. And so, obviously, it's not easy to learn by yourselves, and that's why we are all available. This was one of the pictures that we took, and I just want to give our honor to Alan Cribier, who started off actually the entire transcatheter field. And around the same time, this gentleman is Fred Saint Gore. So he went to listen to a surgeon's talk, and Alfieri, the surgeon, was giving a lecture, and he listened to that lecture where he would just put a stitch in the A2 and P2 scallops of the mitral valve and reduce mitral regurgitation by creating a double inlet mitral valve. So then, actually, on the way back, he drew the entire picture of this device on a piece of napkin that they gave on the flight and on the airlines, and when he was flying back home. And so then he went back to Stanford and then actually went to that biomedical lab and gave them the design, and they created this device. So, he's in Palo Alto Medical Foundation. So Fred said Gore is the reason that actually we have this, and I had the pleasure of actually talking to him after my first MitraClip in 2009, and also met him recently last year as well. So this has evolved the generation 1 to now generation 5. Actually, I only wrote up to G4. G5 is also available. We are just bringing it into our hospital as well. And so there's great reiterations of this device and how the clips have changed in sizes and shapes as well. I mean, the shape itself is very much similar, but the size, and have 4 sizes now. NT is normal and NTW is wide. XT is extra long, or so, and then W is wide. So there are 4 different sizes that you can see, and so I think it's a very important that you can use either. Most of the time we use a XTW as in the United States. That's what is most commonly used, but it goes along with what your valve size is to start off with. If the valve size is smaller, then maybe an NTW would be good. So the difference between them is about 2 millimeters in the NT to NTW, 4 millimeters to 6 millimeters wide, and XT is also 4 to 6 millimeters. And the length is actually, the difference is about 3 millimeters from 9 millimeters, and from NT to become XT, it goes to like 12 millimeters. So you have to have enough leaflet length to actually use an XTW. So we measure on echo. They will talk to you about the measurement of the anterior and posterior mitral leaflets, AML and PML, and see what is the measurement on the TEE. And if it is more than 11 millimeters, then you can, sorry, up to 11 millimeters, you go with 9 millimeter clip. If it is 13 millimeters or so, you can go with XT. And so that is why we want to use a measure. Echo is very important in these. And so the setup is actually very simple. It has to be done under general anesthesia just because we use a TEE probe. If you think that it could be done with a 3D intracardiac echo, maybe we don't need it, but we are still not doing that even in our institution. Some institutions suggest starting up doing a intracardiac echo for even mitral tear procedures. So somebody with knowledge in echo is very important, whether it is cardiac anesthesiologist or echo doesn't matter, or echocardiographer, it doesn't matter, but they need to be very proficient in showing up the mitral valve and staying with us throughout the procedure, because it is a little difficult to a lot of strain on their elbows and their arms and holding the TE probe for so long, and sometimes the procedure can go for a couple of hours. And so my first MitraClip took me 45 minutes. The second one took 4 hours. So now we do it usually about 30 minutes to 1 hour with even if it's difficult and multiple clips, we could finish that. And as I mentioned, 3D TEE is very important as well. And please make sure before you start off with actually the investment has come from the management of acquiring a 3D good 3D TEE machine. Vascular access and radial artery is usually done to monitor arterial pressures by the anesthesiologist and to also check any ACTs or anticoagulation effects. And right femoral venous access for the procedure, we usually pre-close a vein with the one single ProGlide, or much cheaper is actually just put a mattress suture at the end of the procedure, which is a couple of cents compared to $250 for the single ProGlide. And so there are 5 basic steps. Number 1, transeptal puncture. To do any new procedure, we have to unlearn whatever we have learned in the past, because then, just because we think, oh, I have done thousands of balloon mitral valvuloplasties, I'm so good at transeptal puncture, I don't need this step. Unfortunately, that is not true. I'll tell you, if you don't have a good transeptal puncture, that's when your procedure will take 4 hours, or even at the end, you may not be successful. So good transeptal puncture is very important. And then position of the guide, and the CDS stands for clip delivery system in the left atrium, and we call it straddle. And the steering the clip delivery system towards the mitral valve, and checking the trajectory and clip arm orientation, and then leaflet grasping once you enter into the left ventricle. So these are 5 basic steps. So let's look at a transeptal puncture. Number 1 is appropriate location, and that will determine the success of the procedure. What do I mean by appropriate location? The height of the transeptal puncture above the mitral annulus has to be about 4 centimeters, plus or minus 5.5. You can be a little bit, if it is a lateral, it can be a 3.5 millimeter in height. It's okay, but if it is medial, you probably want to be more, gain more height at 4.5 centimeters. And so how do we do that? Similar to what, don't depend just on fluoroscopy. I actually don't move the fluoroscopy C-arm at all. I just keep it in AP view, and go with your femoral venous access. Advance your whatever wire that you use into SL1 catheter or Mullins, whatever catheter that you use, the wire that comes with, which is a 0.32 wire, I think, and then advance into the SVC, and then under TE guidance, pull it back. Ask the TE person to actually put bicable first and then explain. So it is actually the opposite way as what you should, but at least you should have a short axis where you see the aorta, and that's the septum, and this is bicable view where you can see that the needle is right here. And once you are confident that you're in the mid or slightly inferior in the fossa, and actually posterior on the fossa is very important. So if you could still go a little bit more posterior here to gain more height, actually maybe that point would be much better. And then once you are confirmed in this position, you go into a 4-chamber view to look at the height. So, but let's look at what are these. These are fossa that actually shows that there's multiple ways of puncturing it, and slightly mid to inferior and posterior. It would be ideal for more posterior would be ideal for the mitral tear procedure. So, whereas this is for PFO closure, whereas it is superior. And for pulmonary vein isolation procedures, you go more in the mid and anterior, and in the mitral clip is more posterior. And mitral valve replacements, transcatheter mitral valve replacement, valve in valves, or tandem heart and septostomy, you go right in the middle. And for left atrial appendage closures, we go for actually inferior and posterior. So this is the FIOPS or whatever your CT that you have can tell you exactly where to puncture, but unless you have a echo nav that where you can CT navigators and or C-arm, it is very difficult to know. So I think this is just nice pictures for us. Do I use it? No. Okay. In our lab, we don't have that echo or a CT navigator yet for each and every lab, so we don't use it. So as we said, go from IVC up and go a little bit mid to and posterior, and then so that you can come much much more perpendicular to the mitral valve. Okay. So otherwise, you can use a radio frequency wire. As you can see, we got the femoral venous axis. We're advancing this radio frequency wire, which has a curved tip, and then advance the catheter, which is similar to SL1. And then once you're in confirmed, you come out and deliver radio frequency energy to cross the septum, and then just 1 to 2 seconds of radio frequency energy, and advance that the pigtail into the left atrium. So, and then confirm before you advance the dilator again. You can still confirm here on the TEE with whether what is the height that you have, and you need to make sure that you're 4 centimeters above the mitral annular plane. And so the height of the puncture, as I said, again, it's very important. This is how you measure on the mitral annular plane. And this is if you're tenting. From the tenting point, draw a line from there to the free wall of the left atrium. And right from the middle, you can draw a line up to the mitral annulus and measure that distance. And that distance has to be about 3.5 to 4.5 or even 5. And so if it is secondary MR, it's okay to be slightly lower, less 3.5. And don't go below that. And if it is a primary MR, 4 to 5 centimeters is actually very good. So again, we show that transeptal puncture. Sometimes after you do a transeptal puncture, the sheath won't follow. Usually this will happen in a patient who had a prior ASD repair by surgeons, and they put some material there, and then it won't. And so then you have to use a dilator, which you already have in India, very easily available, the Inouye dilator. For us to open up that just a dilator, it'll be very expensive. So we sometimes actually, rather than Inouye dilator, we can actually do a septal balloon dilatation. So, and still, this happens very infrequently that Inouye dilator doesn't work. Then use a 6 millimeter by 4 centimeter a peripheral balloon and dilate the septum with that way, And once you dilate, now this is a 21 French cannula that sheath. You remove the SL1 and everything else other than the wire and the ProTrack wire or the Jalebi wire in the left atrium, and then advance your under fluoroscopic guidance of the sheath first into the right atrium. There's a negative and positive guide turn on the guide that you can remove that and be neutral, and then you advance it into the left atrium. And so this is the tip of the guide, and then you advance through the guide this clip delivery system. So this is a clip, and this is called clip delivery system, and it goes through the guide. And when you get these radio opaque markers on the clip delivery system on either side of the guide, tip of the guide radio opaque marker, that is called straddle. Okay. So it's 24 French guide system, and the clip delivery system is slightly smaller. So this is the radio opaque marker of the guide, and CDS has 2 markers on either side. That's straddle. This is important just because every deflection we want it to be here, so that now there are a lot of knobs that you play with, and that will make the catheter bend medially, laterally, and also A knob and P knob that we have to put on the guide catheter, anteroposterior as well. So once you're in the left atrium, make sure that your tip is clearly visible in the left atrium, and so that you're not in the pulmonary vein. If you're in the pulmonary vein, that means you're too deep with the guide catheter. Withdraw the guide catheter in the short axis of when you look at the aortic valve. You can see where the guide is, and so at least keep it about 1 centimeter from the atrial septum and in the left atrium, and then you should be able to have enough room to flex. And if not, you can pull it back into the right atrium, and then once you start flexing the guide into the right atrium, clip is still in the left atrium, then you start flexing and then re-advance the whole system. Okay, so there are certain things that you have to do. So how to steer towards the mitral valve is using the M knob or medial knob, So that is the deflection that actually continuously you clear up the Coumadin ridge and continuously watch under TEE and also on fluoro to make that movement. And if you get stuck, that means you're probably in the pulmonary vein and you have to pull it back. Make sure you don't poke into the left atrial appendage as well, okay? And so once you steer and then you can actually look at it in intercommercial view, whether you should be medial or lateral, and then and also explain that and to LVOT view as well. So using going into intercommercial view or bicommercial view first, and then explaining that will give you the where you should be. And or we immediately, some of us go into 3D TEE, and 3D TEE will keep the aorta at 12 o'clock, and this is the anterior leaflet and posterior leaflet. And so you have to be very nice and planar, because otherwise any tilt in the TE will actually take you at an oblique view and not looking at exactly on a planar level of the mitral valve leaflet. So this is what the clip arm orientation is. Here it is at 11 o'clock, and when we say 11:05, that means it's this way, and you want it to be more 12:06 and to be perpendicular to the mitral annular plane. And so this is a mitral annular opening, and you have to be perpendicular to that. So 12:06. And here, as you can see here, it is more posterior, and then you have to push it to make it more in the middle by certain changes, which is you can achieve that by actually turning the guide posteriorly, which is actually clocking the guide away from you. So that I'll show you in the next one. Okay. Okay. And so again, this is anterior, and you want it to be posterior in the LVOT view. You can see aorta is here and posterior mitral leaflet is here. This is directing very close to the anterior mitral leaflet. You want it to be here, and that you can achieve by clocking the guide catheter, which will be a posterior torque. So this is the guide catheter, which is 24 French, and it says A and P here. It will tell you the direction, meaning if you clock the whole guide away from you and clockwise rotation, it'll be posterior. If you clock the guide towards you, meaning the Abbott sign comes towards you, it'll be anterior rotation. So as I showed you in the previous two pictures, you have to clock the guide here to make it more perpendicular and towards the mitral leaflets. And so the sheath, the guide ends here, and this is the clip delivery system. We introduced the clip delivery system, and this is the box that has two knobs. One is medial and lateral. You clock it, meaning there's only one way. Right side turn, it makes it M knob, and maybe letting it go will make the lateral knob. And on the top one is A and P. We don't use it that much. It is to gain some height. We use that, and so whenever we use that, there's a lot of changes that will happen, and there's too many bends in the clip delivery system that makes it very difficult to use it. So try not to use that as much as possible. Okay, in the first 50 cases, I would not advise to use that. And then the catheter, delivery catheter handle is right here. That is screwed very tightly here with this black screw. You can unscrew it, and you can make sure that whatever you want to transmit, it takes a little bit time from all the way that any movement here will take a long time for it to be transmitted to the clip. So wait for some time, and you might have to repeatedly do the movement back and forth so that it is transmitted. So remember I said 11:05 and versus 12:06. If you want the catheter to go from the clip to go from 11:05 to 12:06, you actually want to clip delivery catheter handle should be counterclocked or clocked, depending upon where it is. From 11:05 to 12:06, you have to clock it, the clip delivery system, and then go back and forth so that it is transmitted. Okay. So that's what, and there are two lines here, and these are called, that is the gripper line. And so the grippers are there, and this is the lock lever. Lock lever, you have to unlock and lock it to actually, and these knob to open and close the clip arms. The clip arm comes closed like that, and you open the lock lever, and then turn the white knob away from you, so it opens. I mean, it closes. It turn the white knob towards you, counterclock, it opens. Okay, and away from you, it closes. So So all those will be very nice and easy to learn actually. And so once your trajectory, meaning when you introduce the valve, the clip, it should go towards the valve right in the center. Okay, the valve leaflets are here, opening and closing. It should go right in the center. It shouldn't go that way. It shouldn't go this way. It should go right in the center. And that actually you can see both in intercommercial view as well as in LVOT view. And in the intercommercial view, your clip should be, the clip arms should be one on top of the other so that you shouldn't see any clip arms. In LVOT view, you should see the clip arms actually up like this. So they're going to come down. Your clip arms should be very visible in 120 degrees on an LVOT view. And then you make sure that that they're generally splitting the regurgitant jet. So without fluoro first, and then check on, without color, and then put on color and see if you're bisecting the jet right in the middle. And that means you're actually very good. And there are small changes that you can make. And if you want to go laterally, you can push the whole device in, guide catheter in. And if you want to come, medially, you can pull it back a little bit. So we talked about the guide catheter. Clockwise is posterior, counterclockwise is anterior on the guide catheter when you torque it. And the clip delivery system, we talked about the M knob and L knob, medial and lateral, and the clip delivery system as well. And so you pull system in or out to go, as I mentioned, laterally or medially. You pull it towards you out, it'll become more medial. So then, so here is the one that I showed you that I told you that intercommissural, medial, lateral, and LVOT view, posterior, anterior. And here you are checking that it is a bit medial and it is right in the middle. You can see the clip arms here. You don't see the clip arms here. So that is how it is. And if you're on fluoro, actually the clip arms also will not be visible like this. That means you're in AP view. That means you're on the right position. And okay. So that means you're perpendicular to the plane of the mitral plane. So here you go. You can see that you're slightly medial and A2P2 is nicely felt, and 12.6 is the way that it is, and put color, and so that you're bisecting the color jet. Where you should be determined by where actually the prolapse is or where is the MR jet coming from, even in functional mitral regurgitation as well. And so then you push the clip delivery system into the left ventricle in 1 to 2 heartbeats, or actually you can close it and gradually go in. And then once you're in, the clip arms are like that, and you pull back, making sure that posterior mitral leaflet and anterior mitral leaflet are falling on each other in the LVOT view, and wait for it. Don't have to drop the grippers immediately to grasp the leaflets. Do it slowly. And you can now, with the new generation, you can put posterior separately, anterior separately, but then you can tilt it. So you don't want to tilt this way or that way. So just wait and patiently, and you can hold the breath or reduce the tidal volumes to 200 and make sure that you're in the right position, and drop both grippers at the same time so that you're not causing any damage to the leaflets. And only if you're happy, drop the grippers, because these leaflets in elderly people are very fragile, and repeated dropping and grasping and letting it go can actually tear the mitral leaflets. I have another picture for that. Okay. So once you, the assessment following a grasp, take your time, look at whether both the leaflets are quite well captured, and then only you can actually tighten the clip to make sure that they're creating a bridge, just like Alfieri stitch. So make sure the leaflets are inserted, reduction of mitral regurgitation, and then check for residual gradient, and then only decide whether you need a second clip or not. So these are the grippers. The grippers are like fish hooks, and don't think that they're very smooth. And with the mitral clip, they're like really can be damaging. With Pascal, there are less number of clip arms. I mean, the fish hooks are only 2, and so maybe less damaging. We don't know that yet, So here is probably what you want to see. So here the posterior mitral leaflet is falling on it and anterior leaflet is on it. And so patiently wait here, confirm, and then the grippers are on this part right here, and they have to fall on it, okay? So that is the grippers. Once we drop the grippers, so the leaflet is here, clip arm is here, and the gripper is on. So the leaflet is in between the gripper and the clip arm. So that is anterior mitral leaflet. This is the posterior mitral leaflet. And you can see that it is very convincing, and zoom in on the TEE to make sure that you're very clear with that, okay? On cine fluoroscopy, so you can, again, if the clip arms are visible in AP view, that means you're not in the right way. It's probably, unless the patient's anatomy is really changed, but you can see the grippers are here as well. So, and so ideally, this is still acceptable, but depending on TE findings, you proceed not just fluoro, and fluoro could sometimes be fooling. And when you put a second clip, you can usually try to be the medial clip first, and so it is laterally, it is easy. That's what I would recommend. So if you have to put two clips, put the first clip first. I mean, first clip medially. How to gain height, so these are the special things that I said, don't do it for the 50 cases. And after that, you can start applying a knob and to bring the clip back to you can AP axial alignment, and put also posterior on the guide. So posterior on the guide, A knob, and then put an M knob. So there are three things that you have to do to gain height, just because our transeptal puncture was not good. If our transeptal puncture was good, all these things you don't have to do it. So make sure your transeptal puncture, you spend a lot of time to do that. And how to lose height, and opposite. You go anterior on the guide catheter and put P knob on that one on the clip delivery system, and then assess the medial lateral. So you might have to apply M knob, or you have to let it go based on where you are on the echo. So sometimes we do very anterior stick, and it's called an aortic hugger, and that is actually a big problem, And aortic huggers, and you have to put a lot of positive plus on the guide, and antero-posterior guide torquing that you have to do, and then putting an M knob, and then you have to advance the whole system or pull it back. So I think these are all the things that we want to avoid, and that's why I said transeptal puncture is very, very important. Take your time, even if it means 45 minutes, then do it. And then we take only now 5 minutes, but in the beginning we would spend a lot of time. If it's not in a good position, re-stick. And so once you do all of that, the whole thing becomes much easier. And as you can see here, there's some prolapsing segment, and the MR can be reduced after one clip in the NTs right here in A to P2 position. And so the mitral clip is very good, and regurgitation has come down from severe to mild, 1+. Hemodynamics, people can actually put in a pigtail and another transeptal, or right next to it, LA guide. But now the guide itself has the ability to get direct left atrial measurement. So with both the G4 and G5 systems, you don't have to do that. So here's the first few cases that we did, LV and my left atrial measurements. And you can see that the V wave has come down significantly. And so, and after that, you remove the whole delivery system. And there are certain things that I didn't tell you actually, is that once the clip arms are closed and very tight, and you have to deploy the clip, the lock lever has a thread that goes through and through to the entire system and comes out like more than 300 centimeters long. And so that lock lever has to be opened. You separate the strings that are there, and you pull on one string completely. And so that if you use the Gore cardiopharm for closure device similar to that, you keep pulling the string and it'll come out completely, and gently, and under TEE and fluoro guidance. And once you're done that, you test your lock lever a couple of times to make sure that the lock is intact, and then I mean the clip is intact. The clip is not opening when you let it go, and raise the grippers and you take out the whole system. So once you take out the system, and obviously those are the things that I think sometimes I would say initial 10 at least you should do with the proctor, and then you remove the whole clip delivery system and apply either perclose or a mattress suture, and for radial just pressure tape. What you can't treat is all these types of degenerative mitral regurgitation. Just ask the surgeons to help you out with these type of lesions. So in last slide, I think to master mitral tear, you need a commitment, and I think strong technical skills will come. It's one of the actually safest procedures in my opinion, as long as you follow the steps very clearly, and critical thinking abilities and patient-centered approach is important. Not every mitral regurgitation can be treated with this. And obviously, I think, I would always recommend training, proctoring, and preceptorship for these type of lesions. So take-home message, mitral tear cannot treat all patients. Knowing anatomy of the mitral valve helps in choosing the right therapy. And summit trial actually is completed, and the mitral clip or tendine, we will know which one is better soon. And we are participating in primary MR trial or repair MR, which actually addresses surgery versus tear in low and intermediate risk patient. Right now, it is approved for high risk, extremely high risk, and inoperable patients. And but we are trying to evaluate the same thing in the low and intermediate risk patients as well. And so we have to wait for those results, which will come out probably in 5 years. So, yeah, I'll stop here, and I'll be happy to take any questions and sharpen your skills every day. Yeah.
Yeah. Thank you, Ramesh, for an excellent talk and explaining every step by step to all the fellows here. I think most of them had a fair amount of idea now. I think some of them could have been exposed already to this procedure. And now that you mentioned in between that my clip or New Indian, are you able to hear me?
Yeah, I can hear you. Yes.
Indian version of it is coming. Are there any particular differences between that one and what we have already?
So just I think I used about 3 or 4 of the mic clips as well. And just because it is first generation, it takes some time to warm up. And so it's not as smooth and flexible as Abbott mitral clip, which is the 4th or 5th generation right now. So I think the material that the device is made with, or whatever the knobs that they have, it takes you clock it on the M knob, and you have to wait for some time for it to be transmitted, and then you might have to let it go a little bit. So I think for first generation, it has been working quite okay.
Regarding the Pascal thing versus the Abbott clip, Mitra clip, which one? There's some advantages I was told.
Yes, yeah, I'm using a little bit more Pascal for people with the smaller annular area, because the gradients are slightly lower, and also in elderly fragile leaflets, Pascal is probably better because it doesn't have that risk of tearing the leaflets, because too many hooks are available on the mitral clip versus Pascal device.
Thank you, Ramesh. I think we have Satpati madam, and we have a hall full of fellows, and Cecily madam will talk about echo criteria selection. Any questions? Because Ramesh has to leave for another conference. So thank you again for your time.
Thank you. Thank you very much. Thank you, everyone.
As the people are less exposed to this, I think there are less questions. But thanks for your time again.
Thank you, sir. Thank you.
Thank you. I think we can have a.
Thank you. So we'll now break for a short coffee break for around 10 minutes. So I would request everyone to please join us back within 10 minutes.
ఇదే కదా పిక్.
Welcome back, everyone. And I would request everyone to please take your seats. Next, to give an Indian perspective on the MITRA clip, we have with us Dr. Cecily Mary. So Dr. Cecily Mary is an interventional cardiologist, and she has been done many interventions, more than 6,000 angioplasties, 300 pacemaker inclusions and all. She has also been awarded the Best Paper Award at ESC Congress 2023 by the ESC President, International Best Paper Award for Cardiology at the World Cardiology Congress. She has also authored more than 30 chapters, more than 50 presentations in various international and national conferences. Over to Dr. Mary.
Respected senior faculties, respected seniors, dear colleagues, and dear students. I think the topic after the great legend, Dr. Ramesh Daggubati, so who is one of the pioneers in MITRA clip and tower. I think it was some slides may be similar, so I'll switch over such slides. So a small overview for the students. MITRA clip, the current status. So we have what is the criteria for selection of MITRA clip? The transcatheter edge-to-edge repair. So in secondary MR, what are yes, the QAP criteria. So these are secondary MR patients who have optimized heart failure treatment according to the 2021 guidelines, ESC guidelines. The NIHA functional class 2, 3 or ambulatory 4. And the LV ejection fraction between 20 to 50% and an LV end diastolic diameter less than 70 millimeter and at least one heart failure hospitalization within the previous year or an increase in natriuretic peptide levels. Anatomy judged suitable for transcatheter edge-to-edge repair of the mitral valve. And what is no, in which patients we cannot take them for mitral clip? It is the hemodynamic instability patients, patients with stage D heart failure, patients with moderate or severe RV systolic dysfunction, and the systolic, the pulmonary artery pressures are very high, more than 70, COPD requiring oxygen or steroid therapy, coronary aortic tricuspid valve disease requiring surgery, and patients with hypertrophic restrictive or infiltrative cardiomyopathies. But now recently, slowly HOCM is being considered for advanced TER procedures. It is recently but hasn't come into the guidelines. So how are we going to take up these patients? Almost the Euro secondary MR registry, which consisted of 1,676 patients with secondary MR undergoing transcatheter edge-to-edge repair for around 10 years between 2008 to 2019. So we have two criteria, important criteria. One is the adapted QAP inclusion criteria. The other one is the MITRA FR inclusion criteria. So in this, I've already mentioned about the QAP criteria. It is very essential that the RV function is normal, the TR grade is less than 3+, the systolic pulmonary artery pressure is less than 70, and the LVN systolic diameter less than 70, EF of more than 20%. Whereas in the MITRA FR inclusion criteria, the functional class more than 2, here the EF is more than 15%. But the two important differences in the MITRA FR criteria is they have taken the regurgitant volume more than 30 ml per beat and the effective regurgitation orifice area more than 20 millimeter per meter square. So what is the difference between these two? So in contrast to those used in MITRA FR, adapted QAP enrollment criteria appear to be adequately identify the specific phenotype for patients with secondary MR with lower mortality rates with MTER. So now we come into the newer concept. What is the disproportionate MR and proportionate MR? Until now, we always talking about primary MR and secondary MR. what is proportionate MR and disproportionate MR. So this disproportionate MR is the MR which is going to be benefited more with your transcatheter edge-to-edge repair of the mitral valve. So what is the difference between proportionate and disproportionate MR? That is, we find the ratio between the regurgitant orifice area to the LV end diastolic volume ratio. The higher the ratio, the more disproportionate is the secondary MR, which means if it is disproportionate, the valve is more involved than the ventricle. Therefore, these patients benefit more with mitral clip. Whereas if it is proportionate, that is the ratio is less, the ventricles are more involved than the valve. Therefore, they do not benefit much from the transcatheter edge-to-edge repair. I hope I'm clear with this. So remember this disproportionate MR, this was more included in the QUAP trial. That is why the patients of the QUAP trial benefited more than the mitral FR. So we have to remember disproportionate MR, we have to echo-wise, we have to assess the regurgitation orifice area ratio and the LV end diastolic volume, the ratio between the two. If it is high, it is disproportionate. They are more suitable for TER. So that is why it concluded that they have better outcomes following TER. So now coming to primary MR. So primary MR, the subgroups of primary MR could be grouped by the Carpentier classification as either leaflet damage, perforation, or excessive leaflet motion, which could be identified by the echo. So the Everest 2 trial, patients with primary MR were included and demonstrated a non-inferiority of the mitral clip procedure. The major inclusion criteria for the primary MR is EF between 25 to 60% and LV systolic dimension less than 55. This is for primary MR and the regurgitation jet caused by malcoaptation. However, multiple echocardiographic exclusion criteria is the orifice area less than 4 centimeters square, mitral annular calcification, and evidences of intracardiac mass. So we know secondary MR, primary MR for which it is suitable. Now coming to the guidelines, the ESC and the ACC, how do they differ in each? The green suggests both are concordant. Both the ESC and ACC are concordant in their opinion, whereas the red suggests they are discordant in their opinion for primary MR and secondary MR. So mitral valve surgery, if symptoms for primary MR is class 1, repair if asymptomatic and LV dysfunction class 1. Both ACC and ESC have accepted repair more than replacement. And TER for high-risk patients, 2A according to the American guidelines and 2B according to the European guidelines. For secondary MR, mitral valve interventions if symptoms after goal-directed medical treatment and surgery, if mitral valve surgery, if symptoms and low risk after GDMT. So, but mitral valve surgery, if symptoms at time of CABG is class 1 according to the European guidelines and 2A according to the American guidelines. Transcatheter edge-to-edge repair, if symptoms and ineligible for surgery in European guidelines is 2A versus no surgical consideration, only anatomy and QAP criteria is 2B in American guidelines. So coming to the major inclusion and exclusion, considering all these things, the QAP and the Everest 2 trial, the major inclusion criteria is the primary regurgitant jet originates from the malcoaptation of A2 and P2 scallops. The major exclusion criteria are the mitral valve orifice area less than 4 centimeters square, width of the flail segment more than 15, or the flail gap more than 10 millimeter, coaptation depth more than 11 millimeter, or a vertical coaptation length less than 2 millimeter, severe mitral annular calcification, evidence of calcification in the grasping area of the mitral clip between A2 and P2 scallops, presence of significant cleft between the A2 or P2 scallops, prior mitral valve surgery or valvuloplasty, echocardiographic evidence of intracardiac mass, thrombus or vegetation, a history of active endocarditis or rheumatic heart disease, and a history of ASD or PFO associated with clinical symptoms is very essential to exclude for TER. I think you should keep this in mind while looking into the echo of these patients. So the ideal versus non-ideal mitral TER candidate. If the patient is not a candidate for surgical repair, then we consider for TER. So a central focal jet, not much chordae in the grasping zone. Leaflets should be pliable, non-thickened, more than 5 to 6 millimeter length in the grasping area. Focal prolapse, it should be a focal prolapse, not like the complete Barlow syndrome where the A1, A2, A3, P1, P2, P3, all the scallops are prolapsed. That is non-suitable. That is suboptimal TER features. Optimal is a focal prolapse, A2, P2 prolapse, flail with apical tethering and large orifice area. These are suitable for TER candidates. Suboptimal is broad commissural jet, prominent chordae present in the grasping area. You should keenly look into these features in your 2D, 3D echo or multiplane imaging, and presence of mitral annular calcification or leaflet calcifications, particularly in the grasping area. TER should be ruled out. Thickened leaflets following rheumatic or valvulitis, Barlow syndrome with disease with diffuse jet, less than 5 to 6 millimeter length in the grasping area, and a small orifice area. These are the conditions. These are not ideal candidates for mitral clip or TER. Here we are showing a large mitral regurgitation jet. We know the evolution of the mitral clip. Sir has discussed about the NTR and NTW and XTR and XTW in detail. So what is just one few lines about the mitral clip generation 4 system you're able to see in the end. See, all the components of the new generation mitral clip G4 system, they have two independent gripper levers, allow for independent grasping of the mitral leaflets, includes 4 sizes, the NT, XT, NTW and XTW, offering for patient-tailored mitral valve repair. So all these things are the important differences. These are the different positions of the mitral clip. Now coming to the 3D echo, a multiplanar reconstruction is very essential for visualization of the mitral valve. Most of the structural interventions, I think we need a good pre-procedural as well as intra-procedural 3D echo or even a 2D echo with multi-planar imaging so that the different axes should be clearly visualized. That is how we can ideally deploy the mitral clip. So accurate localization of the leaflet pathology and the precise assessment of the regurgitation severity. So this is you're able to see in this video a multiplanar reconstruction of the 3D database. So demonstrated direct planimetry of the double barrel mitral barrel orifice we are able to see. And this is a pre-procedural imaging of the mitral regurgitation. When we do a TE only, we are able to, sometimes we miss this eccentric mitral regurgitation. This patient has got 2 jets, one the central jet and an eccentric jet. So the different steps of the mitral clip, sir has very well dealt in detail. So I'll just, a few points extra which has to be added as, always remember the ideal puncture site, as sir has mentioned, is more superior and posterior. And it should always, apart from that, it should be high and posterior. Apart from that, it should be 4 centimeters above the mitral plane. That is very important. So in TEU, the images we have to see, this is the bicaval view we are able to see. It is more superior, it is more higher. Then in the short axis view, the aorta is the anterior structure, the pulmonary veins are posterior. So here it is, you should be more for a anteroposterior positioning, you go for the short axis. First the bicaval view, then the short axis view, then the A4C for assessing the height of the puncture site above the mitral plane. Here you are able to see the pointing the septal puncture needle. It is 4 centimeters at least above the mitral valve. Why is it very important? So this puncture site is essential. So you look into these 3 views because this puncture, it's a big, the valve has needs lot of room to enter into the LA from RA and then across the mitral valve. So for this this trajectory to enter into the mitral valve, we need a lot of space and room. So the puncture should be 4 centimeters above the mitral valve plane, and it should be superior and posterior. So while entering, you have to be careful. As Sir mentioned, we should not enter in the left upper pulmonary vein, but still the position should be focused towards the left upper pulmonary vein and LA plane, but should not enter into it. The trajectory should position across towards the left upper pulmonary vein, but should not enter into it. So, and always remember, if there is a PFO, don't go via the PFO because we think it's easy. Already there is a septal PFO is there for PTMCs. If a PFO there, we can go across the PFO, but it is not so in the mitral clip. Always, even if there is a PFO, you do a separate because the PFO is in the almost in the center. So we have to go high and posterior. So don't go via the PFO. So, and taking the steps, I think Sir has explained in detail. We'll be able to negotiate it. One important thing, as Sir mentioned, is if there is a difficulty, if the septum is very thick, so Sir said we can use the septal puncture, we can use RF ablation also. That we do for PTMC also. The one other important technique is ensure that adequately very stiff wires are used and sometimes control to and fro, anterior and posterior rocking movement of the system can be applied to help advance the guiding sheet. If this doesn't work, options include a long dilator advanced to the septum or a balloon dilatation of the septum. Once it is confirmed, then always confirm with a 3D echo in such situations. It is very helpful. And then you can go across the septum towards the left upper pulmonary vein or the LA appendage towards that, but don't enter into the left upper pulmonary vein. Then ideally tracking it, everything I've already mentioned. I think Sir has described in detail the delivery of the device. Then the clear steering down the mitral valve and pointing towards the maneuvers to be performed, as Sir has explained in detail. And one more important thing is the images. Once again, we always cross-check all the views, and advancing should check the mitral clip trajectory. That should see the mitral clip advance downwards and ensuring it stays always in the desired path where it has to enter, and always confirm that. And then only this LVOT view also in TE is a very helpful view in echo to confirm the position of the devices. Then the 3D echo. First, it is between the 10 o'clock and 4 o'clock positions in 3D, but the ideal positions would be between 12 o'clock and 6 o'clock positions, but it is tailored for each individual. So the role of echo in mitral clip is very, very important. Though the fluoroscopic images helps us, 99% it is decided by the 2D and 3D echo, as well as important the transesophageal echo from the puncture to the delivery. That is why I am repeatedly enforcing on that, and the pre-procedural workup that there should not be any calcification. The grasping tips, that places should be free of calcification, adequate commissural length. Everything is very essential. So the complications following mitral clip, vascular complications could be, it's not always easy. Once the procedural, we feel everything is fine, the complete procedural success, the patient should go back safely and should come for follow-up with good reduction in MR. So vascular side, dissection, stenosis, thrombosis, perforation, AV fistula, pseudoaneurysm, hematoma has to be ruled out. Since we are doing a septal puncture, there is a risk of ASD always, and any perforation, pericardial effusion, tamponade, pseudoaneurysm, bleed, all those things, and any there is always a risk of stroke, MI, and acute thrombus formation. Device related, there could be MR, residual MR, mitral stenosis, That could be device embolization, rare, leaflet perforation, leaflet tear, caudal rupture, clip embolization, infective endocarditis, new onset of atrial arrhythmias, acute kidney injury. And as we evolve, now we have the FDA approval for the Pascal device, as rightly asked by Srinivasan sir. It has been approved FDA. Though there are many devices in the pipeline, the Pascal device, as students, you should know, because the newer device which has got the FDA approval in 2022. So the retrospective studies in 2020 and between 2020 and 2022, the safety and efficacy of TER in atrial secondary MR, severe mitral annular calcification, TER in ring, and commissural MR. Commissural MR, sometimes we get following post PTMCs. So these MR are also being addressed and studied. So the Pascal system has received the CE mark approval for the treatment of MR. Just a short notes, if suppose they ask you, you should be able to write it. So the safety and feasibility in the CLASP study in patient population of functional degenerative as well as mixed etiology, the procedural and clinical success rate was 92% in functional and 87% in degenerative MR. There was reduction in MR grade from 3 or 4 plus to less than 2 in 98% of the patients and less than 1 in 86% of the patients within 30 days. The 1-year outcomes are very promising in the CLASP study, demonstrated a high survival rate of 92% for the overall population and 88% for functional and 96% for degenerative MR. Another newer system is the Carillon mitral contour system. The distal and proximal anchor are implanted. Here they implant in the great cardiac vein as well as the coronary sinus respectively. That is the proximal, the distal is in the great cardiac vein and the proximal is in the coronary sinus. The implant is designed and to be deployed tension and secured. The reduction of the MR is immediate. The others, it takes some time, at least 1 month in the Pascal system. Here in the Carillon system, it is immediate and the results are modulated during the procedure. The other system is the R2 system. Here the coronary sinus is cannulated from the right IJV and a T-bar implant is deployed in the lateral wall via the great cardiac vein, and the atrial septal implant is deployed through the transseptal puncture and a bridge suture is created. This is the new R2 system, but only the Pascal has got approved, and the Cardioband mitral system, the multi-pit transcatheter mitral angioplasty system, these are the newer ones. So descriptions, apart from secondary MR and primary MR, the newer atypical uses of the mitral clip, successful treatment of post-acute ischemic papillary muscle rupture in and cardiogenic shock. In SAM, I already told, now it is being utilized for HOCM patients with SAM and also with severe malcoaptation, and the clip treatment for post-surgical mitral valve repair system. And the future perspectives are, I've already mentioned the various devices. The key points are the transcatheter is a safe and effective treatment for both, mainly for secondary and also primary MR, and newer we are coming in. So the 10 future challenges, with this I will conclude. What is the optimal medical therapy in secondary MR? Should moderate secondary MR be treated with MTER? To what extent do we reduce the MR with mitral TER in some secondary MR patients? Is mitral TER equally effective in mixed primary and secondary MR? Which mitral TER device should be used in which situation? We have now so many in pipeline. Is transcatheter mitral valve replacement superior to TER? What is the role of MTER compared to surgery? Is there a need to treat concomitant tricuspid regurgitation in these patients? And what is the long-term outcome of transcatheter edge-to-edge repair in secondary MR? Are we with these answers in the future? So it represents a wide range of therapeutic options from the mitral annulus, leaflets, and the chordae. Everything should be properly assessed and kept in our mind before we go in for a mitral clip procedure. I thank one and all for this great opportunity. Thanking you.
Thank you so much, ma'am. So I would just request you to be on the stage.
I think gradually any type of MR, if there's no mitral stenosis, people are trying to close by this sort of devices. But one thing we should understand is very dynamic. Mitral regurgitation is dynamic. When blood pressure goes up, MR increases, when blood pressure gets controlled, MR decreases. Such sort of variability we need to understand. That's why they put in the criteria. 1 month of optimal medical therapy is mandatory before you take up any patient for any procedures related to mitral regurgitation. Because in 1 month course of time, all these so-called variables could have been controlled. But we have seen patient mitral clip procedure. We are very happy that MR reduced. The next day again blood pressure rose up, then MR increased. So those surprises are also there. But all of you, I think you will have similar experiences in future. I think more and more such therapies would come up, and Madam has dealt it extensively. Ramesh has told. Any questions on this mitral clip or MTR? We'll go to tower because we're running behind the schedule, Madam.
Just one question for you. How frequently the clips will dislodge? What is the statistic saying? How frequently they can dislodge from the regenerative leaflets? And number two, is this dislodgement proportionate to the effective regurgitant orifice area? If it is higher, there's a likely chance of being dislodged?
Yes, ma'am. There are few reports, almost 1% only getting dislodged, madam. Otherwise, not much reports. The same question was asked in recent Euro PCR. There is evidence of dislodgement and recapturing, but it is quite rare only with the experienced operators. That is why mitral clip always with the proctors for first at least 20 cases, better to do with the proctor because it needs. But there are reports of dislodgement, ma'am.
Dislodgement proportional to the regurgitant orifice area should
No,
the
ma'am.
be
No,
beyond
ma'am. It
this?
is the where we exactly grasp the leaflets. But that depends, ma'am. It's not only on the regurgitant orifice area.
Okay, thank you.
Thank you so much, ma'am. Ma'am, if you can just wait on this. I would request Ms. Deepa Nambiar to please felicitate, ma'am. Thank you so much.
Can you get the slides on? I think we're running slightly behind the schedule. I'll try to cover it up and then probably I'll mix up both the talks together. I think how many of you sitting here are exposed to TAVI or TAVR already? Yeah. I think good number of you are already exposed, and it is wiser for you to get into this space because it is here to stay, and then probably in future more and more cases will come up because as the longevity of the devices increase, the cutoff points for the procedural intake of patients will increase, and that's why all of us need to become comfortable. It is not the procedure of future; it is there today, be it balloon expandable or self-expandable. Now, I think some of you must be aware, we have come to a stage of 9 French device. Recently, some news were getting circulated, whether it's real or not, we don't know, of a transradial TAVR. So the space is fast rising. Lot of new research opportunities come up, and some of you with your new brains, young talents, young brains think innovatively. If you can come up with a very low profile TAVR, then that will be very good for the patients. I always pay my respects and regards to this association before any TAVR talk, especially to my good friend Dr. Sushil Kodali, who handheld us and taught us how to do these procedures. And he initially came every month, and about the COVID came, then we made us independent. And then we're extremely thankful to the partnership of FACS with Columbia. And that's how such collaborations, we could get such interesting programs, educative programs. Today we had Mega Prasad from Columbia University talking to us, and all that was possible through single coordination. Now, Ajay, I think many of you are aware, he became chief. He took smartly on his role there. And then other two are anyway seniors. We're extremely thankful to their association. Apart from it, we also learned some of the tips and tricks in Europe. And then Tullio Palmerini was again trained by Sushil. We went there to learn some tricks. And Amsterdam, they were doing very aggressively TAVR with coronary artery disease. We learned how to do it. We're also enjoying the scenic beauty there. That's how we have to make. Yesterday, I was telling about work-life balance. So cardiology is a part of it. I think you hope to enjoy even in places where you go to learn. That's how we did. That critical left main disease as well as severe aortic stenosis was treated in Amsterdam in a 1 hour's time. So very aggressive. I make it a point to show this Arslan Clinic, Switzerland, because where the real heart team approach is followed. I think many of you may be aware, heart team is the only theoretical people say, but they sit in the evenings and decide which patient should go for TAVR, which patient should go for SAVR. It's not that patient coming to surgery, surgery will be done, coming to us, TAVR will be done. Real heart team approach is quite commendable. I thought it is all of us can simulate if it possible. I'm very grateful to a good friend, Dr. Samir Kapadia. When we were students, visiting Cleveland Clinic itself was thought to be great. And because of his help, we could scrub for some cases with read and learn some this single femoral artery technique. We not use other groin. The Cleveland Clinic, opposite that, Atizani performed live, and yesterday also he launched the FX model. This is a great friend and helped us to learn the cuspal overlap technique to decrease the complete heart block incidence which happens in this TAVR. I'm extremely thankful to all the colleagues across the country who's marked there, who sent patients for doing procedures for TAVR. And our Apollo Hospital was very happy because it came in news where we did 5 TAVRs together. As a youngsters, I'm telling you, all of us should be in a habit of keeping our organizations happy because we work together. And it's both individual efforts as well as the organizational backup is important for us to progress in life. And this sort of establishment of hybrid cath lab, once we did 5, they got confidence and they established the newer cath lab units, which could have some advantages, like especially this sort of superimposition of CTs into the cath lab could help in solving some of the nuances in the initial part of it carries. If you see this is the TAVR valve which is being deployed, and we were not happy because that superimposition could happen. There is so much of gap which was there. So we were thinking that it should be expanded further. We expanded. So it could have been done even otherwise, but sort of combinations, it makes us more comfortable in delivering right things to the patients. And any complications also, if it happens, it is always good to have a good surgical backup. Our team, Gokhale, our surgeon, is also great support of this. And then that's how I think we are happy to share some of the case recordings. And for the sake of time, I can't go into details of all the recording, but we really follow our surgeon, our cardiac anesthetist are in the hospital, apart from my colleague, Dr. Gokul, and sisters who are coming for the patient. See, our patients also simulate West now. 81-year-old gentleman actually is a doctor, had surgery elsewhere, had a CVA, troponin, dementia, all that, but still, as they can make it themselves and they want to live longer, and such sort of therapies can be offered safely, they're coming. As latest as last week, we did a lady that I think I should confess that's the maximum age what we did, a 94-year-old female, again, mother of a doctor, wanted to, because otherwise active, we did TAVR last week. So that sort of thing, and pre-procedural clinical evaluation, proper symptom assessment, as well as echo evaluation is important. Again, to see the LV function obviously has plays a lot of role. Apart from it, bicuspid or tricuspid nature and the gradient assessment, all that is important for all of you. I need not go into details. The gradient assessment, the TAVR protocol, actually, all of us, you become comfortable with CTs because you become, if you're not initially comfortable, you have to rely totally on the company's reports. But if you master it yourself, probably you can measure the annulus, things like that. And the gain setting adjustments are also slightly different. If you feel everything looks very bright and calcific, you should be comfortable. The report analysis, all we should know, some of the absolute things. Now we have reached a stage where we're not too much bothered whether the patient is high risk, moderate risk, or low risk, because we do TAVR in spite of high risk or low risk. but we should know whether any particular contraindications like low coronary height or a very severe calcium, porcelain aortas, or some places where you can't do TAVR because our surgeons do good procedures. We should be also delivering goods as good as them. That's why it's important for you to understand the CT, study it well, look for any possible contraindication for the procedure. And that sort of thing, when you adjusted the gain settings, what I showed before, you know that sort of extreme calcium is there. It's very difficult to track the balloon. We didn't know this before. We had some issues on table. Then that's how we became wiser and sharing my thought process with you. That sort of gain setting adjustments before and after. It's very important to work with your radiology colleagues to avoid such surprises on the table. Ultrasound guidance, I did the initial, my chip presentation. I did show you the steps of puncturing. For the sake of time, I would not do it. Then this is a video recording which was done to show you how the groins are prepared. Some of you are already exposed, but we use the right groin for taking the valve and the left groin to have a artery and vein. But some of you are comfortable, you can use single femoral artery and not using the left at all. And using the pigtail, you can take it through right radial too. So these are the things. A video will take more time. I'd skip for the sake of time. Steps of entry, once you have the thicker valve, once the valve is crossed, then you're taking the sheaths in. You dilate the sheath. Then it's very important to have a therapy specialist from company. This is a Medtronic valve. We'll also show you, if time permits, balloon expandable valves. Then once you cross it, then you take this across the dilators initially. Then you put a stiffer wire, exchange it for the stiff wire. You check the valve, whether it's deployed properly or not. You always have an idea of a aortic root on table, and you see as what is working. We note it on CT, but you also have to see it on the cath lab. Basic idea is to get all the three sinuses in one plane. That is the idea of getting, because when you're placing the valve, you have to be placing it correctly in all the three dimensions. Then there are various steps in deployment I will take you through. Initially, sometimes the valve is too tight, calcific, the bicuspid, we tend to predilate the valve. Otherwise, we can do it the direct deployment too. This is one of the self-expanding valves. You see, take it through. You should be careful not to scrape the aorta. Then once you place the valve, you check a aortic root. Then half a diamond is what we are supposed to have it. Nowadays, we're going to zero placement to decrease the incidence of complete heart block. You're deploying, releasing the valve. Till this level, you want to recapture it, you can still recapture it. That is the advantage of the self-expandable valves. Once you're comfortable with everything, then you can release it. Once it's released also, when you're getting it out, sometimes that small clips could be stuck to the valve. It's very important to get the nose cone out and get it out. Otherwise, there could be valve movements happening. So once it's deployed, you should not be immediately happy, but you get it out until that and check the pressures. Then I think once this is done, then you take a picture, then check the gradients. There are no gradients. Sometimes if there are such narrowings are there, you might need a post-dilatation too. So that is after this is done, no gradients, no aortic regurgitation, procedure is done well. It's not done totally because even today, the commonest complication which you have is the femoral artery complications. You always need to, after putting a angio-seal or per close, you always need to check the final femoral angio and see that everything is well. Sometimes a smaller kinking could be noted, which could be needing a balloon patch up, things like that. So this is again going to balloon expandable valves. It's become very popular, unlike self-expanding, because it's almost like a stent. And many of the surgical colleagues also started doing it because the technology became very easy. So I think, can you get the other video for balloon expandable valves? Oh. So various types of TAVR subsets are being done now, and that's how it is becoming a newer revolution, and more patients are being taken. Can you close this and show me the balloon? In the last 4 or 5 minutes, I'll show you the balloon expandable valve too. And then the steps will be same. Step by step. So this heart team approach, as I said, all of us know what it is. I don't want to go into detail, but basically it is very, very important to keep the patient's interest on top and do what is good for the patient. And then team meeting, what is also to be decided is what is the type of procedure which you are planning. Femoral artery assessment is also very important because all the techniques, all the data which comes is through transfemoral. Don't plan the crazy stuff like vena cava punctures and other things in the initial stages, unless you become very comfortable and your center crosses more than 100 cases of TAVR. Then the type of anesthesia, again, a word about it, because it's very important to do it under conscious sedation, I feel, because patient, when he gets pain, that is a caution for you not to be aggressive. Cath lab is not a place to show your power, please. If you are pushing it too much, patient is getting pain, you have to withdraw and then assess what is the cause, assess it and do it. That's how I think conscious sedation plays a role. Other steps of patient evaluation, I would go and skip for the sake of time. And then this is sometimes depending upon patient is very too sick, and then probably doesn't give too much time. That's where we prefer to do balloon expandable valves, do a quick job and come out. Some of the things are common. I would go to sizing the valve. Again, you tend to have 10 to 20% oversizing, not to oversize too much. This is all the cath lab hardware which you need to have in the lab. I will share all the slides with you. No, need not take pictures. Everything will be available on our Fax Foundation website. All the wires, sometimes if you find the extra stiff wires, horizontal aorta, calcium, you need to also keep on more stiffer wires. Apart from the Safari wire, the Linderquist wire is what sometimes is required. So essential key steps are mentioned here. I'll take you through again step by step. Puncture, I already highlighted. Depending upon the pre-CT analysis, you decide which side you want to go. I don't want to go into other approaches. And if you're in the habit of doing a micro puncture, that will avoid the initial troubles. And fellows, as you're practicing, the micro puncture technique can be followed. But again, micro puncture is also not free from total problems, because the flow won't come like in a regular puncture. Then you should be watching the wire, how you're putting it. And once you're comfortable, once you take a picture that puncture is done in the right space, then you could further put it on. So this is the thing. Python sheet is equivalent from Merrill company. It's supposed to be expanding. Once you dilate the track, then the other steps are same of getting the access. Then pacing is also important to pace system properly, because when you pace it faster, cardiac output decreases, becomes flat pressure. That's where we need to deploy the valve. The cusp overlap techniques, I am not going to, because of sake of time, I'm not able to go details. But basically, once you take the Amplatz catheter like this, and then you tend to cross. Most of the times we cross with the thermostat tip. Then once you cross, you exchange it with the pigtail. It's crossed, then you put a stiffer wire. And then you check the gradients. Then this is a stiffer wire placed. Then we pre-dilate sometimes. Then this is the way calcium, you took the picture. Now you have a fair amount of idea where you have to position the valve. This is the pre-dilatation, because especially the lot of calcium, you tend to pre-dilate, and then you're taking this valve. Balloon expandable valve is absolutely mandatory for you to actually having a proper pacing, because otherwise it could pop up. Some of the complications that are shown is because you did not neutralize the pressure, and the valve could pop up during that. That's why it's important. There are some markers available for exact positioning in the later generation valves, and you can exactly position that markers of the sinuses. That's how the procedural techniques are becoming simpler. And as you see it, you keep it under the underfloor, you inflate it. You have to do a slow inflation, the balloon expandable valve, adjust it according to you. You have to have a mental picture where you have to get the valve. And then accordingly, once the final inflation is done, then you get everything out, and then you should check for the echo. Also, if it is there in the lab, it is good to check, assess for the paravalvular leak and the valve gradients. All that is checked. So there's no aortic regurgitation, no gradient. That means you have got a perfect result. Again, final position always should be checking the femoral artery, how it is closed. There is some lag between this and that. So echo also is checked. And sentinel device, some of you want to see, I'll just show that one shot of sentinel device placement that is done through radial. So this is goes to 6 French sheath. This is one sheath which is deployed immediately. Then you take it to go into the other carotid. You need to study both the carotid vessels before you decide to do sentinel device. It's basically 2 filter-like things deployed. vertebral arteries are not filtered, but that's a fallacy. With that, I think I'll stop, finish my 16 minutes now. I think those are the steps by which you watch, but I would caution always you become comfortable with the femoral puncture techniques and closure devices before we go on to the further learning further steps of the valve. Many of the doctors or fellows in the meetings ask which valve would you prefer where. If you want some doubt, if somebody asks only, I'll talk about it. Otherwise, we'll stop. I want fellows sitting here to ask some questions before we go on to newer interventions. Is the other very interesting things we have lined up for you in the last 1 hour to keep you all awake and all make you all stay till the end. Any questions or comments on this tower? Feel free to ask. Otherwise, we'll move on to the next session. Sorry. Yeah, that's a very good question. That is why we do tower after 65 years of age is because we have 10-year data now. So we are definite that these valves are going to last for 10 years. Patient average survival, if you take it as 75, that's how in India, probably we can take it as 61 because average survival is 71 years. So we have data up to 10 years now. 10 years partner data is recently just got published. And also we have other valves showing. That's why research is all going on in identifying a more material, not only the porcine and bovine which is used now, but synthetically prepared material which can last longer is being tried. We have thought of that Foldax, the surgical valve. Now they're trying to come up with tower where it's supposed to last for 15 years plus. So as of now, to answer your question, we have 10-year data, but it's all applies if you do the procedure right. If the valve is not expanded well, if the leaflets are not opening well, they could degenerate faster. So it depends. But by and large, if the procedure is done well, you can be rest assured that valve will work for 10 years. Tower, once you have done a tower after 10 years or some unfortunately earlier the patient has come, is a degenerated the valve, then it needs an indication again. So tower and tower is again can be done, but generally that's how I didn't go into the details of life cycle planning of the tower procedure. The patient is coming at 50 years of age. That is not the age to do tower immediately because if he goes for tower, you might need after every decade, you might need a valve again. So if you're 50, 60, 70, then doing the third procedure becomes difficult. That's how the lifetime planning of tower has to be done. So generally, first time tower is done, second time you can repeat tower and tower easily. But doing the third valve, again, the gradients could become very high. So as of now, what is recommended is you should combine with one tower with two towers. How to space it depends upon the timing of patient. And in general, we should try to avoid surgery as the patient becomes very elderly. So that's why the first cut can be surgery, then second and third cuts can be with tower valves. That's a concept I didn't have time to discuss in lifetime journeys of tower. Sorry, can you pass on the mic? Commissural alignment. That's a very good question. I think he's already exposed to some of this tower because many of them are new. I did not highlight those aspects. Commissural alignment is a technique by which where you deploy the valve in a particular way where your future coronary access becomes easy. Suppose the valve is opening like this. If the coronaries are on the other end where the valve is sinus is not there, it is actually only the leaflet is coming there, you can't access it. That's why to simulate the exact naturally how the valve, God is great, how we made the aortic valve. All these things we are trying to do it to place it as natural as possible before. So alignment, we do it basically to have a future access to coronaries. So that is one. Other thing, what is also important is how the depth of implant is important because that's how we are avoiding the occurrence of complete heart block. So these two things are in research, how to have better coronary access and how to decrease the complete heart block incidence. These are further research is going on along with the longevity problems. So we want to place the valve in as zero position as possible to avoid complete heart blocks and to have a commissural alignment to keep the access to coronaries. Nowadays, yesterday only the Medtronic has launched FX Plus in India too, where you have wider cells in spite of the mesh in front, still you can access the coronaries. So that is what is going on. Other technologies are also there. And anybody is interested to know where do you prefer self-expanding, where to balloon expanding valves? you want, or else it will be further late. But by and large, 80% of the times you can interchange the valves. Either of it can work. What is more important is you becoming comfortable with each type of technology. Don't try to use one of each type like stents, because you need to become comfortable. Unless you have used about 20 plus at least of one type of valve, don't change the valve, because you should treat the patients as per our own. So initially we were become comfortable with self-expanding valves before, because those times Edwards didn't give us a valve. Then that's how we are comfortable self-expanding. Then we started using a balloon expandable Edwards valve, now Merrill valve too. And then Merrill valve, Edwards valves are easy to use, because take it there and deploy it, inflate and come out. And the patient is sicker, where you can't afford to take too much long time. That's where we prefer that. But otherwise, if a patient has a stable patient, narrow annulus, and then you want to have optimal results, and you're worried about annular rupture, then that's where you prefer the self-expanding valves. If you have a worry of complete heart block happening, then probably you could prefer the balloon expandable valves. Those are some of the indications in which you prefer, but by and large, your operator comfort is important. What you're comfortable, and have one form of balloon expandable, one self-expanding valve in your shelf for you to become more comfortable. I think we are slightly behind the schedule. With this, I'll stop. Any questions? Final?
Sir, a small. Sir, in case of bioprosthetic aortic wall replacement and mechanical, is there any role of TAVI later once wall get degenerated?
Yeah, actually, initially the part when we had patients used to come after bioprosthetic valve surgery done, I used to think it's difficult, but it's not actually. You have a markers there, you have an app there to decide which valve to put there. I thought it is relatively easier compared to doing it, provided you have the appropriate sized valve placed before. The surgeon has made your wife miserable by placing a 19 mm valve, then it is difficult, because however best you do it, you can't make it an optimal sized valve. But otherwise, surgeon has placed 23, 25 mm bioprosthetic valves. In fact, I feel it is slightly easier to do TAVR in a post bioprosthetic valve degeneration, because it is easy to deploy and come out. But there is some data to show that self-expanding valves could be preferred to get the less of patient prosthesis mismatch. But otherwise, you can safely do TAVR in a degenerated bioprosthetic valve. No problem at all. Thank you.
Thank you so much, sir. Please give a loud round of applause. Coming on to the next session, which is newer innovations and interventions. We have with us Dr. Suresh. Can we have the CV slide? So Dr. Suresh is an interventional radiologist, consultant neuro and vascular interventional radiologist at Apollo. His clinical areas of interest are neurovascular interventions. He has numerous publications as well as guest lectures, and he's also the member of ISNR. This session will be chaired by Dr. A.N. Patnaik. Welcome, sir. Over to Dr. Suresh.
Good afternoon, everyone. At the outset, I want to thank Srinivas sir for giving me this opportunity, and I'm very happy to share the experience of stroke interventions with my cardiovascular colleagues and the students. So we all know that we are talking about ischemic stroke, which is much more common as compared to hemorrhagic stroke. We see it in 85% of total stroke, which is like sudden neurological deficit as compared to hemorrhagic stroke. So there are two treatments, as you all know. The conventional treatment, which has evolved after NINS trial, that is the IV thrombolysis. So the window period is 4.5 hours. So you give the drug and it causes clot busting. And the second treatment is something called as thrombectomy. Instead of giving intra-arterial lysis, which was the treatment before the advent of the mechanical thrombectomy, you are mechanically taking out the clot with the help of different devices, with the help of either stent retriever or aspiration thrombectomy. So the timing is up to 24 hours. Actually, conventionally, it is up to 6 hours, but you can do it up to 24 hours in select cases. So coming to thrombolysis, you all know that the up to 3 hours, mostly there are no contraindications in terms of patient selection, except for intracranial hemorrhage or recent history of ICH or recent history of surgery. But most of the cases, if the patient is having measurable neurological deficit, you can administer it. So patients who are coming beyond 3 hours, then you need have some filters in form of AHR, diabetes melters, INR, all the things. So contraindications I described. I'm not going to details of fire now. So the problem with the thrombolytics, the IV thrombolytics, is that its efficacy. So you have the more distal the clot, like if you have something distal in the MCA, distally or in the antecerebral artery, then the chance of reconvolution is very high, up to 50, 60%. The more distal the clot or the more smaller the clot, more red thrombi, more less white thrombus, the chance of reconvolution is very higher. And if it is more proximal, longer clots, like an ICA clot, then chance of reconvolution is only 5 to 6%. That's the advantage of thrombectomy. Whereas in thrombectomy, most of the operators now have the reconvolution extent of around 90%. So that is the beauty of thrombectomy. All of you must be knowing it, just the schematic representation of how thrombectomy is done. So these are basically stents. It can be done with two devices. The stents have a wire, non-detachable wire. So it takes kind of baskets the clot and takes it out. Or the second one is aspiration device. The aspiration sits at the mouth of the clot and a vacuum is applied and it sucks out the clot. And this is how in the stent looks like. So in it goes to the groin, radial also we can do in post circulation and sits across the clot. And this is how it looks like, what we do. So the clot basically stucks or gets impregnated within the stent. And we try to use sometimes both the devices together, the aspiration device as well as the stent device. So how the assembly of the clot. So we're not going to put the stent across the lesion as in case of cardiac. So because most of the cardiac lesions we see are underlying atherosclerotic plaques are there, whereas in neurovascular setup, only I can say 20 to 30% of the patients are having that to Asian patients. In Western patients, most of them are embolic. The atherosclerotic disease causing de novo thrombus formation is very less. So where it works, do all the stroke patients need them? No. So suppose if you have this scan, so scan is very important. You need to do a scan, MRI, CT, or angio also is very important. So visible artery occlusion should be there. So you have to have an angiographic study, CT angio or MR angio. You can see that there is no visible artery occlusion. So there is no role of thrombectomy here. And thrombolysis, but still it is relevant because any small vessel also it can act upon. And as in case you can see symmetry, you can see on the right side there is a visible occlusion is there, on the left side it is not there. So definitely it will help. The thrombectomy will be helping. And which are the vessels we can target? As of now, the guidelines are there for the anti-circulation. Selective guidelines are there for the post-circulation. And in anti-circulation, we have got that encircled areas, that cervical ICA, intracranial ICA, middle cerebral artery, proximal and middle cerebral artery. Any vessel which is 2 mm or more, we have the devices to target with the stent reverse as well as the aspiration devices. So basically, we are talking something about large vessel occlusion. In all stroke interventions, we should know that this term, large vessel, whenever there is large vessel occlusion is there, then only we can do this particular intervention. So how common it is? All stroke patients doesn't have large vessel occlusion. It is around 20%. Means if you have a stroke code in your hospital, out of 10 stroke codes announced, there is a possibility that you get 2 possible cases or potential cases for thrombectomy, not all cases. So it is around 20%. And what if you treat? This is the most important question that patient asks in the emergency, that if I don't get it done, what will happen? The natural history is that if you don't treat and if you go by conventional management, the outcome is 35% good outcome. 65% is bad outcome. It is reversed if you do an intervention. It is 65% good outcome. It is proven in the trials and it is even proven in our own practice also. But all the patients won't be improving. Like 2/3 will be improving. So we'll be telling the patient that out of 10 patients, 6 may do good and 4 may go bad. Either they may be dependent or they may be fatal outcome. So this is how the pathophysiology. On day 1, there is a small infarct. If you don't treat it, patient may be having mild deficits with a large vessel occlusion. Slowly, the deficits keeps on increasing. Infarct keeps on progressing. And sometimes patient comes with a day 3 scan requesting us to do a intervention. Now there is no point of doing intervention at day 3 because the infarct already progressed. So if you do on day 1, there is large amount of penumbra which is salvageable, and you can salvage. The outcome is going to be faster recovery as compared to conventional treatment. So there are guidelines, definitely guidelines have come up. And what they say is rule of 6. You have to remember rule of 6. The NHS, basically it's You all know about the NHS, the National Institute of Stroke Scale, that measures the extent of the stroke. So milder strokes, there is contraindication. Anything 6 or more you can do. And aspects, that is extent of infarct evaluation. Just like your ECG, the parenchymal evaluation is important. You need to do either CT or MRI. And up to 6 hours. Later it got extended up to 24 hours, but we do the regarding the vessel IC and M1MC occlusions. And so this is how aspects is calculated. Total 10 areas we are divided. The more number of areas involved, the score will come down. 10 minus number of areas. So this I'm going to skip because it is too technical. So after thrombolysis, if you are giving thrombolysis, the patient has come within 3 hours or 4.5 hours, you give thrombolysis, but don't wait for its effects to come. If the patient is a potential candidate for thrombectomy, immediately rush to cath lab. Immediately take the triage the patient to cath lab. So holding of the patient after thrombolysis is class 3. That means harm. So there are certain group of patients you can still go for interventions up to 24 hours based on the perfusion criteria. So this is our protocol. We do either MR or CT based, very simple, up to 4.5 hours thrombolysis plus thrombectomy, beyond 4.5 hours only thrombectomy. So any small infarct with large vessel occlusion, very good patient for thrombectomy, because once infarct is formed, it is not reversible. This is the concept. We are not going to reverse the infarct, same as that for the myocardial tissue. So if the infarct is big, the outcome is not that as great as what you see with the smaller infarcts. So this is the crux of the case selection. Window period 24 hours. Period thrombolysis is not a contraindication. Occlusion level either IC, MC, or basilar artery. So what are the differences between thrombolysis, case selection, thrombectomy? So we have the window period differences there. Anatomical level of occlusion is not a contraindication for thrombolysis, but for thrombectomy it is. It is relevant. You have got anatomical level IC and M1 you can take, basilar you can take, not beyond that. And extent of parenchymal infarction, if it is too big infarct, you can't take. And in anticirculation, there is definitive evidence is there. But for thrombolysis, no level of occlusion, no extent of infarction, or whether it is anterior posterior circulation doesn't matter for thrombolysis. Case examples, patient is a CRHD, posterior for surgery, develops sudden left hemiparesis, and we did thrombectomy. You can see that MCA right side got occluded, and after thrombectomy, and she started moving on the next day. So she got posted for again surgery, the valve replacement surgery after 2 weeks. So young guys also we see more routinely now, and MC occlusions are not common, not uncommon. And this guy is like in his early 40s, fruit window, and you can see he's walking in the ward. He came with complete hemiplegia. And another patient, I see a chronic IC occlusion and recurrent strokes. So we did thrombectomy and stent placement. He's the patient. And some ICA tandem occlusions. You have IC and intracranial IC occlusions. So we did thrombectomy by direct carotid puncture, and I started moving his hand on the next day, on the day 3. So we have innumerable examples of good outcomes in 2/3 of the patients. MC occlusion before and after images, and young guys constitute significant amount of the number of the patients we treated. Again, sometimes we see on-table recoveries like this case, MC occlusion, right side hemiplegia, and we did thrombectomy, and we see sometimes this kind of miraculous recoveries on the table. IC occlusion, this is on POD1. This is post-CABG, because ours being very high volume cardiovascular center, we see post-CABGs are cardiac-related embolic stroke very commonly. So this patient presented with left hemiplegia, in-hospital stroke in the post-op period. We did thrombectomy. You can see that the patient is walking on day 2 after the thrombectomy. And another on-table recovery, left MC occlusion, and patient started speaking. So we have many examples like this. So yes, I will skip for the want of the time. So we have close to 500 cases treated in my experience, which includes the Apollo as well as the previous institute experience. Out of the 500, the most we have around 400, like the 4/5 are 80% are anti-circulation, post-circulation is 80. The outcomes in the anti-circulations are around 70%. The bad outcomes are in the range of 30%. This is my own data assessment after evaluation. In post-circulation, the outcomes are around 55%. not as great as anti-circulation. And window period, we have done many cases, more cases out of 6 hours window period actually. This is very paradoxical. And the outcomes are not different if you are doing less than 6 hours or more than 6 hours. It is both, it's around 70%. And mortality is around 12%. This is very important to communicate to the patient before doing an intervention. So this is especially important in our setup where the rehab services are very poor. Patient is not willing to pay for the rehab services if the outcome is not that great. So, what are the subset of patients still we are selecting? We are like one of the subset is that very distal occlusions that also we target with more increasing confidence and better devices. We go more distally and do thrombectomy. Like in this case, the occlusion is in distal ACA, intracranially, not in even MCA. And patient has high deficit and we did thrombectomy. So recognize these particular the occlusions and corroborating with the clinical deficit and targeting that particular vessel with the stent retriever and doing proper recanalization without any complication can give rise to a good clinical outcome. As you can see that the patient is 84 years and we did distal vessel occlusion thrombectomy and she's doing well. And another case I see as well as tandem MCA occlusions, I just skip the slides. You can see that the distal vessels quite intracranially, very distally into the MCA branches, we try to recanalize them. And because there was a significant penumbra in that particular targeted area, we try to recanalize them. And this is the area that we got recanalized. And this is the state of his functional outcome at the end of 3 months. He was walking, even though there was large infarct at the baseline. Post-circulation steps also we do, like in this case, basilar occlusion. We did thrombectomy. He did well. You can see the pre and post-op images. He is a software engineer who presented with coma and intubation because of the post-circulation stroke. He's an auto driver and came in comatose state and basilar occlusion was there. We did do thrombectomy and this is after 2 months. He was having spastic gait, but he's awake now. So sometimes all the brain strokes are not similar, and I think because of time, I'll skip these slides. So we have done few cases around out of these 500 cases, around 54 cases we have done beyond 24 hours also with reasonable outcome because some patients are slow progressor. They may be having very small tissue of damage and still there is large penumbra available even after 24 hours. Those cases also we did thrombectomy. So to come to conclusion, what are the lytics? Basically, the lysis has the advantage of direct effect on thrombus and ongoing thrombi and collaterals, it will have an effect and short half-life it has. But the problem with the lytics is poor recanalization. Hemorrhage is always an issue. You can't add up antiplatelets immediately. And in our setup, what we do is that there is no conflict between the lysis and thrombectomy. So both are complementary and bridging therapy is always indicated. If so the standard guideline, current guidelines also says the same, that you need to bridge it rather than go directly to thrombectomy if the patient is coming within the window period of 3 hours. So the most important thing is that the thrombectomy is complementary or thrombolytic is complementary to thrombectomy. They are not kind of conflicting treatments and thrombectomy has different set of patients in terms of indication. So there is no conflict between these two modalities. You should always combine them in specific cases where patient has high risk of bleeding, like anticoagulants, antiplatelets, or CKD. There probably you can skip the thrombolytic. So this is our cath lab, biplane cath lab 24/7 available for neurointerventions. And ours is first center in India to have a comprehensive stroke center from ASA certification. And there's one interesting thing that has come up in the last 2 years that IA lysis, intraarterial lysis after thrombectomy. Following thrombectomy, there are so many trials have come up which showed that the lysis after thrombectomy improves the tissue level perfusion, not before thrombectomy, intraarterial lysis after thrombectomy. So that improved the overall functional outcomes. And even there is no proposal saying that you should probably try considering IA lysis after thrombectomy, after successful thrombectomy to get further good outcomes. Thank you.
Thank you, Suresh, for an excellent work and sharing your experience. In cardiology, also, it is a pharmacokinetic strategy which works. That's good for India. That's what is recommended. Give lysis in the periphery, and then patients are shifted for procedures. I think same thing is coming up in your. What is a which lysis means? What is a lysis drug? Just can you tell for fellows?
We are giving both the alteplase and tenecteplase. Even doses are there for the intraarterial. If you are taking doses, you can give up to 12 mg maximum per alteplase.
Okay, sir. Madam is asking tenecteplase.
Sorry. Tenecteplase dose to be standardized, ma'am. Alteplase, they have most of the trials shown up to 12 mg you can give intraarterial. 12 mg, 12 mg, 12 mg maximum.
Do you have pre-hospital usage of tenecteplase?
Sorry, sir, I didn't get you.
Pre-hospital means before coming to your hospital.
Pre-hospital usage of tenecteplase. Like how?
IV, sir, intraarterial.
It is now recommended as pre-hospital in the ambulance. Before
IV
that,
routinely is being administered, and now tenecteplase are like standardly, it is standardized in place of alteplase because it can be given as bolus, number one. Like unlike alteplase where you need to give infusion pattern, whereas tenecteplase has got the advantage of bolus and cheaper as compared to
How much dose?
This is they are giving up to 0.2 milligrams per kg body weight.
Okay.
Yeah.
I think this is very encouraging for all the fellows to note that there's a lot of requirement of such intervention neurologists like Suresh is luckily available because of Apollo. Many places we don't have such. So even both initially worry was whether you do procedure where something happens, medical legal issues and all that. And now it is given not there at all. Even both ESC and ACCHA has said that interventional cardiologists also can do these procedures because of the deficit of people. And in US, if you see, lot of not only cardiologists but even the neurosurgeons are deep into it along with interventional neurologists. So youngsters, I think it's a very potential opportunity and area, and I think it is required also. Not only the case that you will be comfortable, patients need it. And in the era of structural heart interventions, another thing what you have noticed is post-hour something happened, patient embolized, we could immediately do stroke thrombectomy, things like that to treat patients immediately. So even some of these newer indications are also there. So I encourage all the young colleagues, fellows sitting here to take more interest in this. And then decade back, I had a stroke intervention workshop, stroke in our TCT meeting. Since then, I was arguing neurologist, but it'll work. But they were never agreed before. I said it is a vascular occlusion, it has to work. We have to have better system of thrombectomy. That's all, how to do it better. I think now we are better retrieving systems, and that's how it's working. And exactly how it was a decade earlier in myocardial infarction primary PCI, it is going to that, and data has come up to 24 hours also. Now it is beneficial. Anybody has any doubts? Yeah, can you pass on the mic? Suresh.
I didn't get the question.
Shall we introduce the wire first? We have to pass the wire first, he's asking.
Yeah, it's basically a microcatheter deliverable system. If you are using a stent retriever, you need to deploy the microcatheter across the clot. And then the stent retriever is a self-expandable one. So you need to deploy the stent retriever inside the microcatheter, and you need to unsheath it. While unsheathing, the stent retriever gets deployed into the clot. Then
Suresh's doubt is you have to pass the wire. No, anyway, you'll pass the wire and then do all that before. No?
Yeah, wire followed by microcatheter, wire all the microcatheter, then you need to pass the stent retriever.
Same like PCI, no? Without wire, how will you do it?
Yes.
Wire passing, yeah, wire is the primary thing. Yeah. Whereas for the aspiration catheter, they say that you need not cross the clot. The aspiration you can directly kind of navigate and put it across the mouth of the clot and suck it out.
Okay, thank you.
Great work. Congratulations, Suresh, for making Apollo one of the center of recognition for ACC. And a lot of patients got benefited. Thank you. You can go to move next.
Thank you so much, sir. Can you be on the stage? I would request Mr. Krishna Rao to please felicitate Dr. Suresh. Next, we have the topic of zero or ultra low contrast PCI. For that, we have Dr. Ramakrishna. Dr. Ramakrishna is a consultant cardiologist at Apollo Health City, Jubilee Hospitals. He has done multiple presentations on various topics in national and international conferences, and he has also published various research papers. Over to Dr. Ramakrishna.
Yeah. Very good afternoon, everyone. And after structural and the CNS sessions, we move on to the everyday routine, because without this, no angiogram will be done, no PCA will be done. But is it always safe to use the routine amount of contrast, or is there any indication to reduce our dose of contrast? We'll see in the coming slides. So coming to the topic introduction, we need to avoid the kidney injury from the contrast, how to reduce the contrast, and what are the various options. And we'll show you some case examples at the end. So the definition of contrast associated acute kidney injury, previously we called it as contrast induced nephropathy. The nomenclature is slightly changed. That is contrast associated acute kidney injury. It is defined as more than 25% rise in serum creatinine from the baseline, or more than 0.5 milligram per deciliter increase in absolute serum creatinine value within 48 to 72 hours following contrast administration. Why it is important? It is very high in the patient had baseline kidney issue, or it has devastating complications, including high mortality, up to 10% if the patient EGFR is less, and if he develops CIN, the contrast associated acute kidney injury. The KDIGO have proposed a slightly different version of the definition. It's more or less same. The plasma creatinine level that is increased by 1.5 times or more over the baseline within 7 days. If it is up to 7 days, it is 1.5 times the baseline value. Or if it is less than 48 hours, if it is at least 0.3 milligram deciliter increase in serum creatinine from the baseline value. Or if the patient, if you measure the urine volume, if it is less than 0.5 ml per hour, that persists for at least 6 hours after contrast exposure. If any of these criteria are met, it is defined as contrast associated acute kidney injury. So why it is important? If the patient had baseline renal dysfunction, there is 8% risk of developing CA associated contrast associated kidney injury. If GFR is between 45 to 60, if it is less than 30, it is almost 27%. So if you experience any of these, because initially we may not be bothered about this, but once we experience such sort of patients, like if our procedure, everything went well, but patient developed some kidney injury, so we develop some sort of attitude. We tend to treat less aggressively. That is called renalism. It manifests fewer diagnostic and therapeutic opportunities, and the way these patients will have higher mortality. But why? Because most common cause of mortality in kidney patients is again the cardiac. So we'll develop some sort of aversion. So we need to try to avoid. So if a patient had baseline CKD, and if he develops contrast associated kidney injury, the 1-year mortality is almost 25% when compared with the patient no CKD and no CIN. So where are the situations we can reduce? We need to reduce the contrast is, if you anticipate, if a patient had CKD, baseline creatinine is high, then we try to reduce our contrast. If the patient had iatrogenic dissection, don't inject too many injections. It will progress the dissection and it will complicate the procedure. And if a patient had anticipated long procedure, if the patient already had renal transplant, if the patient already had prior history of contrast associated acute kidney injury, or if you are planning for a CTO and patient is in shock or out of hospital cardiac arrest, acute MI situation where you don't know his creatinine level, or if the patient is long-standing diabetic, so emergency PCI, unknown GFR, all these situations we try to be mindful of about our contrast volume. So if this is what is the concept when we call it as ultra low contrast angiography. So is there any definition for this? So there is, if you have to do a procedure in a kidney patient, try to reduce the contrast volume
by GFR. If the contrast volume by EGFR ratio is less than 1 or equal to 1, that is considered as ultra low. Suppose if the patient GFR is 30, you should try to aim for your contrast volume less than 30 or equal to 30 at the max. And if EGFR is less than 15 ml, then try to dilute the contrast and take as minimum as projections as possible. For RCA, one injection, that is a levocranial, that gives the proximal and distal portion. And for LED, the left system, try to have two projections that gives best information and most information, that is epic, caudal and cranial views. That's enough. And try to have a hydration, that is LVEDP guided hydration, or at the basic LVEF guided hydration. Suppose LVEF is 30, try to have at least 30 ml per hour fluid infusion. Or if you have a facility to measure LVEDP and LVEDP less than 13, try to have 5 ml per kg per body weight fluid hydration before starting the procedure or during the procedure or after the procedure. If the the EDP is between 13 and 18, try to reduce to 3 ml per kg per body weight per hour. And if it is less than more than 18 LVDP, try to have 1.5 ml per kg per hour body infusion. So try to adjust the fluid hydration. So what are the principles? Try to analyze the CD and plan your procedure before, and keep angiogram in your playing room. Suppose if already contrast was injected, don't try to take again angiogram, again multiple views. Smaller size guide catheter, why I will show you in the coming slides. Relay and control CHE, pressure monitor, and before engaging also don't inject too many contrast boluses, and try to relay and pressure monitor movement of the catheter and heparinase saline injection to see any ECG changes during the saline injection. So that shows that you are engaged. Your catheter is sitting in the coronary rather than giving a contrast bolus, because each ml has an significance in these cases. Suppose if you take a diagnostic catheter of 5 French, the catheter alone carries 1.3 ml contrast. So if you take a 6 French, it is 1.6. 6 French guide 2.6 ml contrast is lying in the catheter. And if it is a 7 French, your guide catheter can hold 3.3 ml. Suppose if you have a manifold, it carries another 0.3 ml extra. If you connect a Y catheter, it almost so double the contrast volume if you combine Y connector and all. So that's why you try to aspirate the catheter after the procedure or each after injection, so that you will remove some amount of contrast from the catheter. So these are the ECG changes if you are engaging left coronary, and if you inject saline, you can see there is some slight abnormality in the T waves, that is repolarization abnormality in the left system. And similarly for the right coronary artery, you can see the repolarization abnormalities in the T wave. There is slight T wave changes after injecting the catheter, after injecting saline, not contrast. So the purpose is to reduce the contrast. So these are the various procedural steps. Use branches before the lesion, after the lesion. Place one wire inside that, and so you need not check the position of the stent or balloon for each time. And radio opaque portion of the guide wire, the PTCA wire, will help you in assessing the length of the catheter. And if you have IVUS, that is best. You can assess the size, lesion assessment, whether it is calcific lesion or fibrotic lesion. Don't oversize the stents, because if you land in complication, you tend to use more contrast. Use NC balloons to optimize the stents. IVUS pre and post. And final angio, we need to check at least one injection. Otherwise, we may land in the medical legal cases. Suppose after procedure, the patient may argue that we would never put a stent, but we don't have an option. We don't have any evidence to show them. So we use as minimum as contrast as at least 3 to 5 ml for one shot to show that the lesion is treated. So these are the various procedures. Try to have a coaxial engagement of the catheter. Use a smaller and regular catheters. Don't try with AL1 for your IRCA and left systems, because it will be more complicated for many of us don't have experience for AL for a regular use. So try to use JL and XBU or EBU catheters, and use invasive pressure monitor or fluoroscopic projection to have a coaxial alignment of catheters. If a calcification is there, take the help of calcium and previous angiogram, and take the help of ECG. Don't inject contrast. Try to hold the contrast, because that is not our routine process, but this is a complicated procedure for these patients. So what I'm saying is, wire silhouetting technique, that is analyze the angiogram and put a wire in the proximal branch or branch nearer to the lesion, and try to assess with imaging if you have, or even if you don't have imaging also, you can put a wire inside the vessel, inside the branch, proximal and distal, and you can place the position of the stent. So this is an example. I'll show you this. Try to identify high-risk patients. If the eGFR less than 45, patient is diabetic, try to treat them as high risk for contrast-associated nephropathy. GFR less than 30, previous contrast-associated nephropathy. And similarly for both the patients, try to reduce the volume of contrast. The contrast volume by eGFR, it should be 1. And LVEDP guided hydration before, during, and after the procedure. Confirm the catheter engagement without injecting the contrast with saline or workhorse wire. And wire movement, wire position, you can help each step. I will show you in the coming slides in this same. So coming to the case examples, a 51-year-old male, hypertension, diabetic, CKD, under nephro follow-up. He had angina. LVF is around 40%. Serum creatinine 1.9. After angiogram, it went up to 2.1. So he had a lead in RCA lesions. So this was his angiogram. You can see this is the distal RCA lesion for a long segment, and this is the LED. You can see the mid LED lesion. So why this angiogram? It was done outside. After this angiogram, we gave 1 week to 10 days time. That is very, very important, because if you plan the procedure within 72 hours, so there is increased risk of contrast associated nephropathy. Try to give some gap, especially in stable cases. So we place the wires in the branches, and so that proximal wire acts as a guide where our strand should go. And this is IVS we are doing, and IVS will tell you the lesion characteristics and distal landing zone, proximal landing zone, and after the procedure, is there any dissection, or what is the plaque morphology if the patient had calcific plaque. So we need to modify with NC balloon or cutting balloon before the procedure, rather than doing multiple injections after the procedure, whether stent expanded or not. Okay, that sort of information. You can also assess the stent length and the distal landing zone, everything you can. So this was after. If you are in doubt still, you can give diluted contrast, one shot, and don't do multiple projections and multiple injections. So try to inject as minimum contrast as possible. So this is after the stent. So you can see the distal edge of the stent, proximal edge of the stent. No need of any contrast injection at this stage. For each stage, you need not inject. So this one shot injection after this, that's enough. So with wire one shot, without wire one shot, there should not be any contrast injection multiple times. This again, we are wire silhouette technique. So we're placing the wire in the proximal branch, nearest branch, and we are dilating without any injections. So this is the stent we have taken. After the stent, we are again balloon dilatation. And after balloon dilatation, everything is done. Then take one shot. So good result, contrast volume is 20 ml, double vessel angioplasty, and uneventful hospital stay, and before discharge creatinine was 1.8, because in the immediately after the procedure, we are hydrating well. That's why most of the times you tend to see slightly reduction in the creatinine if you use less contrast. So this another 69-year-old male, hypertension, diabetic, he had PTCA2 LED 2012, L6 and 2012 and RCA 2014. Now again presented with exertional angina since 4 months. Baseline creatinine is 2.29 and eGFR is 28. Our aim is to contrast limit to 30 ml. So this was his angiogram. LED stent is patent and L6 stent is patent. There is a distal OM lesion and RCA lesion. So RCA lesion is tight, and we again did IVS imaging and balloon dilation and stent placement without any contrast injection. So this was a stent placement, and again even in the proximal portion in IVS it is showing significant lesion. Again, none of the stent in the proximal portion. So I'm not going into details because we are already running late. So this L6 was stented similarly, and one last injection after balloon dilatation. Everything is done, then give just one short injection. So this another 64-year male, recent ACS, good LV function, diabetic, hypertension, CKD. He had triple vessel disease. He was advised bypass surgery, but he doesn't want to go into dialysis, and he want to die, but not on dialysis. So the option was CABG, first option, but he refused that. So this was his angiogram, L6, LED, all critical lesions. So we didn't took any injections. We were just playing the angiogram CD in the console, and with the help of wire cell head technique, and we dilated the stent. So after balloon dilatation, So this was everything done, and after LED, L6, everything was stented. Then we took one short injection. So for the same medical legal purpose to save. I think. So this was the RCA injection, and creatinine was same, baseline 5.4, and now it's 5.3. And he is in follow-up since 1 year without dialysis and without any cardiac symptoms. So this is a recent case we did for a 70-year-old male. He underwent angioplasty in 2019 to LED. Now presented with unstable angina, especially nocturnal angina. So this was his angiogram. Baseline creatinine was 1.5. And after angiogram, his creatinine went up. And for this patient, we cannot wait for a long period because this is LMCA lesion. You can see there is some ulcerated plaque in the LMCA. What size of the stent you will place for this LMCA? 3.5, 4, 4.5, 5. How many of you? So for this sort of patients, the imaging guidance is very, very essential. So we did IVS for imaging for this patient. You can see the epicranial view. You can see there is some ulcerated plaque or plaque rupture with this. So you can see IVS imaging. There is some ulcerated plaque in the mid shaft LMCA. I think you are able to see the IVS imaging. The left main is good in the distal part with minimal plaque, and at the lesion side there is some double lumen appearance in the LC. So this is a segment. There is some ulcerated plaque. So this was after stenting the left main. This stent was 5. So we post-dilated with 5.5 balloon. So the 5 steps, that is pre-procedure, optimize the hydration, LV-EDP guided or LVEF guided, set the contrast limit by EGFR, stop nephrotoxic medication before the procedure like metformin, telmisartan, ACE inhibitors or ARNI before, at least 3 to 4 days before, and restart after the creatinine is stabilized, correct anemia, and if the patient is in shock, try to optimize the shock and display the previous angiogram during the procedure, stent enhancement technique, zoom out, avoid panning, avoid taking multiple injections, higher frame rate if you are using diluted contrast, and try to have low dose sedation and prevent contrast injection in the femoral, use ultrasound guided access puncture and regular catheter flushes. And if you are having access to imaging, try to have IVAS or FFR to assess the lesion, and post-procedure, try to minimize the contrast volume as low as possible. Minimize the contrast exposure, possibly using the least nephrotoxic contrast, especially VCPAC in our setting with the critical in CH and PCI in CKD patients. Hydrate well before the procedure, during the procedure, after the procedure, stage the procedure, and if it is a non-urgent procedure, use imaging during the procedure to optimize the result and reduce the amount of contrast. So we are definitely going to leave you for lunch. Try to have some fun. I think it's in mute, I think. Yeah.
Anyway, they enjoyed your lecture, Ramakrishna. Anyway,
Yeah,
that's fine.
all cases are very well done, actually. Very thoughtful. Do you charge more for the procedures or less?
IVAS
So
cost
much of
may be
thought
there.
is involved.
IVAS cost is only there if the patient wants to undergo IVAS guidance, that IVAS catheter cost will be extra. But fellows, I think all of you would become comfortable doing procedures in the patients with increased creatinine, because it is going to happen as we keep doing more and more elderly patients. Creatinines are high risk patients, but again, you should come out of the value of seeing only creatinine, absolute GFR values, because thin patient with the normal GFR also could have normal creatinine also could have low GFR. Whereas obese patients, it could be slightly different. So keep that calculation, GFRs, I think most of you are familiar with it, and adequate hydration and amount of contrast which you use, the game changers.
And nowadays, we are not, really, I would say, we're not too much worried about creatinine because we started following these protocols. And whatever is the creatinine, I think he has shown one 5.2 or 5.6 creatinine patient also, where it didn't increase further. If you take precautions and follow these principles and do IVAS guidance, I think you can safely do these procedures. And then once many of the doctors, I've noticed some of the cardiologists also feel that because he has creatinine value high, doing surgery is safe and they send for surgery. It's not true. Patient, once he goes on to pump, and there's more chance of patient going into dialysis than we doing the procedures with following all these steps. So keep that in mind and advise low contrast PCI, and we can do a good job to these patients, especially if they can afford IVAS. But patient has to understand this. The cost going up is not our problem. We are using the technology to give the benefit of doubt to these patients. Any questions or comments? Otherwise, we'll go to next talk because it's running behind the schedule. Okay. Any questions? Any of you had any personal experiences where you had some different sudden rise of creatinine or other way? Want to share? You're in a hurry to go for lunch, I think. Anyway, thank you. We'll go for the next lecture.
Thank you so much, sir. So if you can just stay. So I would request Mr. Krishna Rao to felicitate Dr. Ramakrishnan.
Other thing we wanted to tell regarding the stent sizing in this again, always err towards taking quarter size less because we can't keep on taking exact sizes. And then always we can post dilate with a bigger sized balloon leaving the edges. That helps in avoiding dissections and taking multiple views. And the diameters also you should plan accordingly. Length you can take 2-3 mm more because if you want to position it correctly, take the correct size stents, you tend to waste more contrast. There is another point I think Ramakrishna did mention, I don't remember. So that is another important point by which you will save a lot of contrast and procedures will become easy.
Next.
Yeah, staging, that depends. Osteal lesions. Yeah. Osteal lesions, again, the positioning, if you have intravascular ultrasound, it is good. Otherwise, the wire strategy, best strategy, silhouetting helps in doing the osteal lesions too. Thank you.
Right. Thank you so much. So next we have newer interventions in heart failure, and I would invite Dr. Krishna Lalukota. So Dr. Krishna is the director and senior interventional cardiologist at CARE Hospitals. He has over 22 years of experience in heart failure device therapy. He has led and contributed to many significant research and clinical trials. He is also one of the top recruiter in the United Kingdom for Veritas and Everest clinical trials. Over to you.
Okay, good afternoon. I have partnership agreement with the device company. That's my business. So heart failure is one of the things which has been researched extensively, and you would have seen at least since I was a medical student, it just picked up so much that everything has changed. And then this one slide actually shows everything about heart failure. It is in the guideline slide set, which you can download. So just I'll go through quickly what you can do. So you have a 6-step approach. So step 1, you have to establish the diagnosis, whether it is heart failure with reduced ejection fraction or mid-range ejection fraction or preserved ejection fraction. So anything less than 40 is reduced ejection fraction, 40 to 50 mid-range, and more than 50 is actually preserved ejection fraction. So these are all things which I'm sure you would have read and been listening to many times. So the 4 major pillars, the ARNI, beta blocker, MRAs, and SGLT2 inhibitors, these are the ones. So once you treat the patient, and if the ejection fraction improves to more than 40%, so you continue with the medication for the rest of their life. Of course, you have to make minor adjustments. So there are a group of patients where ejection fraction continues to be low. That means the response is less. And then if they continue to be symptomatic, then you can add the hydralazine and nitrate. And then this group of patients, now you have to consider the third line of therapies, which are like devices, implantable devices. So the devices which have got overwhelming evidence are the CRT, or cardiac resynchronization therapy, and then implantable cardioverter defibrillator. So these are the things which will not only improve the symptoms in terms of CRT. The defibrillator saves lives. So in the asymptomatic or grade class 2 patients, you can see the mortality benefit up to about 60%. So there are a group of patients where you will find no response despite giving these devices. So the conventional method is they're classed as refractory heart failure, and then you send them for further follow-up therapy or the advanced heart failure therapy like mechanical circulatory supports, cardiac transplant, or if you're not able to do anything, and then if they look too sick, then you end up with the palliative care. But there are a couple of things which we can do. So these are like additional therapies which are just now picking up. I mean, like they're not completely in the guidelines, but I'm trying to just see what we can offer to this group of patients. So here is my favorite slide. If you look at it, so this is beta blocker. So one important drug, and then MRA. So these actually over the 36 months, if you treat 6 patients, you would have reduced 1% mortality. So similarly, CRT is the best device which is available. And of course, ICDs, they don't improve the pump function. So their benefit is a lot less than the CRT. And then CRT recommendations, these are all available elsewhere. So, but what changes in this one, like the patients who are actually not responding are the subject of interest. And also in terms of additional therapies, what we can do, we're just going to go through. So these are all actually mentioned, like, transcatheter mitral valve repairs. And then wireless monitoring is actually been in guidelines at least for the last 5-6 years. So this is something which has not been looked upon favorably because of complexity as well as the cost. And then the patients who are not responding to CRT, so what we have now is the conduction system pacing. And the first of this kind would have been the his bundle pacing. And then followed by now left bundle branch block area pacing, which is also available. And this is just being researched extensively, and then a lot of new trials ongoing on this one. So the first one which we can look at is the invasive hemodynamic monitoring, or these are implantable monitors. So how do they help? So if you look at a heart failure patient, so you have a hemodynamically stable patient who is asymptomatic, and then when he starts getting congested, you have autonomic adaptation in terms of what your body can deal with, and still these people might look actually asymptomatic. And then you have intrathoracic impedance changes. These are all extensively researched in terms of devices, the ICDs, CRTs, pacemakers. There are a lot of things which were giving this information. So by the time they reach this, they end up decompensating and they're requiring hospitalization. So these group of patients, the data which we have is from the pacemakers mainly. And then people came up with the devices which you can implant into the pulmonary artery like cardiomemes. And then these things can actually give information remotely, and you can pick the patients well before they get decompensated and start treating them. So this is the slide showing the data in terms of devices where they have actually started picking up the increasing impedance in terms of thoracic impedance. And then this actually will help you pick up a patient before even he needs a hospitalization. That means you can increase the diuretics in this group of patients and then avoid a hospitalization episode for this group of patients. So there are a lot of trials which have happened: COMPASS, Reduce HF, Homeostasis, Escape, Champion, and Guide HF. So I'm just going to quote one, the last one which has happened, and then you can see the clear benefit in terms of number of heart failure hospitalizations. People who have been monitored with the CardioMEMS device, they actually had a lot less hospitalization compared to a patient who is on standard therapy and clinical observations and clinic visits. Even in terms of adjusting their medication, you can see there's a huge benefit in patients who have been observed with the invasive hemodynamic monitoring. So this slide, again, it shows that you don't have to do it in a lot of patients. So you need to treat only 4 patients compared to the other therapies. This actually prevents hospitalization. Obviously, mind you, this is not mortality, hospitalization. which is very expensive in India because you might end up requiring 3 or 4 days of ICU and rest of the things. So definitely this is something which is slowly picking up. And then second thing which I was talking about, what we can do for the patients of the heart failure. So does QRS morphology determine which patients benefit from CRT? So there is an extensive study about these ones, and then people have looked at, and then we have like thousands and thousands of patients, I think nearly 17,000 randomized control trial data in this group of patients. So this one slide shows a patient who has had a CRTD compared to a patient who had just ICD. So this is group of patients with the left bundle branch block. That means before they could do the CRT, or people who have not been offered, those group of patients, if we compare, so probability of death for left bundle branch block patients, you can see a huge difference. So left bundle branch block correction obviously is going to help the patients. So non-left bundle branch block patients, no significant effect of CRT, which we know that is one of the reasons CRT is not offered to this group of patients. So how does this work? So left bundle branch block patients, first you get the sequence of activation. So the early to late activation. So it starts in the right side and then it actually starts propagating. Okay, so if you correct, so if a patient has got left bundle branch block pacing, left bundle pacing compared to a patient who's got bundle branch block, your QRS actually reduces significantly. So this is just left bundle branch pacing. And then if you compare with the RV pacing in a patient who's got heart failure, and then if you have a left bundle branch pacing, so from 164, your QRS has actually narrowed significantly to about 131. The same thing again, if you look at the biventricular pacing, so you pace both right ventricle and left ventricle same time through coronary sinus. So a QRS of close to 200 has come down to about 120. So this group of patients, they actually respond, and the mortality and morbidity both will be reduced. So why conduction system pacing? So there are patients where it is very difficult to actually get into the coronary sinus because of anatomy or because of the branch pattern. So that group of patients, this is being studied now recently for the last 3-4 years. There is a renewed interest. So you can have a large target area where you can actually put in a lead and start pacing these patients and get favorable results. So most of the data which we have now is not randomized controlled trial data. So what we have is like looking back at the other studies and then looking at the small randomized control data or meta-analysis, these sort of things actually looked at. But the important point I forgot to mention, so the physiological endpoints are the things which people have been looking at, but none of these patients, nobody looked at the clinical outcomes. That means how these patients have done. So that is one of the reasons there is a small study which is done by Wang et al. So this is a prospective pilot randomized control trial for the patients who are NYHA class 2 to 4 with non-ischemic cardiomyopathy, left ventricular ejection fraction less than 40% with the left bundle branch block. So a crossover was allowed if left bundle branch block, left bundle branch pacing or BIV is unsuccessful. So 40 consecutive patients they have looked at, and crossover was only about 10% in the left bundle branch pacing, and then 20% in the BIV pacing, which is the CRT patients. The successful left bundle branch capture, then you will see a right bundle branch block pattern. Left ventricular activation time should be less than 100 milliseconds, and it should remain short at high and low output. That means you start pacing after putting a lead, and then both at high and low pacing, it should remain short. The transition to selective left bundle, a transition to LV septal pacing is followed in this group of patients. The primary endpoint they looked at is the LVEF change over the period of 6 months, which is a short period. So this is an interesting slide. If you look at it, it's the same thing which I mentioned, those 40 patients. The treatment effect at 6 months, the change of LV ejection fraction. So look at this, there is actually major improvement in the left bundle branch pacing CRT. I will mention that in the following slide. And then just by CRT, that means the traditional CRT, left bundle branch CRT is actually given much more improvement in terms of LV ejection fraction. Not only that, if you, it's the same thing. If you look at the left ventricular end systolic volume, so the size of your left ventricle is also reduced significantly in a patient who's had left bundle branch pacing. So it's the same thing. But there are challenges for this procedure, and many people don't follow it. And this is actually not looked upon favorably because of these are the perceptions. So this is red one is the left bundle branch pacing, and then blue one is the his bundle pacing. These procedures are fairly difficult. They take long time. And if you look at the his bundle pacing, the area to capture is actually minimal, and the lead stability is the least. That means the lead falling off is a higher risk. That is one of the reasons most of the patients, they actually get an additional right ventricular lead as a backup safe pacing. So limited success rate is the most common thing. And then you look at it, high fluoroscopy time, high procedural time, lack of training, high cost because they need an additional sheath, and then lack of long-term follow-up data, and restricted guideline indications. That means actually there are soft indications at the moment in terms of level of evidence is only C. So lack of tools, complex programming, that means you need to keep on looking at the pattern while doing the procedure, which most of us don't want to do. So these are the commonest ones. The lack of long-term follow-up data, lack of randomized clinical trials is one of the reasons this has not picked up. This is actually a data of survey in the Europe done by the physicians who actually implant pacemakers. So if you look at it, if you have a patient with the AV block, preserved LV ejection fraction, so those people, they want to do it now. It is not actually done. So they actually presume this probably is a better idea. If you look at a patient with the AV block and left ventricular ejection fraction less than 40, there is a best evidence available for biventricular pacing. So still many people want to do that, but there are people now who are more favorable in terms of his bundle or left bundle branch pacing. CRT, left bundle branch pacing, is the commonest one in patients who have got heart failure. And then non-left bundle branch pacing, still, if they have a pacing indication, they still are now referred for a CRT. But ablate and pace in a patient who got preserved LV ejection fraction, this is the group of patients who have got atrial fibrillation, wherein you want to control, and then the only way you can pace them is by ablating their AV node and then give them biventricular pacing. But that group of patients now, there is more favor in terms of left bundle branch area pacing. So this is like a summary slide of looking at the current recommendations. So there, if you have a patient with the CRT indication, and if they have a left bundle branch block, then if the ejection fraction is less than 35%, biv pacing is the one which is now the current clinical guideline recommendation class 1. So those group of patients, if you fail, you can actually, this open tick is meant, this may be considered. So conduction system pacing is now actually is an acceptable mode with the expert opinion. Whereas if the ejection fraction is between 36 and 50%, biv pacing or conduction system pacing, there is a confusion. But if somebody needs a pacing, but the clinical guidelines now say CRT, but this group of patients, you can actually have a group discussion or expert opinion, and you may still consider, but it is still uncertain. If you have a non-left bundle branch block pattern and then ejection fraction is low, and if that patient needs pacing, the biv pacing is the one which is recommended, but it is not as per the guidelines as such. But this group of patients, they may end up requiring pacing, and it can induce pacing-induced cardiomyopathy. So this group of patients should be offered biv pacing, whereas conduction system pacing is still uncertain. And if you have ejection fraction between 36 and 50, again uncertain. if you have a patient who's already been paced, the Brady pacing, and then if they have a pacing-induced cardiomyopathy, you can use the BIV pacing, which is the current guidelines, but CSP is now acceptable mode of therapy. And non-responsible to BIV CRT, if somebody's already had CRT done, and if they are not responding, a CSP may be considered now as the different method. I will talk to you about that one. So previously, CRT non-response, there was no option. Now we have a CSP, whereas earlier this group of patients where you have no option, you have what is called a hot or lot CRT. Hot CRT is the one where you use the his bundle pacing along with the CRT, whereas lot CRT is the left bundle branch block area with the CRT. So these two indications are now available for all these uncertain patients, which was not available, say, 3 years ago in the guidelines. So how do you pace these patients? So these are the targets. So you have his bundle and you have left bundle branch block area. So this is 1, this is 2. So you can do a his bundle and site 1, which is just his bundle pacing. You can do a left bundle branch block area pattern. But if you want to do a CRT, so BIV CRT is sites 4 and 5. That means the conventional CRT is RV and LV. Whereas hot CRT, you can use the site 1 and site 5. So you forget this, you do the site 1 and then site 5, any of these. And then if you have a lot CRT, which is left bundle, use the left bundle as well as coronary sinus lead. So this is the modern therapy available now. So as I mentioned, still there is a lot of uncertainty. This group of patients, if you 90% of the patients, the experts agree, then that is what is going to be something which you need to look forward to in desperate situations. So how do you see what happens to these patients with the pacing? So you can look at the QRS duration in this slide. So in a patient who's got heart failure, this is the baseline, very wide QRS, left bundle pattern. So if you give a BIV pacing, obviously you become right bundle and then QRS naturally narrows, but this is still acceptable, but not great. So if you use the left bundle pacing, this seems to be even slightly narrower, but this is plain left bundle. But if you use a lot CRT, that means you put a left bundle lead as well as a CRT lead, you see a beautifully narrowed. So I mean, like you see a QRS of less than 100. So we see even 70, 80, 80 millimeters, 80 milliseconds of QRS in this group of patients. So what is the advice? Advice is still we don't have a complete consensus on this one. But if you are unable to help the patient despite CRT and this group of patients, you can consider conduction system pacing. So heart failure patients with the ejection fraction of 35% or more, there are a lot of studies being done. And then there are scant data regarding CSP in populations such as children and patients with the complex congenital heart disease or specific conditions such as genetic conditions or sarcoidosis. We don't have much information as of yet, and this is not recommended. And these are the studies which are being done. So this is for the AV blocker conventional pacing, but this is the heart failure patients. You will get all this data online. And then these are the studies. But if you look at it, the numbers in general are not encouraging because it requires more expertise. So the other things which many people can do, a general pacing, this requires extra skill. So that is one of the reasons, the smaller numbers. But you also have one of the trials with the fairly large number. So these are the studies which probably is going to show us the way in the future. Maybe over the next 4 or 5 years, we expect to see a lot more data. So to conclude, ladies and gentlemen, substantial body of evidence that supports feasibility and safety for HBP and left bundle branch area pacing, but it is not in the guideline conclusion yet. Growing body of evidence that shows QRS narrowing, improvement in LVF and functional class. So if you narrow the QRS, patient is going to improve. So that's what it means. Early cohort trials results do show impact on mortality and heart failure hospitalization, which is extremely important. awaiting randomized control trials evaluating impact on mortality and heart failure hospitalization. So, of course, we need a long-term safety data. Thank you.
It's a newly emerging idea. What's
Sorry?
your experience? Which is easier, conventional CRT or LB pacing?
Yeah.
Which is easier technically?
CRT, that means if you've been doing it for a long time, conventional CRT, you have all the kit in, and then you have multiple choices. So you can have different branches and different sub branches. So it becomes a lot more easier. His bundle, the lead stability is the major issue. So I've actually not put a lot of slides in view of time, but the lead dislodgement is about 7.9. That is 8% of patients, the lead actually dislodges and your benefit actually goes. And going back into the same place is actually almost impossible. Whereas CRT, that is one of the reasons people actually started looking at the left bundle branch area pacing. Left bundle branch area pacing is also complex because every turn you give, so either you are going to hurt more of this bundle, and then you need to look at the narrowing during actually screwing into the septum. So and you also have to look at the EGM and then the other data. So that is one of the reasons. CRT, you put it in there, you connect, you get the data. Whereas his bundle pacing and left bundle branch area pacing, it is more complex. So it is considered more difficult. And there is a learning curve as well in terms of the usage of new sheets. Whereas getting into CS is the only challenge for the CRT.
I think as we become experienced, the more data will come. But if you see how the QRS complex is so narrow, it looks that that will be order of the day when these young fellows become future cardiologists. That's why I wanted this topic to be discussed. Thank you, Krishna. We are running behind. We'll proceed further.
Great, thank you.
Thank you so much. So if you can just wait on the stage, please. I would request Mr. Krishna Rao to please felicitate Dr. Krishna. Thank you so much. So coming on to the last topic of the program. So we have with us Dr. Ramya, who would be taking us through renal denervation case selections. She is a consultant cardiologist with City Neuro Hospital. She has areas of interest being management of hypertension, heart failure, and she has also published many papers and also presented papers. Over to you.
Good afternoon, everyone. I think to see so many of you seated now, I think the credit goes to Srinivas sir to keep so many in the last session, though most of you are hungry and eager to finish it and wind up. So let's just walk through this quickly. It won't take much time. I'm Dr. Ramya and I'm presenting on renal denervation therapy. So we see such patients sometimes in OPD where we have a 52-year-old gentleman who is a hypertensive diabetic, and he came to us with headache, breathlessness, and very high blood pressures of 180 by 110 in spite of being on 3 medications, including a diuretic. So we are familiar with this term, which is called resistant hypertension. Now, the terminology has slightly been modified. We have a new guidelines, which was published this week. So where resistant hypertension is defined as blood pressure, which is above the goal despite 3 antihypertensives or on goal with 4 or more medications. So we all know very well that high BP is equivalent to more mortality, and we have to try our best to reduce the blood pressure. So we have 2 important guidelines here. One is the European Society guidelines published in 2023. And we have the 2025 guidelines, which were published in JACC. These are the ACC AHA guidelines. So we can see here in this slide that if a patient has uncontrolled blood pressure, I'm directly going to this topic because we are in the end. I don't want to prolong it too much. So we should first try triple therapy, that is combine a ACE inhibitor or ARB with a calcium channel blocker and a thiazide-like diuretic. If the patient doesn't respond, we label them as resistant hypertension and try a mineralocorticoid receptor antagonist. But there are some patients who don't respond even to this therapy, and there we come to our topic, that is a renal denervation therapy, which has now been given a class 2B recommendation. So now we can say that apart from lifestyle and drug therapy, renal denervation may be the third pillar to manage these patients who have difficult to control blood pressures. So what is the pathophysiology of this? So we know very well that hypertensive patients have high sympathetic drive and they have increase in peripheral vasoconstriction and cardiac output, which is sympathetically driven. And in the kidneys, we can see that the sympathetic nerves are just located around the wall of the renal arteries, as we can see in this picture here. And these sympathetic nerves can be targeted by putting catheters into the renal arteries and ablating it across the wall. So that is the basis of renal denervation. We are basically trying to target these sympathetic nerves around the renal arteries and reduce the total sympathetic output in the body. So the journey of renal denervation began with this catheter, which was called the Simplicity Flex catheter. Initially, there was a lot of good results, rapid decrease in blood pressure. But however, in 2014, in the Simplicity Hypertension 3 trial, there was no benefit over medical therapy. So this lost the charm and many people stopped using renal denervation. But continued research has led to re-emergence of RDN with the development of the Simplicity spiral renal denervation system. So as we can appreciate here, it's a spiral-shaped catheter and it can ablate at 4 levels simultaneously. So I like to explain this procedure by using a small video because it is always better to see rather than just hear blindly.
Introducing the Simplicity Spiral Catheter and Simplicity G3 Generator from Medtronic, the pioneer of renal denervation. Patients with uncontrolled blood pressure may have an overactive sympathetic nervous system. Renal denervation aims to suppress this elevated sympathetic drive. The Simplicity renal denervation system ablates the renal artery nerves that carry the efferent and afferent sympathetic signals, which has been proven to reduce blood pressure. The Simplicity Spiral Catheter and Simplicity G3 Generator offer an extremely efficient and simple method of performing renal denervation. The Simplicity Spiral Catheter offers exceptional deliverability and ease of use, short procedure and ablation times, and consistency of deployment in a wide range of anatomies. The Simplicity Spiral Catheter is a 6 French compatible catheter that is delivered using a rapid exchange system with a standard .014 guide wire. When the guide wire is retracted, the Simplicity Spiral Catheter naturally conforms to the patient's renal artery without occluding blood flow. It is capable of treating a wide range of arteries, as small as 3 millimeters in diameter and as large as 8 millimeters.
Different sizes of the renal arteries, anywhere from 3 to...
The Simplicity Spiral Catheter uses the same helical ablation pattern established by the proven Simplicity Flex catheter.
Not very good. But here it is a simultaneous ablation which is being done. So a better and more accurate and complete ablation is now...
The energy delivery from the Simplicity Spiral Catheter is controlled by the Simplicity G3 Generator. The generator allows the physician to monitor the...
So now we go to the trials. So these were the early trial results which were done with the flex catheters. We showed a significant drop in the office blood pressures, both at 3 months and 6 months. We also have registry data of more than 3,000 patients. This is showing the data from the Simplicity Flex, the older catheter. Still, there was significant drop in blood pressure. And then we have the spiral system, which has shown a drop in blood pressure of as much as 18 millimeters, systolic blood pressure drop at the end of 6 months. Another advantage of RDN is that it has an always-on effect. That is, irrespective of the diurnal variations of blood pressure, it helps in lowering the blood pressure levels. So this is another compiled data for the Simplicity spiral catheter. And again, we can see at the end of 1 year, there is significant drop in the office systolic blood pressure and also in the diastolic blood pressure, but more significant difference is in the systolic pressures. The only limitation with RDN is that we don't have very long-term studies. We have only published data up to 3 years, but we have small case reports where even at the end of 9 to 10 years, the persistent drop in blood pressure was maintained. Now, coming to what are the problems, what are the complications? It is a very, very safe procedure. The major complications are with the access side, that is the femoral artery puncture, groin, hematomas, etc. And studies were done whether there was any deterioration of renal function, but it showed that this system is very safe and there is no worsening of renal function in long term. Same way, they also studied whether there is any renal artery stenosis risk. Yes, there is a risk, but it is very minimal. It is about 0.2 to 0.6%. It varies depending upon the study. And so with the spiral cyst catheter, the newer catheter, almost 0% renal artery stenosis has also been reported. So this is another latest data which was published in February 25, where the long-term 3-year data after denervation, Simplicity Renal Denervation Program was published. They showed that the BP response is biphasic. That means there is a rapid fall in the first 6 months, followed by gradual steady decline, and it is sustained even at the end of 3 years. And the renal artery stenosis rate was only 0.3%. RDN was also studied in different subgroup patients, like those who are elderly with AF, diabetic, and in all the groups, there was a significant benefit. So apart from this spiral system, which uses radiofrequency energy, another catheter, which is called the Paradise Ultrasound Renal Denervation System, uses ultrasound waves to ablate in a similar manner. It also has a hydrocooling system, which circulates water around the catheter so that there will not be any heating effect. This has also been shown in trials like the Radiance studies and Radiance follow-up studies to be beneficial in lowering the systolic blood pressures, and it's a sustained up to 3 years. So coming to case selection, so going back to the ESC guidelines, so this therapy is a class 2B recommendation. It remains the same even in the latest guidelines. It should be used only in patients who have eGFR of more than 40. So this is because the trials have been included only in these patients, but now we have new ongoing trials where they're trying even in CKD patients and those on dialysis. And it is applicable for those who have BP, which is uncontrolled despite combination therapy, or patients are intolerant to drug therapy because of side effects and have a poor quality of life. And it again, the same has been mentioned even in the 2025 guidelines, that this is a therapy to be reserved for uncontrollable hypertensive patients. And remember, this is only an adjuvant therapy. This is not an alternative to drug therapy. Drugs cannot be stopped. The number of drugs will not be reduced in spite of using RDN, but it can be used as an adjunctive therapy to improve the blood pressure control. And the latest guideline also mentioned that the decision to do RDN should be a team decision with a multidisciplinary team evaluating for the adherence of drug therapy. We should look for secondary causes. We should also look for some contraindications for renal denervation before taking the decision. And the patient should be explained about what are the side effects, and informed consent should be taken. So some contraindications which should be mentioned is this therapy cannot be used if there is neurogenic orthostatic hypotension, if there is a patient who is pregnant, fibromuscular dysplasia, renal artery stented patients, or those with renal artery aneurysms or renal artery stenosis. Other than that, we can try this therapy for those who have resistant hypertension. So going back to our patient, he is a 52-year-old obese patient with diabetic and hypertension. So after informed consent, we suggested renal denervation therapy for this patient. So here we can see this is a renal angiogram demonstrating both the renal arteries. There is no evidence of stenosis or aneurysm. And here again, selective angiogram is being done. And then this is the spiral denervation catheter, which is inserted into the left renal artery. So here ablation was done in all the branches. So in renal denervation, we have to start distally and go proximally. All the branches of renal artery, including accessory renal arteries, should be ablated. So this is the RDN being done for the left renal artery. After completion of the left side, the ablation was done on the right side. So here again, renal denervation is being done for the right renal artery. At the end of the procedure, we have to do a check angio to make sure there is no damage or dissection to the renal arteries. So after this procedure, the patient showed decrease of 8 millimeters mercury pressure at the end of 3 months and is doing well without any evidence of renal artery stenosis and follow-up. So summarizing, renal denervation is a new minimally invasive intervention which has a sustained, significant long-term control in blood pressure and maintains an always-on control of blood pressures. It has a very high safety profile. It can be tried, but the patient should be selected carefully. And it is only an adjunctive therapy, not an alternative to drugs, and patient preference should be considered. So because of the initial benefit which we are seeing, renal denervation is now being tried for other conditions where the sympathetic drive is high, such as in patients with heart failure, chronic kidney disease, and arrhythmias. This is still in experimental stage. And what does the future hold? Future is with AI, artificial intelligence. Now there are studies going on where we can integrate AI for RDN to select the patients to assist in procedures. And maybe next year, sir will show us a robotic assisted RDN also. Thank you so much for your time. And thank you, Srinivas sir, for giving me this opportunity.
No, thank you, Ramya, for covering up some of the newer things happening also. I think this is already there, approved in our country, and the newer system of ultrasound-based thing is also, St. Jude is coming with that system too. So all of us, you use, some of you at least you can take it up. And the procedure technique-wise, it's not a great, technically challenging procedure, easy, but you need to identify the right patient, and patient would be able to afford it. Those are some of the things I would like to mention. As it is said that it is not a replacement, it is only other pillar. That's where we have to position it and do it accordingly. Think there's any final questions from anybody? Otherwise, we'll close because we're already behind the schedule and lunch. Some of you must be leaving. Thank you.
I couldn't hear.
What is the duration of contact? That is all preset, madam. That machine decides it, and if it's not doing it properly, it automatically disconnects itself. So there's a lot of safety protocols in the machine that you need not bother. It is preset for 30 seconds. If it's more happening more longer, or it is not touching properly, it disconnects itself. The safety aspects are well set. I think if there are no further questions, I think we will stop here. Anything? Huh?
Yeah. So thank you so much, ma'am. So I would request Mr. Krishna Rao to felicitate Dr. Ramya. Thank you so much.
Thank you. I really appreciate all of you sitting through and then giving encouragement to speakers. And finally, we have to close it. But before we close, anybody, at least as a representative to support or to encourage organizers, can you pass unbiased your opinion about your experience in this last 24 hours, starting from yesterday afternoon, today? Anything you expected? Did it program meet the expectation or not? You had learned some things, or you did not like something? Please feel free. I think one boy and one girl can talk. Otherwise, if you give opportunity to only one nowadays, they say that we have to be given equal opportunities. So anybody, please come on. We need to move on to lunch. I can pass on the mic there otherwise. Otherwise, I'll forcefully ask somebody to stand up. Before that, I think you can please, we really want to improve on. There's nothing, whatever we thought would be good for young budding people, and where some of the techniques, some of the newer things which could be useful as potential opportunities in career also we try to cover. But up to you. Any other thoughts or you had experiences? What did you feel? Any of one of you can comment before we close? No? Madam. Thank you, madam, for the encouragement. She was there last time also.
I'm extremely delighted to be a part of this meeting. And for the second year, last year also I was there. I'm very happy because they are not overlapping with each other. All the sessions are individual and discrete. And for the students, they will have a little knowledge of each of the aspects. Like any of the conference, you see the things are repeated in many of the halls and people get confused. So what I feel, different aspects of the thing are given to the particular person who is involved with that. And so that the people will have, the students particularly, they have a great interest in the subject, they will go to that line and they will have a basic knowledge of everything when they're coming to the examination. Extremely thankful to you. Dr. Srinivas, very nice arrangement also. So I'm also very happy to be a part of it. Thank you.
Thank you. Madam came forward. One student can talk, please. No? Big inertia in our country. Actually, this is a problem. But anyway, thank you all for attending. And Lupin to say final words of conclusion.
Thank you so much, sir. So now we come to the end of these 2 days of learning, and I would request Mr. Krishna Rao to please give the vote of thanks. Before we end, I would request Dr. Srinivas sir to please come on stage. Please give a loud round of applause. He was the one who has devised this program, and the background work has been happening since last many months. Thank you so much, sir, for your guidance. Over to Mr. Krishna Rao.
Thank you very much, Dr. Vivek. Good afternoon, respected doctors and my dear colleagues. I am Krishna Datta Rao. I am divisional head in Lupin's Primus team. On behalf of Team Lupin, my heartiest gratitude for respected Dr. A. Srinivas Kumar sir, who conceptualized this program, and we are happy to collaborate with TCT and CRF. And thank you very much, all you respected doctors, for sparing your valuable time, coming together, joining this meeting. I hope this meeting was worth attending. And on behalf of Lupin, I commit that we will be continuing this program every year. And thank you very much, Srinivas Kumar sir, again. And now I invite all you respected doctors for lunch. Thank you.